Hi, everyone. Welcome to the 2020 Annual Net Cancer Day Symposium. Thank you for joining us live and honoring Net Cancer Day together. I'm Lindsay, the Director of Communications, and this is...
I'm Lisa. I'm the Program Director.
Before we get started, we'd like to extend a special thank you to Rich at TVP Live for making this virtual event and production possible. You rock, Rich. Here are a few tech reminders for today's virtual symposium. For your audio, be sure the volume on your computer is turned up, and double check that the volume is unmuted on the webinar broadcast screen. Also, for the video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. And also, just as a reminder, the full webinar video will be posted on the LACNETS YouTube channel within the next few days. We would like to thank our sponsors today, specifically our gold sponsors AAA, Sun Pharma, and Ipsen, as well as our silver sponsor, Tercera Pharmaceuticals. Patient advocacy groups are an important source of net news and resources, so we encourage you to sign up for our newsletter on our website and follow us on social media. You can find us on Facebook, Instagram, Twitter, and as I mentioned earlier, YouTube. A little disclaimer, these live LACNETS webinars are done for educational purposes only and not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. If you have a question or multiple questions for today's NET experts, please go to www.slido.com and enter event code NETCancerDay. The NET experts will be doing a live Q&A following their presentations. Now I'm going to pass it off to Lisa to talk about LACNETS and introduce today's speakers. Take it away, Lisa.
Thank you, Lindsay. LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society, and our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer since we know that it is in fact a type of cancer. While you often see Lindsay and I leading the meetings and programs, we are led by a team which includes our interim administrator and board member, Kavya Velikabudi, and board member Donna Gavin, also the sister of LACNETS founder and executive director emeritus, Giovanna Joyce Mbesi. We're pleased to announce our newest board member, Mary Dunleavy, who some of you may know from our regular meetings. You may remember hearing her talk about scanxiety at our June 2020 LACNETS annual conference. Not only does Mary bring a background in medical and sales training, she also brings the patient perspective, deep empathy, and a passion for helping others. In addition to our board members, we are grateful for the counsel of our advisory board. As you may already know, LACNETS was founded in 2012 by jazz musician and composer Giovanna Joyce Mbesi, who was a NET patient herself. Giovanna was diagnosed in 2005 with metastatic small bowel neuroendocrine cancer. She then pursued her MBA for the sole intent and purpose of launching a NET patient advocacy group in Los Angeles. She lived fully with her diagnosis for 14 years until succumbing to her disease in November 2019, just over a year ago. On her last day on this side of heaven, Giovanna said to me, with great pride, that she felt her greatest legacy was founding and building LACNETS, now one of the largest NET patient advocacy groups in the country. Our NET hero left behind a legacy and a vision. Her vision was to empower NET patients and caregivers by providing a healing exchange of educational resources and emotional support so they may learn to live richly and fully. To this end, we have launched the Vision Initiative. We launched this to coincide with NET Cancer Day, not just because of the global initiative to spread awareness about NETs. It's also because NET Cancer Day was always special to Giovanna, because Giovanna's birthday is November 9th, the day before NET Cancer Day. So while we're remembering Giovanna with the 1-year anniversary of her passing, this is truly a celebration of life. Giovanna liked to say, aging is a privilege. This perspective and gratitude comes when you're affected by cancer. To the general public, many people may have heard of NETs only because of celebrities such as Steve Jobs and Aretha Franklin, who sadly passed away from the disease. Our hope is to change the narrative from associating this disease with famous people who passed away from the disease to a growing awareness of the more than 180,000 people living with the disease. And we want to support you as you learn to adapt to your new normal and help you live richly and fully despite living with the disease. So we invite you to contribute to Giovanna's vision and help continue her greatest legacy. Your gift will be matched 1-to-1 up to $50,000 if you contribute by December 31st, 2020. Large or small, every gift matters and is greatly appreciated. If you have benefited from our programs, please consider paying it forward. We invite you to share the word and spread the vision to your family, friends, and community. You hear us often say that LACNETS is a NET community. We are a collaborative community of those living with the disease, meaning patients, family and friends supporting NET patients, meaning caregivers, NET experts, sponsors, and many more. And whoever you are, whatever your relationship is to NETs, you are an important part of that community. We do this for you. You inspire us. You make this possible. And we aim to build and strengthen this community, knowing that when we come together, we are stronger together. Today is an opportunity to learn from NET experts across the country, as well as hear stories from NET patients and their families. We hope you will be encouraged, knowing that you are not alone. There are many patients, caregivers, and advocates who are living through this who understand and support you. Also, there are many experts and advocates fighting on your behalf. There is, in fact, a lot of NET research going on to try to find better treatments so that you can continue to thrive for many, many years. Our first guest today is NET patient Lori. Lori was diagnosed with NETs just over a year ago. Whether you're recently diagnosed with NETs or you've been living with NETs for many years, we all go through that initial shock and challenging first year. You'll be inspired to hear Lori's experience and what helped her during her first year. Next, NET patient oncologist Dr. Sandy Kotaya from Mercy Medical Center in Baltimore, Maryland, will be giving a presentation on NETs 101, an overview of the terminology and concepts related to NETs. Here is a fun fact about Dr. Sandy Kotaya. She is fluent in both French and Creole. Let's welcome NET patient Lori, followed by Dr. Kotaya.
Hello everyone, my name is Laurie and I would like to share a bit of my cancer journey with you. I was diagnosed with a stage 4 pancreatic NET on January 7th, 2019. That was the day that I received the phone call from my primary care physician's office stating that she'd like to see me that same day. I had been experiencing gastrointestinal issues for over a year, trying to pinpoint what the problem was, and was initially assured it was probably GERD. My age and health history didn't point to anything alarming or urgent in their eyes. Of course, now I understand why we are called zebras. When I was finally sent for an MRI, the mystery was solved. It clearly showed the pancreatic tumor and metastatic lesions on my liver. That first discussion with my primary care doctor was a blur, and honestly not clear enough. I was sent off to schedule an appointment for a liver biopsy and to see an oncologist. The consultation with the oncologist did not provide much more confidence or clarity. I came away with the understanding that neuroendocrine tumors were somehow different than regular cancerous tumors and that I should begin octreotide injections, but not much more than that. I felt as though I was walking through a fog those first few weeks. I was searching desperately for light while everything around me felt very dark and information so obscure. Even the hospital rooms where I had my biopsy and the oncology offices with their dark lighting and non-responsive receptionists, and even nurses with varying levels of confidence and competence was all very unsettling. I knew there had to be a better environment within which to embark on this journey ahead of me, and before going any further, I knew I wanted a second opinion. I didn't have a concept of a NET specialist at the time and scheduled an appointment with a doctor at another hospital whose name had come up more than once in recommendations. The experience at this new health provider was entirely different right from the start. The warm greeting by the receptionist, the calm lighting and artwork in the waiting room, the efficiency and demeanor of each person on the team before and after meeting with the physician himself was such a relief. The time he took in explaining all the details of my case and the options before me not only instilled confidence in him, but gave me a sense of my power back. I finally had some clarity, and equally important, someone who was listening to me. I was fortunate to be able to make health provider changes quickly and place my care in the hands of this new doctor and his team. My fiance Thomas and I left the office that day feeling more hopeful and more in control than we had in the past 3 weeks. There were more biopsies and scans ahead, but I did begin somatostatin analog treatment, and it would be another 2 months before I started oral chemotherapy. It was a rough start, and I felt like my life was lived between doctor's visits and whatever energy I could muster for work. But I felt supported and well cared for every step of the way, from the close circle I shared my diagnosis with, as well as my healthcare team. Still, I knew I had to be my own advocate in my healing, so I did my best to educate myself. I wanted to learn all I could about my particular cancer and began trying to sort through all the research on surviving cancer to find the most current and substantiated information that would be pertinent to me. It was all a bit overwhelming. So much seemed to not pertain to my circumstances or was simply confusing and contradictory. I wondered about the credibility of sources and at times found myself down a rabbit hole. A couple of months into chemo, I connected with the resource center a team member had told us about on our first visit, and through a nutritionist there, learned about LACNETS. On my initial visit to the website, I wanted to jump for joy. Here was all the information on my specific condition that I'd been trying to piece together, and from knowledgeable, credible sources. It would be several more months before I would attend an event, but when I did, it was such an impactful experience to be in a room with other people and caregivers living with NETs. The information shared was so clear and relevant to my circumstances. I was grateful to have found such an invaluable resource and to start making connections with this community. After an entire year on the chemo, my tumors had shrunk significantly, and my doctor and I decided it was an appropriate time to stop and give my body a break. I've been off for almost 6 months now. I feel much more like myself, and I do my best to make the most of each day while I feel so strong. When I was diagnosed last year, in those foggy early days, I asked my cancer, "What are you here to teach me?" These are a few of my takeaways. First, you must be your own advocate. I realize not everyone has the privilege of choosing from many healthcare provider options, but you must speak up, ask questions, and push for responsiveness from whomever is providing your care. Second, seek out and accept support. It can come from so many places. We often just have to be willing to ask for help or simply let others love and support us. Third, seek things that bring you joy and laughter. In dark times, it's important to keep your spirit high. And through these dark times, Thomas and I have intentionally sought out material that brings us smiles, and he has done an amazing job of keeping me laughing. It is a great antidote to stress, and this year has been particularly stressful for all of us. Finally, remember to move, and to whatever extent possible, remember to rest. Both have been so important for me for balance and healing as I've coped with all the changes this past year. I was determined from the start of this journey to find the gift in the experience. It has made me more present to my daily life, to those I love, to the purpose of my work and what I'd like to contribute to this earth. My sense of gratitude has grown exponentially, and my appreciation for life is palpable. I find so much joy each day in small moments. It's made the hard days bearable and the good days that much sweeter. Last year was the hardest year of my life, but it was also one of the most beautiful. The love and support I received, the strength I found within myself while at my weakest physically, the new relationship I had to forge with my body. the clarity of priorities and purpose, the joy and gratitude in life in the midst of fear and uncertainty. It has all taught me so much about myself and given me so much. I know I am just at the very beginning of my journey, and that there are going to be many more treatments and ups and downs ahead. We are, as Thomas continually reminds me, adjusting to our new normal. We remember that, as Viktor Frankl noted, those who have a why to live can bear almost any how. We focus each day on our why. So I thank those of you who are much further along on this journey of living with NETs. You inspire me. And for those who are newly diagnosed, I wish you strength and courage as you find your own meaning in your journey. Thank you.
Hi, everybody. My name is Dr. Sandy Kataya. I'm a medical oncologist at Mercy Medical Center in Baltimore, and I've been the director of the neuroendocrine program there for about 10 years. And today I was asked to give you guys a talk on NETS 101. I wanted to just jump right into it. When I came up with the slides for this talk, I was really thinking about my first visit with my patients and what I really want them to know about neuroendocrine tumors so that they can get as much out of that first visit as possible. So I decided to start by defining neuroendocrine tumors. To make it simple, these are tumors that are very rare. Most patients, when they have cancer of the internal lining of their organs, they develop a cancer called adenocarcinoma. So neuroendocrine tumors are not typically what we find when we biopsy the pancreas, the lung, the small bowel. But generally speaking, it tends to be better to find a neuroendocrine tumor when somebody is diagnosed. So they come from hormone-producing cells, and hormone-producing cells can be scattered in your organs, like your small bowel, and your lung, or they can be heaped up in hormone-producing glands, like your pancreas or your thyroid or your adrenal glands, which sit on top of your kidneys. So normally these cells function to make hormones, and the hormones are supposed to keep your body in balance. For example, if you think about the pancreas and you're eating a meal and you're making insulin and you're trying to store the sugar from the meal, then eventually when you stop eating, you have to stop making insulin, because if you don't, then your blood sugar is going to drop. And then if your blood sugar drops, you're going to be in trouble. So then your pancreas starts to make glucagon so you can use your sugar reserves so that you can have energy to exercise. So that's what hormones usually do, keep everything in balance. So nobody really knows why patients develop neuroendocrine tumors that are slower growing especially. We just know that over the last several years, there's been a lot more cases of neuroendocrine tumor, partly because we have better technology, partly because we think that there's something driving up the growth of, driving the incidence of neuroendocrine tumors. So when I see somebody with a pancreatic neuroendocrine tumor, I tend to think about different types of hormones that they could produce, but most of them are non-functional. But I kind of separate that in my mind from other neuroendocrine tumors, just because the treatment can be a little bit different for pancreatic neuroendocrine tumors. But under the microscope, they all look the same, okay? So there's many different ways of classifying neuroendocrine tumors, and I'm gonna go over that with all of you today. So there's lots of terminology, there's lots of confusing words. I think that there's still a lot of this name carcinoid, or this term carcinoid being thrown around, and it can confuse a lot of people, including physicians. So I thought I would spend some time talking to you guys about neuroendocrine terms. So generally speaking, carcinoid tumors are tumors that are slow growing, neuroendocrine tumors that are slow growing. And they usually start in the small bowel. You can have them in the appendix, in the lung, and in the stomach. So it can be in different areas, but they're slower growing neuroendocrine tumors. Neuroendocrine tumors, NET, is another term for tumors from hormone-producing cells that could potentially spread to other organs, but they don't necessarily need to do that, but they can. They have that potential. Neuroendocrine cancers or carcinomas refer to more aggressive neuroendocrine tumors, the ones that are faster growing, and they usually spread to other organs, and they usually can require chemotherapy to get under control. Then neuroendocrine neoplasms is just a term to capture both neuroendocrine tumors and neuroendocrine cancers or carcinomas. What's important for you guys to know? So when you're going to your first visit and you've just been diagnosed with a neuroendocrine tumor, your pathology report is very important because it will tell us a lot of information about, is your tumor growing quickly? Is your tumor growing slowly? So I ask the patients to sit down and we write everything down. Is your tumor well differentiated or poorly differentiated? Well differentiated tumors usually mean that they look more like normal hormone producing cells. Poorly differentiated tumors usually mean that they're very disorganized, and if you took the cancer and you moved it to a different place, the pathologist would not be able to tell exactly where it started. So well differentiated usually does better. Poorly differentiated usually does a little bit worse. They usually grow faster. So, and if your tumor is well differentiated, what is the growth rate of the tumor? So for that, we look at things like Ki-67 and mitotic rate, which I'm going to go over in a little bit more detail later. And then the other question I ask is your tumor producing hormones? Because cells that look more like what they originated from still can retain the ability to do what they were meant to do originally. And so, so we ask about, symptoms related to hormone production, which I'll talk to you guys about a little bit later also. The location of your primary tumor matters because we do have some different options for cancers of different origins. And then the stage of your tumor tells us what kind of treatments you need. So is surgery going to be important in your care? Is medication going to be important in your care? Is radiation going to be important in your care? So all of these things are important. So we do something called T, N, and M staging, and we do that for all cancers, not just neuroendocrine tumors. And what we're looking at is either the size or the depth of involvement in the organ it started in. Are your lymph nodes involved? And you have 600 lymph nodes. They're all over the place. They help you fight infection, so they can drain cancer from the area where it started to the area where it spreads to. And what's deceptive about neuroendocrine tumors is sometimes you can't always see the primary tumor. It's so small that it can't be easily detected on scans. And sometimes when they've done, especially in the small bowel surgeries, they found multiple tumors sitting next to each other and very, very small tumors, as opposed to the adenocarcinomas where you have a big mass where the cancer started and it spreads in a smaller mass to like other areas like the liver or the lymph nodes. So the stage of your tumor determines, what your treatment option is going to be. And we base that on your pathology and your imaging, or if you've had surgery, we base it off your surgery. So just remember that clinical staging of your tumor is not as accurate as pathologic staging. So, we can guess the sizes of things on scans, but usually when the surgeons take things out, if you're able to have surgery, then we know exactly how many lymph nodes are involved and what the size of your tumor is. And then we call that pathologic staging. So, okay, so pathology, we talked about this a little bit in the prior slide. So differentiation is how it looks under the microscope, and the pathologist tells you that. So Ki-67 is a stain that they do, and they try to see how many cells are taking up that stain at the time of your surgery or your biopsy. And they come up with a percentage. And so that percentage tells us how many cells are trying to divide at the time of the biopsy. So we'll go over what the numbers mean in a second. Mitotic rate is how many cells are dividing under the microscope at the time of the surgery. So it gives you sort of similar information, but two different ways of looking at the same type of information. And we usually do both here at Mercy, but you don't necessarily have to do both, but whichever one is the higher one is the one that we go with. Okay, so here's what the grading of the tumor. So there's differentiation and grade, right? So grade tells you a little bit more about how fast it's going to grow. Differentiation tells you in the long run how you expect it to behave. So a well-differentiated tumor, it has a Ki-67 of usually less than 3%. This is actually a little bit outdated. It should be less than 3%. And then the G2 tumors should be 3 to 20%, which are the sort of intermediate growth. And then the faster growing tumors have over 20% Ki-67, over 20 mitotic index. So the magical number for our cutoff is 20. But that being said, there's very different behavior for patients who have Ki-67 of 20 to 55% versus 55 to 100%. So even though we had this hard cutoff of 20, it doesn't necessarily mean that somebody with a Ki-67 of 25% is going to behave the same as somebody with a Ki-67 of 80%. So at the end of the day, you have to take all of this into account. Now, the WHO, the World Health Organization, added this third category for well-differentiated grade 3 neuroendocrine tumors, for mainly pancreatic neuroendocrine tumors. That's where we've seen this category of patients. And so those patients tend to behave in between the G1, G2 versus the G3. So they have a better prognosis in the poorly differentiated G3, but not as great of a prognosis as a well-differentiated G1 and G2. So, so we take that into consideration when we make treatment decisions and moving forward. Okay, so the next slide is about pathology pitfalls. And one of the things that's fascinating about neuroendocrine tumors is they're very heterogeneous, meaning that you can see somebody one day and see another person the next day, and they have the same pathology report. They're both well-differentiated tumors, or they have a low growth rate, and then you don't know exactly how fast the tumor is going to grow until you follow them. So sometimes when you get a biopsy, you're not getting the entire tumor, you're only getting a representation of the tumor. That might represent the growth rate in all the areas where the tumor is, or there might be a different growth rate in a different part of the tumor. So we keep that in mind, and we tell patients, generally speaking, if you have a well-differentiated neuroendocrine tumor and the growth rate is low, then we expect your tumor to grow slowly, but slowly could mean different things for different people. Some people, it takes years for them to grow a 0.5 centimeter, and other patients, it takes a year or two before they grow a 0.5 centimeter. So we have to kind of take all of that into consideration when we look at the pathology. The other thing is that, that there's that unique category that I talked to you guys about, which is the well-differentiated high-grade tumors, where we're trying to do some studies to include those patients to try to see what the best treatment options are. Some people, they can get treatment the way that we treat slow-growing tumors. Some people will need treatment the way we treat fast-growing tumors. And it's not always easy to know which way to go until you look at the patient, look at their liver burden, and decide whether or not you're going to go with, hormonal manipulation, which we'll talk about later in the talk, or whether you're going to try to give them oral chemotherapy. So these are all things that we look at when we look at pathology reports. So it's good guidance, but it's not everything. So I just want you guys to remember that. Okay, so what about lab testing for neuroendocrine tumors? So I know that one of the things that probably drives me the most crazy is the fact that people get very caught up in numbers. And I realize that that's important because it's data, and everybody likes to follow data. So there's no great tumor for neuroendocrine. There's no great tumor marker for neuroendocrine tumors. In the ideal world, a tumor marker is a protein that gets released into your bloodstream, and it tells you exactly how your neuroendocrine tumor is doing. Is a neuroendocrine tumor growing? Then the tumor marker is going up in your blood. Is a neuroendocrine tumor going down? Then the tumor marker is going down in your blood. And then we don't have to rely so much on scans. But the reality is that even for other cancers where we have proteins that we can measure, there's no perfect test. And certainly for neuroendocrine tumors, the chromogranin A is a very imperfect test because it's not very sensitive or specific for neuroendocrine tumors only. It can be affected by decreased kidney clearance. It can be affected by liver dysfunction, which a lot of patients with neuroendocrine tumors can have just because they have cancer in their liver. It can be affected by acid reflux medication. It can be affected by inflammation in your stomach. So, the lab can fluctuate depending on what you're taking for medication and what's going on in your body at the time. And if you go to LabCorp, which is one of the labs we have here in Maryland, versus Quest, the different labs have different assays, so their ranges of normal are different. So, you try to keep things consistent, tell the patients to get it done in the same lab each time, and try as much to control things that you can control, like if they're taking acid reflux medication, I don't necessarily stop it. I just tell them we're going to follow the trend on your acid reflux medication. Because if it's trending steadily up over time, then you might be looking at somebody who's going to have growth in their scans at some point. Does that mean that the growth in the scan is going to happen, within the next 6 months? No, it could still be a while before they have growth on their scans. So, to me, I treat the scans. I don't treat the tumor marker. The tumor marker can give me some information. I might do a scan a little bit sooner than I plan if I see a fairly quick trend, but otherwise, which is not usually the case with neuroendocrine tumors, but otherwise, it's just data for me to collect. And if it was up to me, and I know that there's some neuroendocrine experts out there in the States that just don't draw chromogranin A because people get caught up in that blood work, and it's not the most accurate thing we have. And I usually ask the patients to do fasting blood work. Now, when I'm talking about tumor markers for neuroendocrine tumors, I'm talking about the slow-growing ones. So chromogranin A is not something we draw for faster-growing neuroendocrine tumors that have growth rates over 55% especially. Okay, so what about other labs that we can do? So we tried to come up with a better tumor marker, and pancreastatin is a a fraction of the chromogranin A. It's a portion of the chromogranin A. And the assay is available. It's been available for years, but not all of us are using it consistently. And what's more attractive about this tumor marker is that it's not as easily influenced by drugs or medical conditions that you have. So sometimes if somebody has a high chromogranin A and I'm not sure what's going on, I try to draw the pancreastatin to see whether that's elevated as well. And it's a test you can order through Quest, through some of the commercial labs. Pancreatic polypeptide is a protein that gets released into the bloodstream by some neuroendocrine tumors that come from the pancreas. So if you have somebody who has a pancreatic neuroendocrine tumor, and the tumor is not producing hormones, which is like 80% of them, you can potentially draw a pancreatic polypeptide. That being said, again, I don't base my treatment based on due to the pancreatic polypeptide. I can draw the test, but I feel like blood tests create more anxiety in general than they help patients because the tests are imperfect. It's always, to me, is there growth on your scans? Is there a change in your scans? Because that's what will drive us to change treatment. Also, the other thing that will drive us to change treatment is how are your symptoms? If you have a functional tumor, you're making hormones, is your hormone production controlled? Is your quality of life as maximized as possible? So again, we're still talking about slow-growing neuroendocrine tumors because there is no tumor marker for fast-growing neuroendocrine tumors that we usually generally follow. So again, for functional tumors, so people who make hormones, it depends where your cancer originated, what hormone you're going to make. So the most infamous example of hormone production is patients who have carcinoid syndrome. Carcinoid syndrome is when you're making too much serotonin, and serotonin is a hormone that usually makes a protein called niacin. But anyway, serotonin is a hormone that can cause flushing, dry flushing of your face, and it can cause diarrhea that's so bad that it wakes you up at night. And taking Imodium and Lamodal is not going to actually help those symptoms. So, we can measure the hormone production by looking at your 24-hour urine 5-HIA, which I will talk to you guys about in a second. And then, in terms of, do you change treatment plan? Well, it depends on the person's quality of life. But what we have to understand is, although we have very good drugs now to control hormone production, they're not drugs that necessarily resolve it completely. So most people will have improvement of their symptoms, but not complete resolution. And how much it bothers them will guide us towards whether or not we need to be more intensive or try to do more to control their symptoms. Okay, so serotonin production for me is best measured by 5-HIA, which is a breakdown product of serotonin that you can measure in the urine. You can do the 24-hour urine, which most people hate. Nobody wants to do the jug for 24 hours. Everybody complains about that, and I don't blame them. I wouldn't want to do it either. So if you're really not a fan, you can do the fasting plasma 5-HIA. And it's a test that requires you to fast for about 8 hours, and you can just come in and get your blood drawn. Now, there's a special tube. It's a Z-top tube. It has to be sent frozen. So the lab has to be taught how to process it correctly. Otherwise, you're going to keep running into a wall where you have to get it redrawn. It took us some years to train our lab to draw it. But it is something that's also commercially available. And most patients who have neuroendocrine tumors that have carcinoid syndrome, because they're making too much serotonin, they have liver spread. Okay, only about 9% of the patients only have their tumor still in their small bowel or their lymph nodes. Most of them, it's when their liver starts to make the serotonin that they start to get a lot of symptoms and get into trouble with diarrhea and flushing. There's other symptoms too, but those are the two major ones. In the pancreas, again, most of them are non-functional, but you can make too much insulin. You can have too much somatostatin. You can make too much glucagon. You can make too much VIP level, hormone level. VIP can cause a lot of diarrhea and low potassium. Insulin can really drop your sugar, and patients can faint from having low sugar. Glucagon can give you diabetes and blood clots. Gastrin can be high, can cause acid reflux symptoms. So sometimes you can tell just based on the way that the patients present whether or not they're having functional tumor, and you can try to see which level you want to draw based on what they're saying. Sometimes you just draw a few of them because you're not quite sure, but you're suspicious. Stomach neuroendocrine tumors, we usually look at gastrin levels. If your gastrin level is elevated, then that helps us figure out which type of neuroendocrine tumor of the stomach you have, because there's different types. There's type 1, type 2, type 3, and type 4, which is very different than the stage. The stage is how far spread it is. The type just tells us whether or not we need to be more or less aggressive with your treatment. So colon and rectal neuroendocrine tumors are usually non-functional. So if somebody has a rectal neuroendocrine tumor, the the majority of the time there's no symptoms and they're not producing hormones. So what about imaging? So the biggest pet peeve I have with imaging is I want my patients to try to get apples to apples comparison, orange to orange comparisons. So it's very hard for the radiologists, from talking to them and reviewing scans with them, when I ask them, can you compare the gallium scan to the patient's CAT scan? No, that they're not going to do that, because it's hard for them, because they're different tests and they give you different bits of information. So CAT scans with contrast and MRI with contrast, usually we use EOVIST, are scans that measure things. How big is something, and how, like, they can measure in like 2 or 3 dimensions. MRIs are really great pictures of the liver. And sometimes we need great pictures of the liver because the surgeon wants to plan surgery, or the CAT scan is showing something, but it's not that clear. And we want to try to get a better idea what your liver burden is. So depending on which one works better for you, if the CAT scan is showing everything, you don't need to get an MRI, because most patients do not love getting MRIs because they can make you claustrophobic, you can be enclosed, but other people don't mind. But if the CAT scan is not showing things as well, then you get an MRI of the liver. So when I'm looking at, well, did your mass grow, and did it grow more than 20%? Because that's usually how we gauge change. Then I'm looking at the CAT scan and the MRI. And the pitfall that you don't want to fall into is that the person's only looking at the scan from 6 months ago. Because sometimes if you have somebody on treatment, like I've had patients on treatment for like 3-4 years with like Afinitor or everolimus, and the scan's always like stable, stable, stable. I will make the radiologist look at the scan from 2020 and look back at the scan from 2016 and really make sure that things are stable. So that's the sort of the caveats about scans that I try to think about when I'm going over imaging with patients. CAT scans and MRIs can be done for patients with fast-growing or slow-growing neuroendocrine tumors. But gallium scanning is really for patients who have slower-growing neuroendocrine tumors. So patients with Ki-67 or mitotic rates less than 20. Now, does that mean that you can't get a gallium scan on somebody who's well differentiated with a Ki-67 of 20 to 55%? No, you can certainly do that, because some of those patients will have positive gallium scans, and that might open up some treatment options for them. Now, the gallium-68 is one radiotracer that you tag to somatostatin, which is a hormone that controls the production of other hormones. And most hormone-producing cells have 1 or 2 receptors for somatostatin. Neuroendocrine tumors have over 50 receptors for somatostatin. So we use that to our advantage to treat neuroendocrine tumors and control the growth, because we've made long-acting somatostatin drugs. And we use it to try to give a treatment called PRRT, where we tag radiation to the somatostatin molecule and we inject it in the vein, and wherever there's overexpression of these receptors, where these neuroendocrine tumors are, we can release radiation directly to the tumor. So there's tracers like indium-111, which was an old tracer that we used for octreoscans, scans, but octreoscans scans were not very specific or sensitive. Sometimes people would have negative octreoscans scans, but actually have the receptors there. So we came up with a much better tracer that was approved in 2016 called gallium-68, but human beings like to improve on things and perfect things, right? So this year we had approval of copper-64, and that even gives you even crisper images. And the limitation with the copper-64 is going to be that since it's a fairly new indication, fairly new approval, that the insurance companies are probably going to struggle to get this approved initially. So we have to push them and send them data and explain to them what this test is for. Because believe it or not, when gallium-68 came out, I had to spend a lot of time sending appeals in just to get insurance companies to know what it was and what it did. And now it's like not a problem to get a gallium scan. So I think it's just a matter of educating the insurance companies, and then eventually they'll catch on. So, you know, you might see some of your physicians order a copper-64 in the future, which is fine. You know, it's just a matter of trying to find those receptors. And the other advantage of the copper-64 is that the drug tends to be stable longer. So if you miss your scan, it's not necessarily, we don't have to necessarily waste the drug. If something happened, we can still hold that tracer and give you your scan maybe a week later or a couple weeks later. Now, I do tell patients who have carcinoid syndrome, right, which are the patients who are usually small bowel neuroendocrine tumors that have metastasized to the liver, sometimes appendix, about 10% of the time lung neuroendocrine tumors, that if you have had a high level of serotonin production for many, many years before somebody finally diagnosed you, which I think hopefully is becoming a thing of the past with Dr. Google, that you should get an ultrasound of your heart, and make sure that the valves of your heart are fine. Because in the past, people used to have heart failure because they had uncontrolled serotonin that was causing scarring and damage to the right side of the heart. So we always get a baseline echocardiogram. And especially if your serotonin levels are 3 to 4 times higher than they should be. Not serotonin levels, but the 24-hour urine 5-HIAA or the plasma 5-HIAA. So that's just something for you guys to remember. Okay, so this is a neat little cartoon. I can't take credit for it. I didn't really draw this, but I stole it from somebody. And what it shows you is what I was talking to you guys about. So here are these receptors on the surface of your neuroendocrine cell. And it's only 3 of them showing here, but just imagine there's 50 of them just clustering around the cell. And so here comes somatostatin. And you can give, lanreotide, octreotide, or like we call it sandostatin or somatulin, which are long-acting forms of somatostatin. Because somatostatin usually lasts about 1 to 2 minutes in your blood. But we made a form of it that can last 28 days and is a slow, steady release of the drug. So it binds to the receptor, and when somatostatin analogs bind to the receptor, they can stabilize these neuroendocrine tumors and prevent them from growing. So you can slow down an even slower growing neuroendocrine tumor. So again, somatostatin analogs are for slow growing neuroendocrine tumors, not for fast growing neuroendocrine tumors. So what they do is they attach this radiation emitter called Lutathera to the somatostatin. Then it comes to the tumor and it binds to the receptor, and then it gets internalized by the cancer cell, and then the radiation releases inside the cancer cell. So they'll have a different cartoon later on to show you how it works. And that's how Lutathera works, or PRRT, which is a way to give targeted radiation to neuroendocrine tumors that are slower growing. Okay, and then it's also how somatostatin analogs work, by using these receptors. And that's also how gallium scan works and copper-64 scans work. We're trying to find these receptors so it can light up wherever the neuroendocrine tumors are. Now, one of the things I did not mention to you is, do we use a gallium scan to follow for progression? And that's a very controversial thing, because we really use the gallium scan for, is that person going to respond to somatostatin analog, and is that person going to respond to PRRT? Now, if I get a gallium scan on somebody and a year later new spots are showing, new spots are lighting up, do I necessarily always worry about that? Well, it depends. Is their CAT scan or their MRI showing growth in that area? Because what happens with these types of scans is that sometimes it will light up before there's actually growth there. It might be very, very early. So we don't always want to change things unless we see growth, because growth is what drives us to change therapy and something actually showing up that we can measure. So I think for the most part, I've been using the gallium scan to help guide treatment, especially for PRRT. Sometimes I use it to try to, if I'm not sure if something popped up on a CAT scan or MRI, I'm not sure if that's a neuroendocrine tumor, I will add a gallium scan or a copper-64 scan to see whether or not that's showing activity. And if it's showing activity, then I'm like, okay, that's another neuroendocrine tumor. That's sort of how I use the scans. Okay, so now what about fast-growing neuroendocrine tumors? I know I've been discriminating against them. I've just been talking about slow-growing neuroendocrine tumors. I don't want to leave out the fast-growing neuroendocrine tumors. So again, like CAT scans of the chest, abdomen, and pelvis with contrast, absolutely. FDG PET scans, so what's the difference between gallium scans and FDG PET scans? FDG PET scans is basically looking at glucose, and you're tagging sugar, glucose, with a radio tracer, and you're injecting it in the vein. And wherever there's fast-growing cancers, generally speaking, which are neuroendocrine tumors, that have Ki-67 that is over 20%, over 55% for sure, it will light up on the PET scan. We usually get that. And wherever there's the areas light up, we can stage the patients and we can see where the disease is. Now, small cell cancer of the lung can spread to the brain, has an 80% chance of spreading to the brain. So we usually get a baseline MRI of the brain. We follow after that. If it's negative, we follow after that for symptoms like headaches or dizziness to see whether we should get another one. But we do get a baseline MRI of the brain, with and without contrast. How do we decide how to treat neuroendocrine patients? So what I love about neuroendocrine tumors is not everybody who comes through the doors of my office will always get the same treatment. It has to be individualized. So every person is different. Patients can have different medical problems. They can have different liver burdens. They can have different symptoms. Some people can have bowel obstruction because they're having a small bowel neuroendocrine tumor that's, preventing them from eating. So depending on what's going on, we come up with different treatment plans for the patients. Do they usually see the same type of drugs? Usually. Do they see them in the same sequence? Not always the same sequence. It depends on the person and what's going on with them. So we would like to think as oncologists that we always give treatment based on clinical trials and data. We like to see survival data, but survival data is really hard to show for slow-growing neuroendocrine tumors, slow-growing tumors in general, because the patients live so long, you have to follow them for like sometimes decades to show that there's a survival benefit. So our marker for showing that something is working is what we look at progression-free survival. If you can show that the patient's living a longer time with the cancer not bothering them, then we base our treatments off of that. So there's been an explosion of clinical trials, an explosion of treatments in the last 10 years. I have to say that I'm very proud of the neuroendocrine community in general. There's been a big push in the last 11 years. The North American Neuroendocrine Tumor Society formed 11 years ago, and there's been a huge amount of patient support groups like LACNETS that have arisen to support NANETS as well as the patients. And for that reason, even though we were lagging far behind the Europeans in terms of treatment, because when I started the program 11 years ago, there was only somatostatin analogs. And now, like, look at all the stuff that we have. We have a lot of stuff. You guys are going to be impressed. I'm going to go over that in a little bit. But we want to know that that we can tell the patient's response rates, we can tell the patients what they should expect side effects wise and what they should expect in terms of their quality of life when we're discussing treatment options with them, risk benefits, because the patients need to be involved in decision making. We give advice, we give options, and we'll give our opinion, but at the end of the day, the patients have to decide. So in general, slow-growing tumors that don't divide that fast are really hard to shrink. Right? Because chemotherapy works great for fast-growing tumors because as it's trying to divide, it's damaging the DNA, and then the chemotherapy can kind of just put the cells to sleep. If it's an advanced cancer, sometimes it can improve the cure rate or the survival for people who have not had spread to other organs. Slow-growing tumors, we usually try to keep things stable. There are a couple of treatments that can potentially shrink the tumors down, which we'll talk about in a second. Okay, so these are for slow-growing tumors, okay? So somatostatin analogs we've discussed a few minutes ago. So that the two standard somatostatin analogs that we have are lanreotide and octreotide. There are some more somatostatin analogs than that, but right now these are the two that are approved to be used for patients with neuroendocrine tumors that are slow-growing from the pancreas to small bowel. Is it approved for lung? No, but have we used it for lung? Yes, we've used it for lung neuroendocrine tumors and have had success. And that's based on just lots of years, like decades of what we did in the past before there was any great treatment. So everolimus, Afinitor, and Sutent are pills that we can give, and the pills are supposed to block blood vessel growth of the tumor because neuroendocrine tumors have very rich blood supply. And if we can cut off the nutrients to the neuroendocrine tumors, we can stabilize the tumor. The stabilization rate of everolimus is about 80%. Okay, the shrinkage rate is about 1 to 2%. So it usually keeps things stable, doesn't usually shrink things, but this drug has been approved for all forms of slow-growing neuroendocrine tumor. Lung, pancreas, small bowel, appendix has been approved for all of them. The Sutent or sunitinib is a drug that's mainly been approved for pancreas neuroendocrine tumor. So now, are these drugs easy to take? Not always. So sometimes I have to reduce the doses because they can be quite toxic, almost as toxic as chemotherapy, but there are people who will do very well with them. Like I've said, I have some patients who've been on it for years, and it requires some dose modification, some aggressive management of symptoms, and some people are able to take it. So, that's in our armamentum. We can use these drugs, they're available, and they've been FDA approved. So what about liver-directed therapy? Liver-directed therapy is when you're trying to take advantage of the fact that these tumors have very rich blood supply and you're trying to cut off nutrition to the tumor. So you can do that in many ways. You can feed chemotherapy through the artery. We call that chemoembolization. You can feed radiation to the artery. We call that radioembolization. You can just cut off the blood supply with something bland, and we call that bland embolization. You'll actually give a chemical, just kind of reduce the blood flow to that part of the tumor. And the interventional radiologists are the ones who give that treatment. And we tend to think that it works better for small bowel neuroendocrine tumors than for pancreatic neuroendocrine tumors. But we have used it for both. And we're still trying to figure out what is the best treatment plan. Usually for radioembolization, we try to hold off giving that to patients with slow-growing neuroendocrine tumors because there's been some concerns that within a few years, patients can develop cirrhosis of their liver from damage to some normal tissue. So we only hold out for radioembolization when we think that somebody has a very aggressive tumor, faster growing tumor, and that they're not likely to see the complications from that treatment, but they're more likely to see the benefit. And of course, we have good old chemotherapy. Now, chemotherapy does not really work for appendix neuroendocrine tumor or GI neuroendocrine tumor, because these cancers don't grow fast enough to be killed off by chemotherapy. However, Dr. Strasberg, who's a good friend of mine in Moffitt, has developed this Xeloda and Temodar or capecitabine Temodar regimen, which is 2 oral chemotherapy drugs that have worked fairly well for slow-growing pancreatic and lung neuroendocrine tumors. So it's not that we haven't used chemotherapy for slow-growing neuroendocrine tumors. It's just not our preferred choice first line unless it's a pancreatic patient. The pancreatic patients can have good shrinkage, and what we call, cytoreduction is what we call kind of shrinking of the cancer. So sometimes we've done that first line for patients who have a higher liver burden to try to get some good control of the liver. So there are times when we'll use it. And of course, we've talked about PRRT, and again, what I want to point out is, for patients who are in the in-between space where you have well-differentiated tumor, but your growth rate is between 20 to 55%, then it depends how your cancer is behaving over time with your imaging, whether we're going to go more for chemotherapy options or whether we're going to go more for PRRT, especially if you have a positive gallium scan or copper-64 scan, or whether we're going to go for like Sutent or everolimus or one of the other somatostatin analogs. So these are things that we're still learning, and things are evolving over time. And the liver burden is what drives a lot of my decision making. So when I see a patient for the first time, I say to them, okay, let me take a look at your liver. And most of the time, I don't necessarily have to worry about little ditzels that they find in the bones or little areas in the lung. I don't generally have to worry about them. That's what been my experience the last 10 years. But the liver is an area where the cancer tends to thrive more. So I always look at it. I'm like, is 20% of your liver involved? Is 40% of your liver? Is 80% of your liver involved? Because that will tell me what I want to do in terms of the next step for that patient. And I always ask the surgeons for slow-growing neuroendocrine patients, do you want to do surgery on this patient? And not everybody's been on board with that. Some people think that surgery resets the clock, but most of the neuroendocrine surgeons in the US will tell you that they can reset the clock for you and push back the need for drugs. So they want to at least take a look at your liver to decide whether they can debulk or try to remove at least 70% of your tumor burden. And if you have syndrome, then it can really help control your syndrome. So these are things that we talk about in a group. So we always meet and discuss things with all the different disciplines, with the surgeons, with the medical oncologists. The radiation oncologist plays some role, not that much of a role. We have nutritionists, we have social workers, because there's always some issue with diarrhea and bowels for some of the small bowel neuroendocrine patients. So all these patients, all these pieces are very important to try to get you the best mental health and the best physical health so that you can keep going and have the best quality of life. So this is another cartoon because I'm in love with the technology for PRRT. Looking at this radiation emitter called Lutathera that's binding to the somatostatin hormone, and then that's binding to the receptor, and then it gets into your cell, and the radiation travels 1 to 2 millimeters, and it can destroy these cancer cells. Now, the thing that is sort of disappointing in a way is not everybody responds to PRRT. The response rates are about 20%, and we're trying to look at other agents, other radiation agents that we can add to make this more effective or to increase the response. But some of the patients who respond to PRRT have responded for years and have done very well, and patients have been able to stay off of drugs. So it's certainly something worth doing, especially in slow-growing neuroendocrine tumors, and it's generally very well tolerated. And it's an infusion that's about every 2 months, and you get 4 treatments. And the biggest risk used to be nausea, immediate risk, used to be nausea from an amino acid infusion that we gave to prevent kidney failure, but the formulation has changed, and patients actually do very well now in terms of nausea and vomiting. And there's some small risk of kidney failure and bone marrow toxicity, especially with platelets dropping, which we watch for during treatment, but generally speaking, it's a well-tolerated treatment. Okay, so what about fast-growing cancers? Fast-growing cancers can be tough. I think that chemotherapy tends to work very well. And the response rates are usually about 60 to 80% of people respond to chemotherapy, but it can relapse within a few months. Some people 6 months, some people 9 months, some people 12 months. There's a 5% cure rate with chemotherapy with small cell cancer of the lung, even if it's spread. So there's always going to be a small amount of patients who can get a cure from chemotherapy. But generally speaking, patients see their cancer come back. So, you can give platinum etoposide, cisplatin, carboplatin, other drugs with etoposide. Sometimes you can give zolidemdar. We've used another chemo regimen called FOLFIRINOX. I've done that a lot in conjunction with Dr. Strasberg, that I've seen some responses. And then the thing that's sort of relatively new, I think within the last year or so, for small cell lung cancer is immunotherapy. So immunotherapy is a treatment where you get your own white blood cells, your lymphocytes, which are your white cells that help you kill viruses and bacteria, to fight your cancer cells and wake up and kill them off. And immunotherapy in general has done very well across the board for lots of cancers. And I've seen some patients have complete responses where the cancer completely disappears, even with stage 4 disease, with immunotherapy, but it doesn't work for everyone. So that's a disappointing thing. But it's something that we want to try to add, and it adds some months of survival for small cell lung cancer. Some people have done better than that, but on average, it adds some months to your survival. So usually I tell the patients to look into getting chemo and immunotherapy for faster growing neuroendocrine tumors. So this is the final slide. So what I want to convey to you is your pathology report is important, your stage is important, your imaging is important, and the understanding of how your treatment works is important to me. Because if you know how your treatment works and you know what side effects to expect, then it makes sense that you're going to be able to communicate with me if something's not working well, and we're going to be able to talk about how things are going over the course of time. We want all our patients to do well. I always want everybody to have the best quality of life, because to me that's the most important thing. You don't always get to choose things that happen to you in life. You don't get to choose a lot of what happens to you in life. But if you're going to have cancer and it's going to be something that you can't cure but you have to live with, then the best thing to do is to live your life to the fullest and keep your symptoms under control as much as we can help you to do that. And, try to make sure that you don't get too caught up in labs and blood work and data points, because that will create stress and drive down your quality of life. I use laboratory studies mainly to guide my symptom management. So if somebody's telling me they have diarrhea and they're a patient who has carcinoid syndrome, and I'm not sure if the diarrhea is coming from the sandostatin or the somatrogon that I'm giving them versus carcinoid syndrome versus pancreatic insufficiency, because sometimes the somatostatin analogs can cause the pancreas not to make enough digestive enzyme. I draw the 5-HIAA. If the 5-HIAA is down and the patient's having diarrhea, then I look at the fecal fat. Is there fat in their stool? If there's fat in their stool and they're having pancreatic insufficiency, I give them Creon. If it's the lanreotide or octreotide, then it's better for me to know that, because I can always give them some Imodium or something else. So laboratories can be helpful for symptom management. I don't think they're as helpful always to tell us what's going on with the cancers. And some other people might disagree with me, but at the end of the day, sometimes when you draw a tumor marker and you see it going up, but nothing's going on the scans, sometimes you generate a lot of anxiety for people because they're anticipating the worst. And they might go a while before their imaging shows something. And so you really want to try to, the laboratory studies are going to necessarily see that your chromogranin A is elevating, and I'm going to do something about it, then that's fine. Then I'm happy to draw your chromogranin A every month or every week. But if it's just something that's a data point for me and I'm really looking at your scans to see whether there's growth, then I put that in some perspective. Like, do I really want to go chasing the chromogranin A? And I've chased many chromogranin A because people have been anxious, and most of the time it ends up being just bouncing around, fluctuating, and not doing anything. And if you get imaging, remember that you should try to get the same imaging for comparison. So if you're getting a CAT scan to follow your cancer, you should keep getting CAT scans. If you decide to switch to an MRI, then the MRI should be the way you go forward, so that you can compare apples to apples and oranges to oranges. So I'm hoping that over time we continue to have more treatment for the fast-growing patients, for the slow-growing patients. We're certainly doing a lot of research. There's a lot more awareness, and I'm very, very hopeful for the patients, and I'm very pleased with the way things have been going and the fact that I can give people so many more treatment options. So always keep some hope in your heart and try to stay positive and make sure that your quality of life is maximized as much as possible. That's my last takeaway point. And on that note, I'm going to stop.
Thank you, Lori, for sharing your story. I think many of us can relate to the anxiety and uncertainty surrounding getting the diagnosis and starting treatment. We're grateful for your insights and inspiration. We also want to thank Dr. Kotaya for her excellent NETS 101 presentation that gives us a good overview of NETS. Our next speakers are on the topic of clinical trials. As those living with or supporting those living with NETs, it's important for us to know how to interpret research articles and understand clinical trials that we might be looking into. It helps to understand how our NET experts weigh the clinical studies in making our treatment decisions. We will first hear from NET patient Mary, who shares about her own experience in a clinical trial that changed her life. Next is NET oncologist Dr. Dan Lee, co-director of the Neuroendocrine Tumor Program at City of Hope in Duarte, California. Dr. Lee leads several clinical trials on NETs, and in fact, he recently gave 2 oral presentations at the Professional Medical NET conference called NANETS, which stands for the North American NET Society. One of these presentations was on NET Vitals, which you may be familiar with because it was created by our late founder, Giovanna Invasi, along with myself and Dr. Dan Lee, with the goal of improving patient-physician communication. You can find the NET Vitals tool and a webinar to help you complete it on our website. Dr. Lee will be giving a presentation titled Clinical Trials 101 to explain research terminology and concepts. He will go over 2 examples of groundbreaking studies that are the cornerstone of our treatments with somatostatin analogs, sandostatin and lanreotide. After Dr. Lee's presentation, NET endocrinologist and oncologist Dr. Heidi Del Rivero from the National Cancer Institute, NIH, will present on NET clinical research. She will describe some of the current and ongoing NET studies that are open for enrollment. We will now hear from Mary, followed by Dr. Lee, and then Dr. Del Rivero.
I'm pleased to have the opportunity to talk to you on the topic of clinical trials, as I have spent a number of years in my cancer journey on a clinical trial. In 2005, I was diagnosed with a pancreatic NET and underwent the Whipple procedure. I had no evidence of disease for a number of years, but eventually had growth in my liver and was in need of a systemic treatment as my liver lesions were considered inoperable at this point. I was fortunate enough to be enrolled in a trial at Cedars-Sinai by my oncologist, Dr. Wolin. My husband and I had extensive discussions with my doctor about the risks and the benefits of the trial and other treatment options, and we decided this was the best choice for me. I will be honest when I say that I was very scared about this treatment due to the fact that it had not been approved for pancreatic NETs at that point. There were 2 separate arms of the trial, and my arm was sandostatin injections along with everolimus or Afinitor, which is an oral chemo. I joined the trial in 2012, and 5 years later, I received an email from my doctor with the subject line, quote, "You beat your study to submission," unquote. He went on to say, "Congratulations for being the last patient and single-handedly keeping it open several years longer than expected." The clinical trial was a success and became an accepted treatment modality for NET soon after. And I'm proud to say that 8 years after my enrollment in the trial, I'm still on the same treatment protocol and continue to live a very fulfilling and active life with stable liver metastases. Many people think of trials as a last-ditch effort, but that's absolutely not the case. The way to think of a trial is more that it can be a viable option, a treatment option at any point during your cancer journey, from very early on in your treatment, possibly after a surgical intervention, or even when you're at a decision-making point later in your diagnosis. I cannot stress enough the importance of being under the care of a NET provider if you have any interest in being enrolled in a trial. A non-specialist will not be as informed of the many trials that are available, and most importantly, the one that is right for your specific disease. The zebra aspect that we're all familiar with NET cancer makes it much more complicated to determine the best course of treatment. So having a NET specialist is critical. It's also really important to note that with a rare disease like ours, it's much more challenging for researchers to find enough patients to fill the studies. So any assistance that any of us can provide will benefit our entire community. I'm often asked, am I glad that I did it? And if what I would tell other patients about being in a trial. I can't stress how much I value being a part of my trial. Obviously, high on the list of reasons is that the treatment has been a huge success for me. I also felt that the trial was really well managed, and I felt extremely well cared for by my team. There were very tight protocols on the labs and the scanning and the distribution of medication. I had special treatment room assignments, and the list goes on. but all this made you feel like you were really well cared for. I had a study coordinator that monitored me every step of the way, which was very comforting. I'm so grateful for my clinical trial and that it has afforded me years of stable disease. And equally gratifying is that many other NET patients will benefit from the trial as well. 15 years later, I've been witness to multiple medical advancements in the NET world, thanks to other clinical trials that have occurred since my original diagnosis. This is proof that our involvement in trials has the potential to make a huge impact on expanding our treatment options and moving the field forward, which clearly benefits us as well as all of those coming after us. Thank you so much.
Great. Good morning, everyone. I'm Dan Lee. I'm a GI medical oncologist at City of Hope, and I co-direct the neuroendocrine tumor program. So today, I'm going to be discussing with you understanding clinical trial terminology, NET patient basics. And I think what I want you to get out of this presentation is really some of the key fundamental basics in terms of how we read and understand some of the clinical trial data. And I think that's absolutely vital to NET patients, because if you understand the data that you're reading, then you will have much better knowledge and insight to some of the treatments that might be coming that are able to help you. So in this presentation, I'll be going over a couple of different things. First, we'll highlight the general research process that's involved in doing clinical trials. Next, we'll highlight some of the statistical terminology that are used when you're trying to read and understand these clinical trials a little bit better. And then finally, we'll look at a lot of these clinical trials. When they're designed, they have certain types of outcomes that they're trying to address. And these are the really kind of the primary objectives of these various clinical trials, so that you have a better understanding of what those trials are trying to accomplish. All right, so we'll start with the initially with the drug development process. I think this is very important to recognize, because oftentimes it's very difficult to get an understanding of how much work it goes into in terms of a medication that ultimately gets FDA approved for neuroendocrine tumors. So initially with the drug development process, in terms of drug discovery, we usually will start with approximately 10,000 different types of compounds. And from this, only about 250 compounds ultimately make it to what's known as preclinical work. So this is usually work that involves animal testing, as well as higher primate testing, before they can be considered for human clinical trials. And out of those 250 compounds, then ultimately 5 compounds make it to actual clinical trials. And these are trials where we're testing them in humans. And then out of these, usually only 1 will ultimately be FDA approved. Now, going through this whole process, what you can see is that it takes about a little over 6.5 years from initially screening those 10,000 compounds and then ultimately leading to 1 FDA approved treatment. So there are really 4 major phases of a clinical trial. Initially, all trials will start with what's known as a phase 1 trial, which is really focused on the safety as well as trying to establish a safe dose. So usually in a phase 1 trial, you're really assessing for toxicity from the treatment. You're also looking at how the drug or medication is ultimately absorbed and distributed throughout your entire body. Initially, you're not going to necessarily find too much about whether or not the drug truly works or not, but you can sometimes get a hint of it. And the trials are getting more sophisticated over time. So sometimes after you establish initial safety, you might see what's known as a phase 1b extension trial. This is where once they develop an initial safety signal from the medication, it will then expand to a group of patients to see whether or not the drug is efficacious. But then traditionally, efficacy is really evaluated in what's known as the phase 2 clinical trial setting. This is where we already have a safety signal from the phase 1 clinical trial. And now we want to test the drug to see whether or not it actually works for the tumor type that we're treating. In addition, a phase 2 trial also helps to develop additional short-term side effects as well as safety, in addition to the initial phase 1 trial that it went through. And if a drug is found to be safe through a phase 1 trial, and that safety is confirmed in a phase 2 trial, and in the phase 2 trial is shown that the drug is efficacious, then the drug usually will then move on to what's known as a phase 3 trial. In the phase 3 trial, usually the newer drug, the experimental treatment, will then be compared to a current standard of care. So kind of an established treatment for neuroendocrine tumors. Now, sometimes you might see a phase 3 trial that's randomized to what's known as placebo, meaning that it's essentially like a sugar pill if it's an oral medication. Sometimes that's done because, let's say it's a trial that is testing a medication for neuroendocrine patients after they have gone through all the different FDA-approved treatments. So the current standard would be no additional treatment. So this is where kind of a placebo is potentially justified. But that's something to be aware of whenever you're participating in trials, because if you're not comfortable being randomized to the placebo control arm, that's something to consider. And a lot of these trials that are phase 3 that's randomized to placebo might have something that's known as crossover. This is where you might start on the control arm with placebo, but if you develop disease growth on that arm, the trial will allow you to cross over and participate in the experimental treatment moving forward. So that's something else to kind of keep in mind. And then finally, once a drug is FDA approved, there's what's known as a phase 4 trial, which is essentially a post-marketing study to obtain additional long-term safety and as well as efficacy of the medication in the real-world setting. So now that we have understood kind of the different phases of the drug development process as well as the clinical phases of a clinical trial, the next important thing to understand about clinical research, and especially when you're reading about the data from these trials, is some statistical concepts and terminology. So we'll start with what's known as mean and median. So mean is essentially the average. So oftentimes you'll see a clinical trial that presents a table of different types of patients that were included in the trial. And it might include the mean age of the patient, so the average age of the patients that participated in the trial. Usually, I would say mean is not really used these days in a lot of the reporting of clinical trials. One of the reasons for that is that oftentimes there's wide variation of the mean in the trials. So this is where the median really comes in. So the median is essentially the middle value in a set of numbers. So it's often used when 50% of patients experience an event. So you could have a table of participants where it lists that the median age of participants participating in that clinical trial might be 60 for neuroendocrine tumors. And then it might also report that the median Ki-67 proliferation index, which is a way to grade your tumor, might be, let's say, 5%. Okay, and then it might also report a outcome of the trial, such as how long patients lived in terms of survival, and then it will usually report it as a median survival, meaning that what is that middle number for how long patients lived with that treatment. In addition to mean and median, something to really understand is something that's known as the hazard ratio, or HR, and you'll see this, and I'll give you some examples. So this is what the hazard ratio refers to, is the relative risk of an event happening in one trial arm versus another. And this is really important because a lot of your key outcomes will include this hazard ratio. What you'll see is that if the hazard ratio is 1, it means that there is absolutely no difference between the treatment groups, whether it's the experimental treatment or the standard of care treatment. If the hazard ratio is 2, essentially this is a doubling of risk of the event. And usually if you're talking about survival, you don't want that hazard ratio to be above 1. That means the experimental drug is actually doing worse than the current standard of care drug. And usually you want the hazard ratio to be less than 1. So for example, if the hazard ratio is 0.5, it means that it would be half the risk. So if we take survival, for example, and you see a clinical trial that reports that the hazard ratio for overall survival of the experimental treatment to the current standard of care treatment is reported as 0.60. What this means is that there's a 40% reduction in the risk of death with the experimental treatment. So that's good. So anything less than 1 is going to favor that experimental treatment. And you would take 1 minus whatever hazard ratio is to get the percentage in terms of the percentage reduction in the risk of death. And this hazard ratio is really important because it accounts for differences in events over the entire period of clinical trials, and that's why it's used this way. Finally, one of the key things that you'll see in a lot of clinical research is something called the p-value. So this is the probability of obtaining a statistical result by chance. So this is what is usually reported in a clinical trial if it is statistically significant or not. The lower the value, the lower the p-value, the less likely that the findings from the clinical trial was a result of chance alone. And that's important. It's actually then really driven by the experimental treatment, for example. The typical threshold that we set for the p-value is 0.05, and each trial will have a different threshold for the p-value. What this means is that only 5% probability of the final result from the clinical trial actually happened by chance, so that you're most likely seeing that the events that happened in the clinical trial was actually due to the actual treatment itself and not by chance alone. As I mentioned, there's different types of p-value thresholds for different types of trials, and sometimes the p-value might be a little bit lower. So just because a p-value might be less than 0.05 for one trial, it might not be necessarily, and it might be significant for that trial. It might not necessarily be significant for another trial, because the other trial might have a lower threshold when they were designing the trial to achieve for a p-value, such as 0.025, for example, to achieve statistical significance. So in addition to the p-value, something else that you can use to see whether or not something is significant and also whether or not something is very precise is something that's known as the confidence interval. So this is oftentimes something that will also be reported. So the confidence interval is essentially the percentage of certainty a result will fall within a given range. So as we mentioned, oftentimes a hazard ratio will be reported. And if it's less than 1, it's good, meaning that the experimental treatment is potentially benefiting. So the hazard ratio will also be reported as a 95% confidence interval. And it indicates that 95% certainty that the hazard ratio will fall in a certain range. So for example, if the hazard ratio was, let's say, 0.55, and the 95% confidence interval was 0.4 to 0.7, what it means is that you have 95% certainty that this hazard ratio will fall between 0.4 to 0.7, indicating that clearly the treatment works. Now, if you have this confidence interval that's very narrow, let's say instead of 0.4 to 0.7, it's maybe 0.5 to 0.6, what that tells you is that you really have a lot of confidence in what the result is showing, and you truly know the significant benefit of the treatment, and it allows you to have better precision from those results. This is important because you clearly don't want a treatment that, let's say, has a 95% confidence interval of a hazard ratio that, let's say, ranges from 0.4 all the way up to 10, for example. So here it crosses 1, which is our threshold of equivalence in terms of potentially the experimental treatment to the other treatments, the standard of care treatment. So if you have also a large range that crosses that, you really might not know whether or not the treatment is actually working compared to the standard of care. Once you understand kind of the different phases of the trials, and you have kind of these basics in terms of statistical terminology, the final thing that you want to look for is what were the key kind of clinical trial endpoints for all of these trials. So usually the primary endpoint for many studies in oncology will be something that's known as overall survival. This is defined as the percentage of patients living at a defined period of time. This is traditionally the absolute gold standard for oncology clinical trials, and it's often reported as a 5-year survival rate. However, overall survival is very difficult for neuroendocrine tumor research. The reason why is because oftentimes for neuroendocrine tumor patients, as you know, with a more indolent disease, patients might live for a long period of time. In addition, they're going to be treated with numerous different types of treatment. They might start with somatostatin analogs, they might go to a target therapy, they might go and be treated with PRRT. So their overall survival is actually influenced by multiple treatment and not just one treatment that they get. So in this setting, it makes overall survival for neuroendocrine tumor research very difficult to achieve because someone's overall survival is not just dependent on that line of therapy that they're receiving at this one period of time, but it can be influenced by later treatments as well. How do we try to counter this in neuroendocrine tumor research? Well, what we oftentimes do is then we focus the primary endpoint to be what's known as progression-free survival. So progression-free survival just refers to the percentage of patients who continue to live with a disease that is stable or better. The reason why this is an important objective measure is that we know that when patients and their tumors start to grow, that progression is often symptomatic. And this progression-free survival endpoint is not affected by crossover, meaning that if, let's say, a patient starts on an experimental treatment and they got into the control arm, and then they crossed over to the experimental treatment, your progression-free survival did not change, right? So your progression-free survival is the time when you first developed confirmation on a scan that your disease is growing, even on the control arm. And then when you cross over to, let's say, the experimental treatment, then it resets and you try to define what was the time until you develop progression on the experimental arm. So this is a nice endpoint, and it's not also impacted by, let's say, later lines of treatment, because once you have confirmed that your disease is growing, then you know how long the current treatment was effective for you. And it's not like overall survival that's influenced by additional treatments that you may have later on. In addition to progression-free survival, another key endpoint that we look at in neuroendocrine tumor trials oftentimes is quality of life, because we not only want to know whether or not the treatment is effective, but we also want to know whether or not your quality of life is negatively impacted or whether or not it's actually helping your quality of life. And this is really can be done with various different types of questionnaires and scales. And there's different ways to look at quality of life. You can see whether or not your quality of life will improve with treatment. But oftentimes what we look at is whether or not there's a deterioration in your quality of life over time on the experimental treatment that you're on compared to the standard of care treatment, to get a sense of, potentially how negatively a new treatment might be impacting your quality of life. And that's really good to know, because we not only want the treatment to be working for you, but we also want to make sure that your quality of life is preserved as well. So let's look at some examples, since we've gone through a lot of terminology in terms of how we look at some of these clinical trials. of FDA-approved treatments for neuroendocrine tumors and began to get a sense of how we interpret some of the results and understand whether or not the treatment is effective for us. So the PROMIT study was one of the first studies for neuroendocrine tumors, and it really was what's known as a randomized study. It was a placebo-controlled, double-blind randomized study, meaning that patients were randomized to receive either octreotide long-acting injection versus a placebo injection to see whether or not there was control for tumor growth in patients with metastatic mid-gut neuroendocrine tumors, so really neuroendocrine tumors kind of throughout the small intestine. Back then, when the PROMIT study was reported, this just shows you kind of the patient demographics of the patients within the study. You'll see that there's equal number of patients essentially in each arm, as you would expect for a randomized placebo-controlled study. So there were essentially half of the patients in the octreotide long-acting injection arm, and then half the patients in the placebo arm. They will report kind of this median age in terms of what was essentially the middle age for patients that participated in the study. And that was relatively consistent with those that had a diagnosis of neuroendocrine tumor. They will then report kind of the median time to diagnosis, and then a lot of different types of tumor characteristics where they will give you the number of patients as well as percentage of patients so that you can understand what were the patients that were enrolled on this clinical trial specifically. And then all the way to the right side of this table, you'll see this p-value on the side. And for a p-value for a baseline characteristics table, what you're trying to see is that the p-value is not too low, essentially less than 0.05. The reason why is you want the arms to be balanced. So you actually want them to be not any different to each arm. So remember, the p-value just tells you whether or not something occurs by chance or not and everything. So if you have a really high p-value, what it means is that there's no significant difference between the two treatment arms, which is exactly what you want for baseline characteristics. So this is kind of the opposite of what you want for, let's say, outcomes comparing the experimental treatment to the standard treatment. You just don't want to see any differences between the patient characteristics between the two treatment groups. And this was fairly consistent in this trial. One of the ways that clinical trials will often present a key outcome, especially related to, let's say, overall survival or progression-free survival, or even quality of life, is that they might use something that's known as a Kaplan-Meier curve. What this curve tells you is essentially the proportion of study population still surviving or free of disease or hasn't necessarily progressed on the current treatment at successful times. It is really the common method to represent overall survival or progression-free survival or efficacy. And the larger difference that you see between the curves, between the experimental treatment versus the standard of care treatment or placebo treatment, it just shows you and it tells you the greater difference in the treatment arms. So this is the PROMIT trial again, and this is how the Kaplan-Meier curves are presented. So on the top of this figure, in terms of the A part of the figure, this is essentially the analysis focused on progression of the tumor between those patients that were treated with octreotide long-acting injection versus placebo. And what you see is that there's a great separation of the arms in terms of time to progression, favoring treatment with octreotide compared to placebo. So the octreotide is shown in yellow, the placebo is shown in blue. And what you also see a little bit further down in the kind of the footing of the A panel is that you see a p-value, and then you also see a hazard ratio. Again, the p-value is clearly less than 0.05, meaning that the results are statistically significant. And then what you see is that the hazard ratio is 0.34. What this means is that there's essentially a 66% reduction in the risk of progression or death if you're treated with octreotide long-acting injection versus placebo. And the data also reports this 95% confidence interval, which is also relatively narrow. So it shows you that the results are also very precise. So this is exactly what you would want for a treatment that's being tested for a patient with neuroendocrine tumor. You're seeing that the treatment is effective compared to placebo in terms of tumor control. Now, in panel B, what you'll see is the overall survival data for those patients that got treated with octreotide long-acting versus placebo. And now what you can see is that the Kaplan-Meier curve does not separate. They're essentially on top of each other, meaning that overall survival was very similar between the group that was treated with octreotide versus the group that was treated with placebo, which makes sense, right? Because many of these patients might have come off trial for placebo. They might have gotten additional somatostatin analogs further or additional other treatments, just like the experimental treatment option. So there's no difference that's detected in terms of overall survival. And as I mentioned, that's because it's influenced by additional treatment after the clinical trial was done. And that's why oftentimes for neuroendocrine tumor trials, you might not see that overall survival difference. In addition to this, there's kind of, subgroup analysis that's usually done in a clinical trial. So they'll try to see, who are patients that are included in that trial that really benefit from treatment. In this PROMIT trial, they looked at, did patients that have carcinoid syndrome or essentially functional tumors, did they benefit? Did patients that have a lot of liver burden, the percentage of liver involvement, did they benefit? Did patients that were younger versus older, did they benefit? The patients that have primary tumor resection, did they benefit or not? So what you can see here is that, again, this hazard ratio number comes on the right side of the figure, and it's good. It's all clearly under 1, and that's beneficial. And then if you look closer in terms of the 95% confidence interval, you'll see that some will have a narrow range where it's clearly under 1, but then some will potentially cross 1. So for example, liver involvement 10 to 50%, your 95% confidence interval is 0.10 to 1.67. So that's a wide range. And you don't know truly how precise the data is for someone that has significant liver involvement. Now, I will say you can't say that it doesn't work either, because it could just be that your patient size is relatively small, and as a result of that, you have this wide range. So if you look at the number of patients that had 10 to 50% liver involvement, it was only 14 patients, whereas you definitely had more patients that only had 0 to 10% liver involvement, 52 patients. That's where your hazard ratio is more narrow. So these are kind of the little nuances that you have to kind of pick up. But in general, for subgroup analysis, this is really exploratory, and you want to just get a general sense that overall the hazard ratio is benefiting for all different populations. If you see that there's one population where it's not benefiting and the hazard ratio is very high, meaning that the experimental treatment, it might not be working, and the confidence interval is very, very wide, even when you have a large number of patients, then you would be a little bit suspicious of whether or not in that subpopulation, whether or not the treatment is working compared to the overall population. Let's look at the lanreotide trial. That was also a phase 3 randomized double-blind placebo-controlled trial comparing lanreotide, which is the other somatostatin analog, versus placebo in patients with well-differentiated or moderately differentiated non-functional somatostatin receptor positive gastroenteropancreatic neuroendocrine tumor. Primary outcome of this study was progression-free survival, as we mentioned, because overall survival is very hard to demonstrate for an initial first-line trial. The Kaplan-Meier curve for progression-free survival separates very clearly on this. So it met its primary endpoint. The p-value was less than 0.001, so that's good. That means the results were significant. The hazard ratio was 0.47, meaning that there was essentially a 53% reduction in the risk of progression for those patients that were treated with lanreotide versus placebo. And you have a narrow 95% confidence interval, meaning that the results are fairly precise. So this is usually how researchers will present their data for the different subgroups that's involved in a study. There's some things to kind of keep in mind for a forest plot. The size of squares is usually proportional to the importance or the weight of the data, meaning that if there's more patients involved in a study and they are looking at these various different subgroups, if sometimes the square that's larger means that there's potentially more weight put into that subgroup, usually because of more patients. The horizontal lines essentially represent the confidence intervals that we talked about. So it's a different way, it's more of a pictorial way to represent the data. So here I show you a forest plot from the lanreotide study. Again, these are looking at kind of subgroup analysis. So you already saw the data in terms of how the treatment benefits versus placebo for all comers. But then this shows you, and it looks like looks at the subgroups in terms of breakdown. And what you will see again is that generally on this subgroup analysis forest plot, that everything favors lanreotide with a relatively narrow confidence interval. The only thing that you don't see is for those patients that have high gut tumors. So these are patients that might have tumors of the neuroendocrine tumors of the colon or the rectum, where you have a large range now in terms of your 95% confidence interval and your hazard ratio is above 1. So you can't truly say that lanreotide is necessarily favoring this population. But then what we also know is that the number of patients, again, in this group was only 14 patients. So you can't say that truly that lanreotide is also not benefiting these patients. You just have a much wider range now because you only have a small number of patients to really get that precision that you would want, which is what the 95% confidence interval is trying to tell you. In addition to the Kaplan-Meier curves as well as the forest plot, another thing that you will see as a clinical trial outcome is what's known as response to therapy. And this is essentially categorized as response rate, or are my tumors essentially shrinking or not? So response rate is really based off of a tumor size measurement. And in clinical research, we often characterize it based off of something that's known as the RECIST criteria, which is just a fancy medical term for response evaluation criteria in solid tumors. It's our criteria that we use as researchers to classify whether or not a treatment is responding to treatment or not. So what you'll see is that it's not necessarily just any tumor size shrinkage. If a patient has a complete response, meaning that essentially on a scan, they have no evidence of measurable tumors after they start treatment. A partial response means that you have had a greater than or equal to 30% reduction in the size of all measurable tumors. So usually when you start research, we'll pick certain type of tumors that we look at from the very beginning. And if there's overall a greater than or equal to 30% reduction in the size of these tumors over time on the clinical trial treatment, then we will say that you've had a partial response. Stable disease, meaning that you have not either achieved a partial response or you have not achieved what's known as progressive disease, which I will show you now. And progressive disease is really defined as greater than or equal to 20% increase in the size of the tumors. So as you can see, this is not what you traditionally will think about necessarily clinically, but this is really what you see in terms of research, because you could, let's say, have 10% growth of your tumors and still be called stable disease because you did not meet the requirement for progressive disease based off of this criteria, and you did not meet the criteria of partial response. But we know that probably your tumors are growing, and clinically, probably you are progressing, even though by research, you don't meet that. So this is something to tease out on the clinical trials. Similarly to that, if your tumors are shrinking, let's say by 10%, it's still called stable disease, even though you're probably responding to treatment because you're having some tumor shrinkage from the treatment. It just doesn't meet the threshold of what's classified as response. So when you ask your doctor what's the response rate of a particular treatment, and they tell you that the response rate is overall 10%, that doesn't mean necessarily that it's not benefiting a majority of the patients. It just means that only 10% of the patients had that greater than or equal to 30% reduction in the size of all measurable tumors to classify as a partial response. So this further clarifies this. So oftentimes you will see a report for the objective response rate, which is a percentage of patients that had a partial response or complete response with treatment. You'll also sometimes see that clinical trials will report a disease control rate, which is the sum of a complete response, partial response, or stable disease rates. And then there's also a duration response, so how long patients maintain their partial response, complete response, or stable disease until. So response is usually presented at a clinical trial with something that's known as a waterfall plot. So this reflects individual patient response rate to the treatment itself. So this is the RADIANT-3 trial that looked at a medication called everolimus for patients with advanced pancreatic neuroendocrine tumors. And this is the waterfall plot that was presented. So what you can see is that if you just compare, let's say, response rate per RECIST criteria, the objective response rate for everolimus was only 5% versus placebo. So you might, as a patient, say, oh, this is not a good treatment because there's only 5% response rate. But again, that's 5% of those patients that had 30% or more shrinkage of the tumor. For those patients that got treated with everolimus, shaded in the purple, is all those patients that had shrinkage of the tumor to some extent. They might not have met the 30% to classify as a response, but they still had shrinkage of the tumor. And if you look at the table in terms of decrease in the size of the target lesions from baseline, what you'll see is that 64.4% of the patients that received everolimus had decrease in the size of the target lesions, compared to only 20.6% of patients that were on placebo. So this is the waterfall plot for sunitinib. And as you can see, a majority of patients had shrinkage of the tumors, but only 9% of patients actually met that threshold of 30% or more to classify as an objective response rate. So those patients that had complete responses or partial responses. But again, this waterfall plot informs you much more of those patients that had, responses compared to no responses. And that's why you see that a lot of these patients are now falling into this stable disease category of 63% with a sunitinib arm. But that 63% are actually those patients that are shrinking in size of the tumors. And you say, hey, well, the placebo arm also had 60% of patients that had stable disease. Well, if you look at the waterfall plot, that's because a majority of patients, they had some growth of their tumors, but it just didn't meet the criteria for progression of disease of 20% or more growth. So they were still classified as a stable disease. So when you look at these tables, sometimes they can be misleading, and you might get more understanding of the efficacy of the treatment in terms of shrinkage of the tumors or stabilization by looking at the waterfall plot. Finally, after you understand kind of the efficacy endpoints, there's always safety or toxicity to treatment. And this is usually reported as adverse events. So adverse event is really defined as an unfavorable symptom, sign, or disease associated with use of treatment. And there's different levels of grading. A grade 1 adverse event to the experimental treatment or the standard treatment is essentially mild or no symptoms, and treatment is not indicated. So you don't do any additional treatments. A grade 2 adverse event is essentially moderate, meaning that non-invasive intervention may be indicated. So if you, for example, develop nausea or vomiting, you might want to intervene with anti-nausea medications. A grade 3 event is that it's severe, but not immediately life-threatening, but oftentimes a grade 3 event is characterized by a hospitalization or going to the emergency room. A grade 4 event is what's known as a life-threatening consequence, and urgent intervention is required. So these are patients that are definitely hospitalized and they're really sick, and sometimes they might need to be in the ICU. And a grade 5 event is that, unfortunately, the patient passed away from the treatment itself. And that's obviously very serious. So if we look at another clinical trial for neuroendocrine tumors, now the RADIANT-4 trial, which also was a phase 3 trial looking at comparing everolimus versus placebo in patients with well-differentiated non-functional neuroendocrine tumors outside the pancreas, so of the GI as well as the lung. We can really kind of look at these adverse events. So usually there will be a table in the clinical trial showing you all the different adverse events, and this will really allow you to compare the experimental treatment, in this case everolimus, versus the standard of care treatment, in this case placebo. And you can really compare the 2 treatments to see, what is the percentage of patients that develop these various different types of toxicities, whether it's fatigue, diarrhea, rash, nausea here, and it's all included here. And that's a way for you to get a sense of, potentially what are the side effects that can be encountered with this treatment, and potentially how toxic the treatment is. Usually we want to really focus on, kind of serious events like grade 3 or higher events, because obviously those are the ones that are potentially not being able to be managed outside the hospital. So kind of keep in mind and highlight that area, particularly in terms of safety. So in terms of approaching a clinical trial, I think what you need to ask your doctor is, what is the phase of the study? Is it a phase 1 study that's looking at essentially safety? Is it a phase 2 study that's already looking at efficacy and trying to detect efficacy? Is it a phase 3 study where now it's a randomized study comparing the experimental treatment to something else, and that something else could be placebo, and you need to know that? Or is it a phase 4 study, essentially a post-marketing study? So you need to join the study that you're most comfortable with. The advantages of phase 1 and phase 2 studies is oftentimes that there's no randomization, so you automatically get the experimental treatment. The disadvantage is that you have less data initially. You only have preliminary data in terms of safety and efficacy. And this is really where phase 3 comes in, where you have already that safety data and initial preliminary efficacy, but oftentimes it's a randomized study, so you have to be okay with the randomization. What is the primary endpoint of the study? So is the primary endpoint response in terms of significant proportion of patients that are getting significant tumor shrinkage? Is the primary endpoint progression-free survival, how long you can have disease control before you progress? Or is the primary endpoint overall survival? You want to get some of those details to understand what you want. Like I said, earlier phase studies will initially focus on response. And then later studies like phase 3 studies and neuroendocrine tumors will probably focus on that progression-free survival endpoint. What is the treatment and control arms? So you want to know what is the experimental treatment and how comfortable you are in terms of understanding that treatment and what preliminary data your physician might know about that treatment. And what's the control arm? Is the control arm a current standard of care, another drug, or is the control arm placebo? And you have to be comfortable with that. And along with that, does the trial have crossover, meaning that if you're randomized to the placebo arm, for example, are you able to cross over to the experimental arm? What is the patient population? So you want to look at essentially, once a trial is reported, what were the patients that were included in the trial? And if you're participating in a trial, you want to know, well, what is the patient population? Is it including all neuroendocrine tumors, including lung, pancreas, as well as GI neuroendocrine tumors? Or if you're a pancreatic neuroendocrine tumor patient, is it specifically a trial just for pancreatic neuroendocrine tumors? Because you might want to be more specific on the trial that you want to choose. How are the results presented? So once a trial releases its results, you want to see all those different presentations that I talked to you about in terms of the Kaplan-Meier curve, focusing on survival, in terms of the waterfall plots, looking at response and tumor shrinkage, and then forest plots looking at kind of subgroup analysis in terms of the patient population that was treated. And are the results significant? So you want to look at the p-value and then the 95% confidence interval to see if it's really precise, and also the hazard ratio to see if the experimental treatment really benefited, and are the results statistically significant. And what are the toxicities to treatment? So really looking at that table of adverse events to see how patients tolerated treatment and what are the common side effects that patients might have reported in clinical trial, so that when you go on that treatment, what to expect. So with that, I want to thank you for attending this session and everything, and hopefully I've been able to educate you a little bit on the basics of clinical trial terminology and how you should kind of look at clinical trial data. So when you're thinking about all these different types of treatments, you can make a wise as well as knowledgeable decision, and also a knowledgeable decision in terms of participation on clinical trials. Thank you so much.
Hi, my name is Haidira de Rivero. I am an assistant research physician at the National Cancer Institute. Today it's my pleasure to talk to you about how can we optimize neuroendocrine tumor clinical research. I know that you have been having a lot of discussions throughout the day about the different classification of neuroendocrine tumors, as well as the different anatomic distribution of neuroendocrine tumors. But this is just as a reminder of the different types of neuroendocrine tumors, which can be localized anywhere in the body. We can see here on the green circles that we can have neuroendocrine tumors in the lungs, neuroendocrine tumors in the pancreas, of the GI tract, of the small intestine. There is also a smaller cohort of patients of neuroendocrine tumors that is localized in the adrenal gland, and we're going to talk a little bit about that, since pheochromocytoma, which is a neuroendocrine tumor of the adrenal gland, is also considered an orphan disease and with not that many treatment options. And we're going to discuss what are the opportunities that we have available at the NIH. Something important to know about neuroendocrine tumors is that neuroendocrine tumors is a very important group of neoplasm that has very unique tumor biology. And at the same time, there is very challenges in terms of deciding the best treatment algorithm, especially in the advanced setting. This is just as a reminder that the neuroendocrine tumors has also increased exponentially over the last few decades. We can see the frequency as well as the incidence of neuroendocrine tumors in the pediatric population as well as in adult population. We have seen more and more patients in the pediatric population that present in my clinic with neuroendocrine tumors in different locations in the body: pancreas neuroendocrine tumors, liver. I have seen patients that have also breast neuroendocrine tumor, appendiceal neuroendocrine tumors, and we have seen an increased incidence of neuroendocrine tumors in the pediatric population. We can also see here on the graph on the left, a classification of the incidence of adult neuroendocrine tumors. And we can see here that there is an increased incidence of lung neuroendocrine tumors, as well as the small intestine neuroendocrine tumors and appendiceal neuroendocrine tumors. Neuroendocrine tumors can be classified into well-differentiated neuroendocrine tumors, as well as neuroendocrine carcinoma. Neuroendocrine carcinoma, the difference between the two of them is because neuroendocrine carcinoma is more rapidly growing, more aggressive. They can go to other places earlier compared to the well-differentiated neuroendocrine tumors that they have more indolent behavior. Something to discuss here, and I'm sure you have heard about it, is the Ki-67. Basically measures the percentage of tumor cells and is associated with tumor cell proliferation. This can also guide us to classify the neuroendocrine tumors into well-differentiated neuroendocrine tumors, as well as the more aggressive neuroendocrine carcinoma. Here in this picture, you can see the different type of neuroendocrine tumors, the grade of progression in different places, but also something that I want to mention here very briefly is that these neuroendocrine tumors, they also have a very distinct genomic presentation. However, we're still trying to understand what these markers means in terms of the behavior and in terms of treatments of neuroendocrine tumors. Throughout the years, we have some advancements in the treatment of neuroendocrine tumors. As you all know, most of you are familiar with the lanreotide or the long-acting octreotide or sandostatin, which has been very helpful in control the tumor, but as well as Dr. Dan Lin discussed, there is evidence that these treatments can also slow down the progression of the disease. We also have some other treatments that we have used for neuroendocrine tumors, such as everolimus, and also temozolomide. Now in 2017, it was approved the PRRT with Lutathera, or PET receptor radionuclide therapy with Lutathera, and we're going to discuss briefly about it. And this treatment, we know that it's efficacious for the treatment of neuroendocrine tumors. However, we're going to discuss later today that even though we know that this treatment is efficacious for neuroendocrine tumors, we still need to make this treatment more effective in shrinking the tumors as well. As we all know, some of you are very familiar with telotrestat. Another name for this is Armello. This medication blocks the serotonin production, and we know that this medication also helps for the treatment of the diarrhea. So even though throughout the years we have seen the some advancements of in the treatments of advanced neuroendocrine tumors, we still have some challenges in terms of management. We have very few FDA-approved therapies for neuroendocrine tumors, but the question here is when and what combination therapeutic approach should be used. Sometimes we know that depending of the amount of disease or how the tumor is behaving, whether it's rapidly growing or slow growing, we need to decide what will be the best treatment approach at the time of the presentation. But we still don't have standardized guidelines in the sense of when we need, what treatment we need to use and for how long the treatment needs to be continued. Another question that we have is like, what's a group of patients a particular treatment option should be used on? So we know that a lot of the treatments that has been used for neuroendocrine tumors, it focus mainly on the pancreatic neuroendocrine tumor, the small bowel neuroendocrine tumors, but how about the other sides of disease? Can we extrapolate the same information? And that's something that we need to do more research about it to understand which patient would benefit from which type of treatment. Now, neuroendocrine carcinoma, which is another neuroendocrine tumor which is more aggressive, we know that immunotherapy has a role in the treatment of neuroendocrine carcinoma. However, we still need to understand more about it to really determine which patients benefit from this treatment. However, there are other challenges that the patients face. Patients with neuroendocrine tumors as well as their families face unique challenges. And one of the reasons is because sometimes it can take long time to diagnosis and is often identifies in advanced stages. By the time the patients go to see the doctors, they already had advanced disease, the neuroendocrine tumor has spread to other places. Most medical centers has limited experience with these tumors, so patients often have to search for experts, and sometimes they have to travel outside of the home origin. So that can definitely generate a lot of anxiety and a lot of frustration going to other places where we don't know if the insurance will cover for that visit and so forth. Another frustration and challenges too is that sometimes we don't have a standardized treatment guidance, and that creates uncertainty and search for answers. And I see this all the time, that my patients can often feel isolated. And that's why, what will be a solution for this? A solution will be to develop an easily accessible national and international patient engagement network for NET research. And here, that's where organizations such as like the LACNETS, the LACNETS can play a very important role to educate patients, as well as to establish a network of research that can help patients as well as researchers. And also patient care with advocacy and support groups is very important, such as the LACNETS, LACNETS has been doing an amazing job in educate patients and inform patients with neuroendocrine tumors. Other ones will be the Neuroendocrine Tumor Research Foundations, the NORCAL. There are different neuroendocrine tumors that are around the United States that can be a support to you. And that can definitely address some of the patient needs, as we discussed above, but they can also increase the access to patients for research. But also the NET researchers also faces hurdles to develop cures, because sometimes considering these neuroendocrine tumors are considered rare type of tumors, sometimes, and with these rare tumors, it can take a long time to accrue patients in clinical trials. Sometimes multidisciplinary care, or often multidisciplinary care, are needed for patients living with neuroendocrine tumors. We need to have your nuclear medicine physician, your oncologist, your endocrinologist, your radiation oncologist. We need to all be together working as a multidisciplinary team in order to give the best treatment approach for patients living with neuroendocrine tumors. But also at the same time, neuroendocrine tumors also are associated with cancer predisposition syndromes such as von Hippel-Lindau. Von Hippel-Lindau, besides neuroendocrine tumors, they are associated with pheochromocytoma, with hemangioblastoma of the central nervous system. And you need to have a multidisciplinary team that will definitely look out for all of the clinical manifestation and give you the best care. So this is very important to have a multidisciplinary care, because this is what is needed for the care of patients living with neuroendocrine tumors. But sometimes having this approach can also form silos in terms of lack of coordination and communication between teams, and that can also limit efficiency into clinical trials. We also understand there are limited diversity in terms of neuroendocrine tumor cell lines, meaning that we don't have enough preclinical models to do drug testing to then develop more effective treatments for neuroendocrine tumors. And also, fundraising is very challenging for this rare disease. And for all rare diseases, it's very difficult to do fundraising, less sources of grant funding. And that's one of the hurdles that we as a NET researchers also experiencing as well. One of the solutions to this is to have a more collaborative, well-funded research network for neuroendocrine tumors that could also promote development of new therapies and a standard of care treatment for patient care. And this is very important. I think in regards to the treatment of neuroendocrine tumors, we definitely need to have a collaborative approach with different institutions as well with different organizations to give the best care of patients living with neuroendocrine tumors. We're working very hard for the understand more about the biology of neuroendocrine tumors. And after what I discussed to you, one of the solutions could then have a more standardized cohort of patients that we can follow over time. And for that, we had developed the natural history study of children and adults with neuroendocrine neoplasm. This is part of the natural history study for children and adults with red solid tumors. The goal of the study is that we wanted to characterize the natural history of neuroendocrine tumors. All of the data that we're collecting is demographics. Also, we're collecting clinical characteristics, patterns of disease progression, response of or lack of response to therapeutic interventions, as well as disease recurrence and overall survival, how long these patients are living with this disease. We wanted to understand more about the biology and the clinical presentations of these tumors to better give the best care. And we feel that by having this natural history study can definitely help us achieve those goals. The natural history study will allow us to study you long term. We can also look back what has been done, and we can also follow you what can be done in the future. Patients that are enrolled on this study can be enrolled remotely in the sense that patients doesn't need to come to the NIH, or they can also come to the NIH, and then we can provide different assessment in terms of other research evaluation that we wanted to do to understand more about the biology of these tumors. We also, besides the patients that we wanted to study, we also wanted to understand more about the relative, if there is any germline or cancer predisposition mutations within the family that can help us understand about neuroendocrine tumors. We are doing a very extensive clinical and laboratory evaluations because we wanted to understand if there is anything abnormal that can be found in the lab that can help us understand more about how these neuroendocrine tumors behave. We're also doing a very extensive patient-reported outcomes in terms of the psychological and social functioning, something that we all know with neuroendocrine tumors, especially patients with carcinoid that produces a high level of hormones, they have profound diarrhea, and sometimes that can be quite debilitating, losing hours of work, and it can be very also frustrating for the patient that they cannot live a normal life. We wanted to understand how that affects every aspect of the patient, from the socioeconomic levels, from the psychological levels. So we wanted to understand how we can help patients in that aspect. We're also doing a very extensive molecular profiling on the tumor tissue, blood, saliva, and stool, and we are going to do specimen repository, in the sense that if we in the future found something that is interesting that can help us understand about the biology of these tumors, we'll go back and then do more assessments on those tumors. The whole goal of doing this is that we wanted to develop new therapies. We wanted to also understand how we can make better clinical trials, maybe with less patients that can be included, that can be of benefit of patients with neuroendocrine tumors. And we also wanted to establish screening guidelines for those patients. So the way that our natural history study works is that either the patient itself or the referring physician or the referring site we refer the patient to us. If patients initially will be consented to the main natural history study for rare tumors, we're going to collect all the clinical information, pathology, imaging reports. We discuss all of the findings, doing a multidisciplinary review, and provide an opinion to the patient as well as the referring physician. We're also doing in the tumor a very extensive molecular and genetic analysis, and that information will be shared with the patient as well with the physicians. Once we decide that this patient is eligible for our study, they can either follow on this study long term. We can then enroll them on the neuroendocrine tumor sub-protocol. We have a very specific protocol to study neuroendocrine tumors for pediatrics and adults. They can also be possible enrolled on a treatment trial if available at the NIH, and those are all the possibilities of patients that are being enrolled on this natural history study. So what data we're collecting, and I have to say that has to recognize Dr. Riley and Dr. Wideman, who are the director of the Rare Tumor Initiative, for which I'm able and fortunate to collaborate and work with them. But the data that we're collecting is either for all participants that are unable to come to the NIH, that we're enrolling remotely. We're able to collect medical and family history. We're also able to collect patient-related outcomes such as pain, fatigue, depression, cognitive functioning. We also wanted to understand about the cancer characteristics by imaging, by pathology, by tumor specimen, and doing a whole exome sequence on the tumor as well. Patients that come to the clinical center, we're doing a more extensive clinical profile with very detailed history and physical examination. We may do imaging at the NIH. It's possible that we may do a biopsy if necessary to understand more about the molecular findings of the tumor. We're also doing a very extensive tumor immune profile as well as in the blood and in the tumor to understand of these patients who they may benefit from immunotherapy. By doing that, we also trying to establish cell lines and as well preclinical models when we're able to get tumors that, well, once we're able to collect that information, we should be able to then do more drug testing that can be of benefit for patients with neuroendocrine tumors. We have a wonderful genetic counseling that is very familiar with all different manifestations related to neuroendocrine tumors. And as we discussed, we have also very specific patient-related outcome. All participants that are eligible for our study, they also can be eligible for clinical trials at the clinical center. And also we can provide opinion for other studies outside of the NIH. So this is just very briefly about the type of biospecimens collection that we are collecting as part of our study. So for patients that are unable to come to the NIH, what we do is that we send a saliva kit. We're able to extract DNA. And with that DNA, we should be able to do a germline testing. And then we compare that with the tumor. So we're doing a whole exome sequence on the tumor as well as on the DNA from the saliva to understand if there is any other cancer predisposition syndromes associated with neuroendocrine tumors. We also, what we're doing for patients that come to the NIH is that we're also doing a very extensive blood collection in forms of the, to study more about the immune microenvironment related to neuroendocrine tumors. We're also collecting more of the DNA as well to do further studies in the future. So what are the objectives of this study? So the natural history study will definitely help us to establish a more formal mechanism for patient referral. Also, we can also allow us to do a systematic collection of epidemiologic data and as well to collect tumor samples to do further analysis. The whole idea of having this study is that we wanted to understand and classify patients with neuroendocrine tumors from the clinical state, from the genomic, epigenetic alterations, as well as gene expression profile that could serve to better define the biology of these neuroendocrine tumors. And the whole idea is that with this, we should be able to correlate with clinical outcomes and be able to develop effective therapies. So we also wanted to address the unmet need to also evaluate children and adults throughout the whole time of their disease course, because we wanted to understand the natural history, the clinical features, how these tumors behave over time. Do they change from more indolent to more aggressive behavior? Those are the questions that we have, and we're hoping that with this study, we should be able to answer those questions. We wanted to also allow the identification of cancer predisposition syndrome. Maybe some families are at risk to develop neuroendocrine tumors. We wanted to understand that. We wanted to do cancer screening for cancer prevention, as well to the risk reduction of neuroendocrine tumors. This is our objective of doing the studies, and this will be a longitudinal study, and we hope that we can answer all these questions by the end doing the studies. And as we discussed earlier, I think it's important to also understand the patient-related outcomes, how having this disease is affecting you from the socioeconomic level. It's the cause fatigue, the diarrhea, how does it affect you in your personal life and your work life? I think those are questions that are important to answer as well. I'm going to discuss now the current clinical trials at the National Institute of Health for Neuroendocrine Tumors. So the first one that I'm going to discuss is a study that we have for pheochromocytomas and paragangliomas. As I said earlier, pheochromocytomas and paragangliomas is also considered an orphan disease. It's very rare. It's a tumor that is localized in the adrenal gland. The adrenal glands are on top of the kidney. They have also very specific clinical profile in the sense that they're able to produce adrenaline. Catecholamines or adrenaline. So as you can imagine, when you think of adrenaline, that's what has caused your blood pressure to go high, your heart rate to go up. So there are tumors that can cause this excess of adrenaline that can be quite symptomatic from their disease. So that's a very rare disease that has also very limited treatment options as well. And another thing important to know about these tumors is that they also express somatostatin receptors. The majority of these tumors express somatostatin receptors very similarly to neuroendocrine tumors as well. So one thing that we wanted to do and understand more about finding more efficacious therapy for neuroendocrine tumors is that if we can do something that could stop the DNA repair. So as we know, and on this picture, whenever there is either a stress or any type of treatments that breaks this DNA, because the DNA, everybody has their DNA, it goes into a certain way, but whenever we give a treatment that causes a nick on that can cause damage of the DNA, there are certain enzymes. We call that the PARP enzymes. And I'm sorry that I'm getting a little bit too technical here, but the name of that PARP enzyme is also called polyribose polymerase. And basically, what it's doing is that once that happens, the cell is trying to repair itself. And that's why by using what we call these PARP inhibitors, as we can see here, there's 3 different type PARP inhibitors, such as olaparib, rucaparib, niraparib. Those are the ones that has been approved for other cancers, such as ovarian cancer, prostate cancer. But when you use one of these medications or this drug, what it is blocking that repair, and is to put in what it's doing is this action is lethal to the cell and kill the cells. So that's basically the rationale, and that's why we nowadays, in terms of finding other treatment options for different tumor types, we're trying to combine treatments with these PARP inhibitors to make the treatment more efficacious, to stop for the cells to trying to repair itself. As we can see here on this picture with the survivals, and I know Dr. Danlin explained to you very nicely about the clinical trials and to understand what is Kaplan-Meier are for, but basically this is what is telling me what is the survival of the cells, how long the cells are able to survive on this graph. And basically here what I'm trying to say is that the combination of temozolomide, who has been a drug that has been used for neuroendocrine tumors, with olaparib can definitely help the cells to survive even longer. And this is the same rationale that we're using with different tumors, but this is the rationale that we're using here for the treatment of pheochromocytomas and paragangliomas. And because of that, we now have a trial that is going to be open very soon at the NIH. That is the combination of temozolomide and olaparib versus temozolomide alone. This trial is in collaboration with Dr. Kim Perez, who she's at Dana-Farber, and we're going to include all patients that had pheochromocytomas and paragangliomas, either advanced or unresectable pheochromocytomas and paragangliomas. And what we wanted to know by using this combination, either combination or temozolomide alone, is that we wanted to know if by using this medication, does these patients live longer with their disease? Do we see, does the tumor shrink? We also wanted to understand with this combination if there is any more toxicity related to this versus the temozolomide alone. So those are the questions that we want to answer with this trial, and is going to be available very soon at the clinical center as well as other institutions within the United States. So we discussed earlier about the importance of doing a gallium scan in patients with pheochromocytomas and paragangliomas. So we also discussed, very similarly to the pancreas neuroendocrine tumors or the small bowel neuroendocrine tumors or even the lung neuroendocrine tumors, that they express somatostatin receptors. And it's the same with pheochromocytomas and paragangliomas. So we can see here and on your left side a picture of the FDG PET scan, and we can see tumors that we can see on the picture. But when we see on the gallium scan, you can see every single tumor related to pheopara. So the tumors are very well delineated. We can see how the gallium scan can pick up other tumors that were unable to be seen on the other imaging studies. So this definitely type of gallium scan has reformed the way we use diagnostics for different type of neuroendocrine tumors, and the same with pheochromocytomas and paragangliomas. So, and this is just very briefly to discuss what are the basics of theranostic. What is theranostics? I'm sure you have heard this throughout the day today for the treatment of neuroendocrine tumors, but basically theranostic is the combination of the term therapeutics, treatment, and diagnostic, how we're able to diagnose or localize the disease. The same thing with the gallium scan. So we have a diagnostic modality, which is the gallium scan, which binds the somatostatin receptor. Whenever you inject that type of radiation as a diagnostic tool, it binds to the somatostatin receptor, for which we're able to see these tumors. If they express the receptor, we're able to see it on the scan. And at the same time, we have the treatment modality that have the same rationale as well, that finds the somatostatin receptor, which is found on the surface of the tumor cell. So peptide Lutathera is a type peptide receptor radionuclide therapy, and it's a type of radiation that can be given to treat advanced disease or metastatic disease related to neuroendocrine tumors. It is approved by the FDA for the treatment of pancreas neuroendocrine tumors as well as for the GI neuroendocrine tumors. It is not approved for the lung neuroendocrine tumors. However, research is now ongoing in order to determine the benefit to get it approved so patients can get Lutathera with lung neuroendocrine tumors. But the same for pheochromocytomas and paragangliomas is not approved, but we have a study at the NIH that we wanted to understand more about what is the benefit of using Lutathera in patients with pheochromocytomas and paragangliomas. So this is a phase 2 study. So Dr. Dantlin explained to you the difference between this clinical trial and clinical trial development. We're running this study together with Dr. Franklin for nuclear medicine at the NIH. We wanted to understand is by giving this treatment, those patients live longer with this disease? Can we see can the tumor shrink by giving this disease? Can we improve the quality of life? Because as we discussed earlier, these tumors with pheochromocytomas and paragangliomas, they produce excess of adrenaline, and that causes high blood pressure, palpitations, sweating. By giving this treatment, can they improve the quality of life? So those are the questions that we have by giving this treatment. We're still accruing those patients actively, and that is available at the NIH and open to all patients. I'm sure you're familiar with this study. Throughout the day, I'm sure you have heard about about the NETHER study and the Lutathera for neuroendocrine tumors, and we know that this treatment works. This was the study that was led by Dr. Jonathan Strathford that was published in 2017. And basically, the study is showing you that there is benefit of using Lutathera in patients with neuroendocrine tumors. We see that there is benefit of patients that they can live longer with the disease, but also they stabilize the disease for longer time. So this is very important. This has reformed the way we're seeing now neuroendocrine tumors. However, something to keep in mind here is that even though we know that it works in neuroendocrine tumors and it's a very good treatment for neuroendocrine tumors, the response rate is not as high. So now the ongoing research is to make Lutathera more effective. And that's why, the answer is, how can we do that? Can we combine Lutathera with something else that make the treatment more effective? And that's the question that we have. So Lutathera, as I discussed earlier, is a type of radiation. Because it's a type of radiation, it can cause DNA damage to the cells. As I discussed earlier with another study, sometimes when there is DNA damage, the cell is going to start to repair itself with this enzyme that is called PARP enzymes. And the question is, does it make sense to give drugs such as olaparib that blocks that enzyme in order to doesn't let it repair and then cause cell death? And that's exactly the question that we have here. So we know that the type of radiation does cause breaks on the DNA, and there is a potential synergy, meaning that can be more active when you combine with the olaparib. And that's what is and that's where I want to show you here in this picture. And this are preclinical study done in neuroendocrine tumor cell lines, when we can see on the first, and if we can focus right now with the blue cells and the pink dots, as we can see the first square is the neuroendocrine tumor cells. But when we add the Lutathera, we can see that the pink dots are the DNA breaks. We can see with the Lutathera it caused some DNA break. So now the third one is only olaparib alone, or the PARP inhibitor alone, and we can see some DNA break. However, when we give it together, we can see more pink dots. So it means that there is more DNA breaks. And that's the rationale that led us to then have this trial of Lutathera in combination with olaparib. It's a first-in-human study. So that means this combination has been used in human. So we need to do a phase 1 study to determine what is the safe dose. We have a dose escalation with olaparib. The Lutathera is a standing dose. We don't do any dose reduction of the Lutathera. It's a standing dose that has been approved for all neuroendocrine tumors. And then we add olaparib and escalation dose, starting with a low dose, and then we go a little bit higher to determine what is the safety and tolerability of this combination. Once we know what is the safest dose to continue with a phase 2 study that is going to be mainly specific with neuroendocrine tumors, and is going to be a fixed dose of the Lutathera and as well as the olaparib, then we wanted to understand, is this more efficacious? Is this combination helps to shrink the tumor? If this combination helps for the tumors to get stabilized and to live longer with this disease? And that's the question that we want to answer with this study. I wanted to also mention here that it's important, something that I always do with my patients, I want to educate it about what other treatment options are out there, what clinical trials are available for patients with neuroendocrine tumors. And that's why here it's important that you're familiarize yourselves with clinicaltrials.gov, because it's important to know that there is any other treatment options besides the ones that my doctor is giving me. And as you can see here, it's important that you type the condition, in this case neuroendocrine tumors. You can also type the place where, if you want to find a place closer to you. We can also type if there is specific name drug or investigator that you want to add, and you can plug all that information into this website, so that way you can find other treatment options available for neuroendocrine tumors. And here there are only a few that I was able, when I went to the clinicaltrials.gov, there is a few here that I would like to mention. There is the cabozantinib study, Jennifer Chen at Dana-Farber leading this study. We also have the NETHER study, the Lutathera for higher grade neuroendocrine tumors. Dr. Jonathan Strathberg is leading that trial. The same with the tamoxifen for well-differentiated neuroendocrine tumors. There is a rationale that these neuroendocrine tumors, they may have a hormone receptor, estrogen receptor in the surface of the cells, and maybe that's the rationale why tamoxifen can be used in those patients. It's still in the setting of a clinical trial. We have another trial with the tripine, the same rationale with the olaparib. We wanted to make this treatment more efficacious. Dr. Aman Chauhan is the investigator on this trial. And then we have also the combination of telotristat, sort of another name for this one is Remelo, in combination with Lutathera for neuroendocrine tumors. All of these are available, and there is always an information on who to contact in order to determine if you're eligible for any of these studies. Lastly, I would like to mention in the last two slides in terms of what is the research ongoing with high-grade neuroendocrine tumors. As I discussed earlier, the neuroendocrine carcinomas are the ones that are more aggressive, more rapidly growing. Those are the ones that can metastasize earlier and go to other places, and that's why it's important that this is an unmet need, that we need to determine more effective treatments for this type of neuroendocrine tumor. At the NIH, I'm working very closely with Dr. Thomas. Dr. Thomas is the one who is developing treatment trials for small cell lung cancer, which is another type of neuroendocrine tumors. And we're trying to open a trial that is specifically for high-grade neuroendocrine carcinoma. This is a combination of two drugs. The first one is lurbinectedin. So lurbinectedin is a drug that basically damages the DNA. In combination with berzosertib, what it does is inhibit the ability of cells to divide, and it even causes more DNA damage. So, and there is already studies that show that the combination of the two can be more efficacious for the high-grade neuroendocrine carcinoma. So this is a first-in-human study because this combination has not been used before. So we're trying to determine the best dose to then move to the more phase 2 specific for neuroendocrine tumors, and that's one of the treatment trials that I'm working very closely with Dr. Thomas. And it should be open in the next month or 2 months, and it will be available for small cell as well as for high-grade neuroendocrine carcinomas. The same thing if there is a patient that has a higher grade neuroendocrine tumors or neuroendocrine carcinoma. Also, clinicaltrials.gov has other treatment options that it will be worthwhile to explore. Also, one of the other treatment options that we're working very closely is also given the combination chemotherapy with other drugs to determine if we can make this treatment more efficacious. Immunotherapy, that's another thing that we're working very closely as well to determine of the patients that understanding the tumor immune microenvironment to determine which patients may benefit from immunotherapy. But those are the treatment options that are available at clinicaltrials.gov, and all this information will be given to you, so it's available to you at any time. So lastly, I would like to recognize everybody that I'm working with. This is a teamwork. I'm not doing this by myself. I'm working with very exceptional investigators at the NIH. I have investigators that focusing on the tumor immune microenvironment. Dr. Polina is one of them. I have an investigator who's trying to understand more about the tumor biology of any extrapulmonary, more aggressive neuroendocrine tumors. I have an investigator who's only focusing on preclinical models, Dr. Kumar, and he has been quite successful in developing some of these models for neuroendocrine tumors. Dr. Lind is a nuclear medicine and oncologist who's also working on the theranostic program at the NIH. We have other investigators who has very specific interests on different type of neuroendocrine tumors, and I feel that this is the only way that we can advance the science forward, that we work as a team. And we always put all our minds together to definitely excel and advance the science. So I have to acknowledge everyone that I have worked with. This is just a few of them that I have been fortunate to work with at the clinical center from different departments at the NIH, from surgery branch to radiology department, from nuclear medicine, from endocrinology, surgery, pediatric oncology, the developmental therapeutic branch, which is my current home. I think that I have to acknowledge everyone that I've been working with, but more importantly, I have to acknowledge all of the patients, because without them, none of the studies will be possible. So I have to end with this slides. I want to honor our great friend and the founder of LACNETS. As you all remember, Giovanna Invesi, it was the heart of this organization. I was very fortunate and honored to meet her last year at the ENETS meeting. We have this cooking class, and you can see how happy she enjoyed to be with all of us. She really cared about each one of you. She really wants you to fight for this disease, to find better treatments. She did all this for you, and I have to thank her for that. There is a quote by Albert Pike that I want to say to all of you. Whatever you do for you, stay with you. Whatever you do for others, and the world will be always immortal. And she wants you to fight every day. She wants you to work together, and she wants you to find better treatments. And that's what we're here for. Without you, without her, we wouldn't be where we are, and we're grateful to you all. Again, this is a team effort. So individually, we are one drop. Together, we're an ocean, and we can do this together. Thank you all.
Thank you, Mary, Dr. Lee, and Dr. Del Rivero. We now have insight to a patient's experience on a clinical trial, a better understanding about research concepts, and we're encouraged to see some of the open clinical trials for NET patients. Thank you also, Dr. Del Rivero, for that beautiful tribute to our dear friend Giovanna. Giovanna showed me those pictures as she shared with me what a fabulous time she had at that cooking class in Barcelona. Moments like those are why we go through all the treatments and research so that we can enjoy life. So as I said earlier in the program, we have launched a Vision Initiative. It coincides with NET Cancer Day, Giovanna's birthday, and the anniversary of her passing. So we invite you to join us in carrying on Giovanna's vision. We're now going to shift from talking about disease and treatments to talking about thriving. I'm excited to introduce NET patient Cindy, who has an inspiring story of how she doesn't let metastatic grade 3 NET prevent her from living a rich and active life. Following Cindy's story, hospice and palliative medicine physician Dr. Chandana Banerjee from City of Hope will give a presentation on living with cancer during COVID-19. Let's welcome NET patient Cindy and Dr. Banerjee.
Hi everyone, I'm Cindy Poole, and please forgive my appearance. I am fishing with my family today up in the Sierras. It's a beautiful fall day, and I thought this would be the perfect backdrop for me to talk to you. Lisa Yin wanted me to let you know how I've dealt with COVID and being cooped up all the time. But my dealing with COVID really is how I deal with neuroendocrine cancer. I began walking, which led to hiking the day of my surgery. Just like many of you, I had to have a resection, and the minute I could, they had me up and walking. And I vowed to myself I'd walk a little bit further each time I got up. And I did. I just a little further, even if it was just 3 steps. I would remember where I ended, I would walk a little further that next round. Pretty soon I was walking about 3 times a day, and when I left the hospital I was walking 1.5 miles. I really, in my youth, enjoyed hiking, and this was a great way to increase my physical fitness, was walking, which then led later on to hiking. I didn't really start hiking until about 2 or 3 months after my surgery. I made sure it was okay with my doctors. Thank you, Dr. Mercy. Thank you, Dr. Gong. And I remember asking Dr. Mercy, my surgical oncologist, how far can I walk? She said, unlimited. Listen to your body, walk as much as you want. So, 8 months after surgery, I hiked the Tour de Mont Blanc, which was 110 miles around Mont Blanc in Europe. It's Europe's highest point. I went through countries France, Italy, and Switzerland. That was a bucket list. I would never have done it if it hadn't been for the support that I have at home and my girlfriend that planned the trip. But I kept going. It's the best way. Getting outside is the best way, I think, to deal with COVID. When you're out in nature, if you can find a place that doesn't have a lot of people, you don't have to worry about COVID. It's a non-problem. The problem is we have neuroendocrine cancer, and many of us have carcinoid syndrome. What do you do when you're outside and you know what? Visits or hits, or you know what I'm talking about. Well, as it happens, the hiking community online on forums, they love to talk about how to go in the woods. And I learned that it's okay to dig a hole and do what you have to do. And there's something called a backcountry bidet, where you have a bottle of water and you put this little $2 top onto the bottle, and it's your bidet. You can clean yourself in nature perfectly well and continue on and have a great time. It became a non-issue for me, where that's like the first thing most people think about that have ulcerative colitis or Crohn's or carcinoid syndrome. How am I going to go in the woods if I have a problem? It's pretty easy. It's doable. I also have a kit that I carry always in my vehicle, as most of you do. I have an extra set of clothes just in case. And I make that simple and easy to carry. It's just leggings. I have a cleanup kit and everything, so if something really bad happens, I can take care of myself. My hiking is really an important part of who I am and how I give back to the neuroendocrine family and community. So I started an Instagram at Zebra Hiking, and you can follow along on some of my adventures there. Sometimes it's a visit to the hospital, it's getting my shot, sometimes it's going to the top of a mountain. But I try to show how I live with cancer and prepare to go to the outdoors and do these long hikes. A lot of communication with my doctor is involved, a lot of communication with my dietitian is involved. But it's doable. And during times of COVID, there's nobody out on the trail. Sometimes you don't see anybody. So COVID's a non-issue, and it gets me out of the house and it helps me clear my head. And look at this view. Look at that. The fall colors are turning. That lake is spectacular. People who come and say hello, they're probably 30 feet away and they give a wave and say hi. So that's how I deal with COVID. And that's how I deal with life. Follow me on at Zebra Hiking. I would love to share my journeys with you and have them inspire you in some way. Take care.
Hello everybody, I'm Dr. Banerjee from City of Hope. I'm the Assistant Clinical Professor in Supportive Care Medicine, and today we're going to be talking about cancer and COVID-19. So let's talk a little bit about COVID-19. COVID-19 is an illness caused by a novel coronavirus that was first identified in an outbreak in Wuhan, China in December of 2019. Coronaviruses are a large family of viruses that can cause mild illnesses such as common colds to more severe diseases such as severe acute respiratory syndrome and Middle East respiratory syndrome, better known as MERS. How does this virus spread? It can spread from person to person through small droplets from noses or mouths. Droplets are produced when a person either coughs or sneezes. A person may get exposed to COVID-19 by breathing in these droplets. They may also get exposed by touching a surface that has these infected droplets and then touching their eyes, nose, or mouth. Most commonly, the virus has been known to spread through close contact within 6 feet. The virus can also spread by airborne transmission. In an enclosed space, virus particles can remain in the air for minutes to hours and can infect people at distances of more than 6 feet. Knowing this is especially important in our patient population. There's a lot of anxiety and fear associated with acquiring COVID-19, especially when you are in a situation where your immune system is suppressed. It can be an especially difficult time for those with cancer during COVID-19 on every level, whether it is psychological, social, or emotional. There can be limited access to cancer treatments. Patients might be living in an area of surge. Access to hospitals might be limited. Bed capacities can be limited. If they have procedures that are not life-saving, that are scheduled, those may be postponed due to the pandemic. The risk of infection due to a weakened immune system is an issue for most cancer patients. Fear that cancer treatments leave patients immunocompromised. That leads to patients fearing a more severe course of COVID-19 compared to the normal population. Pandemic and fear of infections can bring back memories that can lead to anxiety, stress, anticipatory grief, and also depression. If COVID-19 is giving you anxiety, there are many things you can do to ensure your health. Here are some tips from City of Hope psychiatrist Mona Mojtazadeh. First tip is to relax. If you are in acute distress, start with relaxation techniques that work for you. These could be something like breathing and progressive muscle relaxation, but also practicing mindfulness, paying attention to your surroundings. Some people can meditate. Others listen to music or take walks. Whatever gives you a break is what you should be following. Identify, write down your thoughts and emotions and actions that are prompting you to lead to anxiety. Are you exaggerating the significance of just a cold or a cough? Or is it something more serious? Take control of the emotions that you are feeling. Connect. Ask yourself, how are my current feelings of stress connected to my past traumas? Examine that relationship to help achieve a sense of control. Reach out to other people. We may be self-isolating and physically distancing, but this is no time to be alone. You need to remain socially connected to ease your anxiety and also to maintain your community of family and friends. Go easy on the news. Keep up with all the latest information, but try not to get overwhelmed. Try to help others when you can. It's also okay to ask for help. Maintain a low threshold for seeking help. The right assistance, whether it's psychological or whether it's medications, can make a big difference. The last aspect is unity. This is a pandemic that we are all facing together. And personal challenges brought on by cancer, this pandemic can also be a shared crisis. Remember that we are all in this together, and we are only safe if we all are safe. So we need to help each other through this. So what can you do to support cancer patients through COVID-19? Many cancer centers, at many of them, loved ones cannot visit people in the hospital or accompany them to their appointments. At home, individuals with cancer are especially vigilant about physical distancing from visitors. These are uncertain times that bring about a lot of anxiety, fear, and depression in those that are already diagnosed with cancer. This, as we've seen, can lead to increased isolation and loneliness for cancer patients. Maintaining a support system is extremely critical during this time. Physical distancing does not have to mean social distancing. One can still maintain social interaction with cancer patients by the following guidelines. You wear a mask. Physically distance yourself. Hand washing and use other appropriate PPE equipments. Using technology to interact with loved ones is an excellent way to keep in touch. You can use email, you can use the telephone, or you can video conference your loved ones so that they do not feel alone. If you cannot visit them, then check in with them often. Ask them if there's something you can do to help them. Some patients may not be able to leave the home, so you may be able to help them with simple errands. Arrange for virtual gatherings or happy hours to decrease isolation. If there's a birthday, celebrate it via Zoom. Let them vent to you. Sometimes you just have to sit and listen. The most important thing is that make it about them. Make them feel loved. Thank you.
Thank you, Cindy and Dr. Banerjee, for inspiring us on how to live richly and fully despite cancer and COVID-19. I first met Dr. Banerjee 1 year ago today at the 2019 Net Cancer Day Symposium at City of Hope, where she led a caregiver breakout during lunchtime. I found in Dr. Banerjee an ally with a shared passion for caregiver support. That day, a seed was planted and watered for launching a virtual NET caregiver support group as a place to address the unique needs of NET caregivers. 6 months ago, with Dr. Banerjee's guidance and leadership, LACNETS officially launched the support group for NET caregivers, and it's been amazing. We're now going to hear from NET caregiver Jack, who shares his experience of being a NET spouse. We're grateful to have Dr. Banerjee return to give the final presentation for today on caregiving. Let's welcome Jack and Dr. Banerjee.
Good morning, everyone. My name is Jack DeBlaise, husband of NET patient Beth DeBlaise, who was diagnosed with stage 4 GI NET with the primary in the ileum in March of 2016. This initial diagnosis came as a result of another painful family situation. Beth's older sister had been diagnosed and was succumbing to another rare immune system cancer that would ultimately take her life. This family history prompted Beth's primary physician to investigate, and subsequently he discovered tumors in her liver. He then referred her to the City of Hope for a biopsy. A positive NET biopsy, along with a diagnosis from a local non-specialist oncologist that was pretty grim, left me in shock, which was followed by denial. Thus begun Beth's journey against cancer. Several visits to City of Hope specialists, extensive surgery, somatostatin analog hormone therapy, affiniter-targeted therapy, as well as several imaging tests, including gallium scans. I was physically present for this part of the journey, work permitting. So here we have Beth's journey, and I'm pretty much along for the ride. Trust in modern medicine, stay the course, complete the checklist. I was just completely in denial that this type of cancer couldn't be cured. And I had this rule that I was the oldest, that I go first, no questions asked. So obviously denial had left me at that point incapable of moving forward as a caregiver. Unfortunately, after a few years, Beth confided in me that she felt like she was alone in her journey against cancer. And, I was a provider of resources, things like insurance, but I wasn't emotionally and mentally prepared to be a caregiver. And this was just unacceptable, and I needed help. Beth, as you all know, is immersed in LACNETS, so I thought, well, I should too be immersed in LACNETS. After all, there's education webinars, there's conventions, there's retreats, and more specifically to me, there's LACNETS Net Caregiver support groups, and there's also LACNETS-sponsored health coaching. So, in synopsis, I was in a phase of denial and was inadequate as a caregiver, and I went to LACNETS for guidance, and with their support, I am better equipped to fight this battle against cancer with my wife, Beth. Thank you.
Hello, everybody. I'm Chandana Banerjee, physician in the Supportive Care Medicine Department at City of Hope. Today, we're going to be talking about caregiving. It's really important for us to understand what a caregiver is. If you look at Merriam-Webster Dictionary, the definition is a caregiver is a person who provides direct care, as for children, for elderly people, or the chronically ill. I'm sure we've all been in this position or in the role of a caregiver at some point in our lives. If we haven't already, we will be someday. So what does caregiving really mean? It means different things to different people. Does it mean caring for your parents? Does it mean caring for your community? What does it mean to you? I think it's really important, if you are in a caregiving position or in this role, that you identify what the meaning of caregiving is personally to you. Cancer and caregiving can be very tricky. Caregivers managing cancer need different sets of skills. Many caregivers feel that they know what to expect when it comes to providing care and support for a loved one with cancer, but they may not actually know that. They may discover the journey along the way, and they may find that the expectations or the understanding of what it was to be a caregiver has changed over time. Learning to manage the needs of the patient while also attending to the caregiver's own evolving psychological and emotional needs can add strain, stress, and anxiety to a caregiver's life. So guess what? Sometimes the journey can be long and it can be difficult, not only for the patient, but also for the caregiver. Burnout is a huge issue in caregiving. It can affect caregivers too. We're all human. We all have our own capacities for compassion and care, particularly when helping family members who may seem to walk this journey alone. Even the best caregivers can burn out and no longer offer the best care for both themselves and their patients. So what exactly is self-care? Deliberate activity in order to take care of our mental, emotional, and physical health is what self-care is. It leads to improved moods. It reduces anxiety. It can lead to good relationships with yourself and with others. And it's something that refuels us and in our relationships allows us to be better caregivers. What it is not is something that we force ourselves to do, something that we don't enjoy doing, or something that adds stress to our day-to-day. Self-care is not selfish. Many caregivers feel that focusing on themselves and not their loved ones is a selfish act. It is important to know what we need to do in order to take care of ourselves, and it is important to know that so that we can allow ourselves to take care of others. Taking care of ourselves allows us to be in better positions to care for others. If you do not tend to yourself, you will get burnt out. If you get burnt out, you will not be in a position to care for your loved ones. So COVID-19 has impacted caregiving and your loved ones. And here are some things that we often discuss in our clinical practice. One thing I encourage is to write down 3 negative impacts of COVID-19 on you and your responsibility as a caregiver. Think of how you can remedy these 3 impacts. Think of how you can prevent these negative influences in your life. On the other side, write down 3 positive impacts that COVID-19 has had on you and your responsibility as a caregiver. Think of how you can enhance these further. Think of how you can seek similar aspects in your life. There is not one real answer or one right answer for these questions. Caregiving is a personal responsibility. As we've said before, it can mean different things to different people. So here are some ideas for self-care. Identify things that make you stressed or anxious. Identify things that make you happy. Create boundaries at work and in your personal life. Create boundaries with the people you care for. Eat healthy, sleep, exercise, and do not neglect your own medical care. Explore mindfulness techniques, connect with your loved ones, and find 30 minutes for yourself every day, be it whether just reading a book or just sitting down and reflecting on the day. That is time for yourself, for your self-care. Thank you.
Just a reminder that these webinars are done for educational purposes only and are not a substitute for medical advice. Talk to your medical team if you have any questions or concerns about your individual care or treatment. Remember that we all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. We also recognize that we are all zebras, and each person's situation is unique. A reminder also that the videos will be posted on YouTube later next week, so if you want to rewatch the videos, you can. So now we'll go to our live Q&A.
Okay. Exciting.
I know, it's gonna be fun.
I love these guys. I know Sandy for quite some time, and she's amazing. You all guys.
Oh,
You all are.
Back at you.
Yeah. So I'm excited to be with you all today.
Yes, well, welcome to our live Q&A. We're really excited to have Dr. Dan Lee, Dr. Sandy Kotaya, and Dr. Del Rivero. So Dr. Sandy Kotaya is board-certified medical oncologist and hematologist and serves as the director of the Neuroendocrine Tumor Center at Mercy Medical Center in Baltimore, Maryland. Dr. Dan Lee is assistant clinical professor in the Department of Medical Oncology and Therapeutics of Research at City of Hope, specializing in GI oncology, and is the co-director of the Neuroendocrine Tumor Program at City of Hope. He's involved in several committees, including research committees for LACNETS, the Professional Medical Net Society, and has authored several publications in peer-reviewed literature. And Dr. Jadira Heidi Del Rivero is board certified in both endocrinology and medical oncology, and she joins us from the NIH. She currently has efforts going on underway with open clinical trials that are really exciting, as we have all already heard. So welcome to the three of you. Thank you for joining us today to honor Net Cancer Day with this educational symposium. And so we'll dive right in. And the first question that we have is, how do we find current research literature, and how can we find information on current clinical trials? And I'll give that to you, Dr. Lee.
Thanks, Lisa. Yeah, so I think this question is kind of twofold in terms of how to find net literature. I would say one of the first things that, just like you do for anything that you're looking for, you can go to good old Google and kind of Google a topic that you might be interested in. But that's kind of a general broad search that you would do at first. And then once you identify that broad search and there's a specific topic that you want to look at, then usually we go to the primary literature, usually on PubMed. So I think Lisa can put up a link in terms of, how to, the web address for going to essentially PubMed. And there you can type in a specific investigator's name, or you can type in a specific article that you're looking for, or just a general topic for neuroendocrine tumors, and then you'll get a list of various different publications that has been shown. So that's how you would look at some of the research aspect of it. In terms of looking for clinical trials, clinicaltrials.gov is an excellent initial source to go to see the various different types of neuroendocrine tumor trials that are available. Usually that's a fairly long list, and clinicaltrials.gov will update periodically in terms of what are the trials that are active and that might not be inactive or have completed accrual. So it's really important to go to that website, see what potential trials are available, and then bring it back to your net provider and have that discussion, because usually your net provider will have a little bit more insight in terms of what are the key trials that are still active and ongoing, and maybe also insight in terms of what types of trials have already completed accrual.
Great, thank you. And a follow-up question to that, I guess we'll start with you, Dr. Del Rivero. I know you already addressed some of the current trials you have open, but how many current clinical trials are there for NETs? And
yes.
of those, which one or ones are you most excited about?
Thank you so much, Lisa, and thank you so much for having me here today. And that's a great question. I think it's important that we, first of all, educate our patients as well for any possible neuroendocrine tumors that is out there. But one thing that I usually recommend to our patients is to go to clinicaltrials.gov. So you can Google that, and then basically in those situations on that website, you can type always the tumor type and even which area you're from, because there are clinical trials all around the country. And I think that you can always type the region that you are closer to. You can also type the type of tumors, and then there are different trials that also appears on that clinicaltrials.gov. There are current various trials and ongoing and upcoming clinical trials, and I think Dr. Lee and Dr. Kotaya can also comment on that. But the way I like to kind of describe these different clinical trials available for neuroendocrine tumors are the ones that are for the well-differentiated neuroendocrine tumors, and there are now various clinical trials. We have the Cabozantinib study. Jennifer Chan from Dana-Farber has that study. We have the study available also for PRRT in combination with triapine. Dr. Aman Shahan is a PI on the study. I believe Dr. Lee is also a PI on his, and maybe he can comment a little bit about that. I am very excited about this trial because, as we discussed earlier on the discussions, we know that PRRT or Lutathera is effective. However, we wanted to make this therapy even more efficacious in order to shrink the tumor. And I think that's where we have these combinations, treatments with Lutathera. We have the triapine, there are other ones that are coming as well. And also UCSF has also Lutathera in combination with immunotherapy. There are also other trials for the higher grade neuroendocrine tumors, and Dr. Jennifer Eads has her trial as well in combination with chemotherapy. But I think that it's important that, and it's always something that I advise to my patients, to go to clinicaltrials.gov, look at the region that is closer, and then after that, I'll also look at the tumor type as well. I think that's important. I don't know what Dr. Lee has or Dr. Kotaya has any other thoughts about that.
Thank you. Let's go to you, Dr. Lee.
Sure. No, I absolutely agree with Dr. Del Rivero. I think it's really important to kind of break down the clinical trials based off of what kind of patients that the clinical trial is specifically trying to help. So for the well-differentiated trial or for the well-differentiated neuroendocrine tumors, I completely agree with Dr. Del Rivero. I think cabozantinib for patients with a well-differentiated neuroendocrine tumor is probably furthest along in terms of development. And, I think the Alliance Cooperative Group, after some, initial resistance, have finally understood kind of the challenges with accruing to that trial. As I mentioned in my talk, it was a randomized phase 3 trial versus placebo. And I think that wasn't relatively fair to the participants going on to the trial. So they're going to have an amendment which will allow for crossover for the placebo group to, get the experimental treatment of cabozantinib at the time of progression. And I think that would be very meaningful to patients. I think for the poorly differentiated high-grade neuroendocrine carcinomas, I think this is really an unmet need. And I think one of the very interesting trials, and we have a lot of hope for this trial, is the triplet therapy trial with cabozantinib plus nivolumab plus ipilimumab. Mm-hmm. I think a lot of us who treat this disease have already seen some initial signals with nivolumab plus ipilimumab from the SWOG DART trial and everything. And so this would really, kind of build upon that. And it's an earlier phase trial, so everyone gets the experimental treatments. So that's very beneficial for a high, very aggressive type of tumor. So I think that's a very important trial. And as Dr. Del Rivero mentioned as well, in terms of PRT, I think there's various different types of PRT trials that are looking at kind of combination treatments. We recently opened up, Dr. Chauhan's trial with, Triopan plus PRT, like Dr. Del Rivero mentioned. And then finally, I agree, paragangliomas, pheochromocytomas is oftentimes unmet need and everything. And I was, very encouraged, to see Dr. Del Rivero's trial mentioned at the Alliance Cooperative Group meeting just yesterday, where she's looking at temozolomide plus olaparib. I think the mechanism of action is very interesting in terms of the synergy of the two compounds. And we know that temozolomide does have activity for paragangliomas. It's something that we tend to use a lot and everything. So I think that trial is going to really be able to build upon what we already know and potentially really improve patient outcomes for that rare subset.
Okay. Thank you, Dr. Lin. And something that I would like to add also for our NET patients is that I think that now there are more awareness about neuroendocrine tumors, and now the different cooperative group, which is part of the National Cancer Clinical Trials Network. And that's what Dr. Lee was saying, is the Alliance, the ECOG, ICRIN, the SWOG, they're all part of the NCTN, which is the National Cancer Trials Network. And I think there is more awareness as well about these neuroendocrine tumors, and there are definitely more trials upcoming for neuroendocrine tumors. I think it's an exciting time too. I think Dr. Kotaya and Dr. Lee, you agree with me, because I think we're making more and more efforts to definitely, develop more treatment options for neuroendocrine tumors.
Yes.
Yeah, I just want to make one comment, which is that, I have clinical trials that I have been opening and open at my center as well. And, I think let's not forget that when you're looking for a clinical trial, it's because you've exhausted the standard of care, and, you have gotten what we think works and what has shown, benefit, and now it's no longer working. So you're reaching for something that is experimental, but for us, I think as neuroendocrine providers, we're kind of excited about looking at combination therapies and seeing if we can improve response rates and improve survival and capture more patients. Because even though PRT has been, I think, revolutionary to the field of cancer in general, the fact that we can do targeted radiation and use a marker specific to the cancer to find the cancer to try to target radiation to it. I mean, I know that there's other cancers that we're looking at that technology for biotheranostics, but the response rates haven't been as great as we wanted, which is why we're trying to improve on it and try to combine things. And we're trying to make sure that there's not toxicity involved, but that there's going to be more benefit than toxicity. So I think that, I wouldn't always jump to a clinical trial, especially if you're newly diagnosed patients, because there are a lot of standard treatments that you can get that can work very well for a very long period of time. But I do think that there are plenty of patients that have exhausted the standard of care and they're feeling great and they still look good. And we really want to be able to offer them more treatment options. So I think it's very exciting that we have all these trials and that we have all these investigators who are opening trials like Dr. Lee and Dr. Del Rivero.
Right. I think that.
Yeah, I think just to add on to that, I think really work with your provider. I think as what Mary highlighted in her testimonial is that this is kind of a strategy that you want to work together with your provider because there's different approaches for different patients. For some patients, they might want to see a lot more of the data before they go on a clinical trial, and therefore they might wait for a later trial once they've exhausted kind of traditional therapies. But then there are other patients who want to potentially broaden all the different lines of therapy that they might be able to have throughout their neuroendocrine tumor journey. So they might want to go on a clinical trial relatively early when there's still FDA-approved treatment that's already available that they can go on to at any time later on. So I would really say that, you have to build this kind of teamwork strategy with your provider and kind of really be able to trust each other in terms of when to, pick the timing of the trial, because clinical trials will come and go. Just because one trial is available right now doesn't necessarily mean that a trial is going to be available, let's say, 6 months or even 1 year or 2 years from now and everything. So you want to be able to take advantages of the timing of the trial as well as your overall outcomes that you're trying to achieve.
Right. That's a good point, Dan, because there are trials for newly diagnosed patients and we don't want them to necessarily pass up on them. That's a good point.
Great. I think the exciting thing for the NET patient community is that there are clinical trials, right? So that, the graph that Dr. Del Rivero you showed in your talk, there's all these treatments that have come out in the last several years and more. And also when we hear that there's more work being done, just to hear that all this stuff is going on behind the scenes is very encouraging. Right. So thank you all for that. I guess another practical question that I is not submitted, but I just wanted to ask the follow-up because this comes up in our support groups is, what about the financial aspects of it, right? Especially if someone's HMO, can they qualify for a clinical trial? And how do they go about doing that? And Dr. Del Rivero, we'll start with you.
I will, if it is okay, I would like to pass on in Dr. Lee and Dr. Kataya, since I am in a research institution, so I don't necessarily exposure with insurance companies. So that's why, if it is okay with Dr. Lee and Dr. Kataya, and I can always chime in.
Sure, absolutely. I can take this one, and I think it really depends on. I think that there's potential, state-to-state variations. So I can comment in terms of what happens here in California. So in California, every single person, there's a law that essentially mandates that every single patient has a right to access to clinical trial, irregardless of insurance. So what that means is that when you see a provider and you consent to a clinical trial, that institution will submit for authorization to the insurance. And it's almost very difficult for an insurance company to potentially deny it because of that state law. The only instances where that's even potentially possible are certain insurances where to the patient, they have a pre-identified clause within their insurance that says this does not apply to clinical trials and everything. But those are really like outdated, documents and everything, and it's very, 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 very rare on that occasion. So at least in California, we're very fortunate that because of the law that's in place, that anyone that wants to be and wants to participate on a clinical trial, they will have access to that clinical trial, and it will be covered, for insurance. So financially, it is not a significant impact. Now, you could have, potentially Medicare insurance where if you don't have a supplemental, Medicare will, cover, let's say, 80% and everything, and you're, on the hook for potentially 20%. So there could be instances in those scenarios and everything. So again, it's very good to, work with your insurance companies and everything to make sure that you're able to, do everything properly. And usually wherever you're going for a clinical trial, again, the financial counselors of that institution is going to be working with your insurance. So very rarely would you be actually getting a bill for anything that's done on a clinical trial.
Mm-hmm. So that's not really what happens in Baltimore, unfortunately. So, there's that, and that's great, Dan. I wish maybe I should move there. But there's of course like industry-sponsored trials, and then there's government-sponsored trials that we have access to at our institution. With the government-sponsored trials, there's not as much funding, although that doesn't mean that trial is not important. It's extremely important, but the funding is not always there. But the industry-sponsored trials, the pharmaceutical company that's funding the trial usually takes up the cost of whatever extra lab work, extra imaging that needs, and of course the drug cost. They make sure that is not a cost for the patient. For the government-sponsored trials, I've gotten pushback on the imaging because they want imaging, of course, every 6 weeks instead of every 2 to 3 months. And sometimes I've gotten, denials about blood work. So it's much harder for us to have government-sponsored trials at our institution. I wish it was a little bit easier, but that is a concern for us. And that, usually there's not a shortage of trials. JD is not that far away from me, and I can always send them to NIH if I need to. So I haven't felt the lack because of that, but that's definitely something concerning about, getting reimbursement for the patients for insurance and having to fight with them for the government-sponsored trials.
And just to add information here, I work at the National Institute of Health, so we are a government-funded research facility. And because of that, we are not dealing directly with insurance. I have to say that the NIH and the NCI has recognized the need to study more rare tumors, especially neuroendocrine tumors. I think they have recognized there is a need, there is a significantly unmet need, and that's why they are realizing that, okay, we need to invest on this disease, we need to develop more effective treatment options. So I think I'm very fortunate to be where I am right now because I feel very lucky to be helping with these efforts as well. But everything that we do at the NIH is free of cost. So in regards to lab, CT scans, lab, drug, everything is free of cost, and we don't involve the insurance for any kind of payments. The only way that we can involve an insurance company is, like, for example, if we need any form of transportation from one way to another, like they require a different specialty care that we may not necessarily have at the NIH. But other than that, in terms of follow-ups, care, we even fund for any travel because we see patients from all over the United States. We actually, depending on the trial, we can fund any travel back and forth as well. So I think that's, and again, I feel fortunate that I think the NIH has recognized that this is an unmet need, the field of neuroendocrine tumors.
Great, thanks for that. And that's our tax dollars at work, right?
Yes, that's right.
There's a specific question for you, Dr. Del Rivero, about your natural history study. Specifically, does it include sexual orientation in the demographic study?
So yes, so the NIH, we include any, I don't think we include all patients regardless of the age, regardless of the race, regardless of the sexual orientation, regardless of, where they're from. I think that we are very inclusive. I think the NIH is something that our clinical director, Dr. Francis Collis, definitely wants to recognize, like the whole kind of like we are one unity. We need to collaborate. We need to really be together. He really trying to something that I've been proud of the NIH there is we have a lot of diversity, and they're very, we see a lot of that in my institution. So I have to say that in our natural history study, we include everyone, regardless of where they are from, where they are, from all over the world. So I think this is a unique opportunity to really, see these patients and really understand more about the disease in a more organized, systematic way to study these tumors.
Okay, great. I realize I misread the question. It says, does the natural history study demographic questions include sexual orientation? So.
Yes, I mean, we wanted to include all of that, yeah.
Great, okay. Let's move on to some questions about symptoms, because, living with the disease, of course, is really a challenge. And so a question that comes up is, how is carcinoid syndrome diagnosed? And we'll start with you, Dr. Kotaya. How is carcinoid syndrome diagnosed? Does the patient have to recognize or report long-term symptoms as abnormal, or is it automatically tested for?
Yeah, well, that's a good question. So, most people do not have carcinoid syndrome, but a lot of people have diarrhea. Mm-hmm. So when I see a patient who comes in with a neuroendocrine tumor of the small bowel, or, where you classically find where you're going to be looking for carcinoid syndrome, and they have liver metastases, which is most of the cases they have liver metastasis, I usually check a 5-HIAA level. And if they're describing, some of them flush right in front of me, and I'm like, wow, that's impressive. And you can just, you can expect that their 5-HIAA is going to be elevated. But especially if they're describing, the flushing and the diarrhea, and the diarrhea is waking them up at night, so clinically it makes sense. And then you can confirm it with biochemical testing and drawing the 5-HIAA level.
Mm-hmm. Okay. And Dr. Lee, do you have anything else to add to that?
Oh, I agree.
Yeah.
Okay. Dr. Del Rivero?
Yeah, I think I agree with Dr. Kotaya. I think when we have the suspicion that this could be neuroendocrine tumor, the urine test is very important. I know that there are other markers like chromogranin A, but chromogranin A is not a specific marker, and not everyone uses chromogranin A. But again, I think every institution has difference in opinions about using chromogranin A, at least as a biomarker, responsive biomarker. But one thing that we do when we have, in order to diagnose somebody that has either carcinoid tumor, then after we have the biochemical evaluation with a urine test or a blood test, then we do the imaging studies as well. And then the imaging studies could be either from CT, MRI, to these more Gallium scans that is more specific for neuroendocrine tumors.
Great. So a related question is it possible to continue having carcinoid syndrome after the primary has been removed, especially something like lung, and nothing else visible on the scans? So we'll start with you again, Dr. Kotaya.
Well, that's the challenging thing, because I think I've met patients who are convinced that they still have carcinoid syndrome, even after they've had definitive surgery and the 5-HIAA levels are normal. And it's really hard for me to sort of imagine that's what's causing their symptoms. I know that sounds kind of awful, because a lot of people are convinced that they still have it. And sometimes it gets to the point where I do a trial of sandostatin or short-acting subcutaneous just to see if their symptoms get better. And most of the time it doesn't change. So, I think there are a lot of, I know we're always saying, hey, when you have flushing and diarrhea, don't forget that there's neuroendocrine tumors out there. And that's true. But sometimes people can have diarrhea and flushing for other reasons, and not necessarily neuroendocrine tumor. Is all I'm going to say about that. I'm going to leave it to my colleagues to kind of chime in if they want to.
So we'll go to Dr. Lee and then Dr. Del Rivero.
Yeah, no, I completely agree. This is a challenging aspect, and I think testing it with kind of somatostatin analog therapy for someone who has, let's say, persistent symptoms, but not necessarily any evidence of disease, you can see, and you can see whether or not there's an impact. I agree. If there's no response to that, then I think you're relatively pretty clear that it's not due to it. The harder question is, what if you do feel better? What do you do? And I think, again, you're going to have a very detailed discussion and very frank discussion with your provider, because as providers, we really try to focus on the science and really try to say, what we believe might be the potential causes from what we know, as far as we know from the science and everything. But at the same time, we also know potentially what you're feeling and everything. And I think it's potentially okay for a provider to just say to you, I don't necessarily know why you have those symptoms, because that's the truth and everything. But how do we work together to manage your symptoms and whether or not there's an effect? Because no matter how benign somatostatin analog therapy is, there's still side effects that's associated. There's still long-term impacts that's associated with that. So you have to have that risk-benefit discussion with your provider and an honest discussion in the setting of the unknown.
For that. And Dr. Del Rivero?
Yes, thank you. I think it is an important question, and I usually like to add to this, and I'll tell you why. When I was a practicing endocrinologist, I got a lot of consults, like it was flushing and diarrhea, rule out carcinoid syndrome. I got a lot of consults as a practicing endocrinologist. And that's one of the reasons why when I was an endocrinologist and seeing more and more of these patients, I decided if I really want to treat these patients from every aspect, I think I want to go back and do more training so that way I can, treat the more advanced disease, because I was getting a lot of these consults. I remember when I was in New York as a practicing endocrinologist, and it's true. I think I do agree with Dr. Kataya and Dr. Lee, and it's true. Like Dr. Kataya said, I don't think this is your neuroendocrine tumor. Maybe another reason why you have this flushing, or maybe why you have these diarrheas. Sometimes when they have any abdominal surgery, sometimes, as a complication, they can also have the continuous diarrhea because of the abdominal surgery that they have, not necessarily related to the neuroendocrine tumor. And sometimes with the flushing, sometimes I found that there may be other abnormalities associated with the flushing, like having menopause, like having thyroid disorders. So that's something that I was finding in a lot of my patients. I do feel like we don't necessarily need to ignore it. I do feel like you need to work very closely with your physician to say, well, we don't see any evidence of tumors. There may be something else that may be causing this. And maybe have a hormonal evaluation to determine if maybe the lack of testosterone or the lack of estrogen is causing those symptoms. And maybe the diarrhea may not be necessarily because you have a tumor, maybe because of the complications from the surgeries. So those are the things that, kind of like explain my patient, but that's a good question. Thank you.
Yeah. Yes. Thank you for that really thorough answer. And, this is a related question. It may be the same person, but let's take a case, right? So if someone has known carcinoid tumors that were removed at an early age, like 7 years old, and then they later on had return of symptoms years later, but their gallium-68 scans are negative despite multiple gallium-68, they're normal, and they respond to SSAs, but those SSAs only last for 2.5 weeks. Number one, what other diagnostic or genetic testing would you do if that gallium-68 is repeatedly normal? And number two, what would you do to keep controlling the symptoms? So Dr. Del Rivero, would you like to take that one?
Yes, can you repeat again about when was diagnosed with neuroendocrine tumors? It was 7 years ago, or
at the age of 7.
At the age of 7 years old. Oh, okay. So that's very, very young. So that's a great question. And I think that something that, and I can tell you by my experience that I have acquired at the NIH, but yes. So one thing, when I see somebody, very young patients, and we're seeing more and more of those patients as well, but when I see somebody that is that young, one thing that I need to evaluate is for any cancer predisposition syndrome. So that's something that we do. Sometimes in our study, we do a very comprehensive molecular analysis on the tumor. And sometimes the tumor, if there's any mutations within the tumor, that sometimes guide us to do what specific genomic panel we can do, germline panel. But something that we look in somebody that young with any neuroendocrine tumors is to look for other cancer predisposition syndrome. And which one are those? Multiple endocrine neoplasia type 1, von Hippel-Lindau, neurofibromatosis, tuberous sclerosis. So those are the other cancer predisposition syndromes. And I can tell you that I have seen similar case in somebody like has multiple endocrine neoplasia, that sometimes they remove the tumor, but then years later may have they have present with the symptoms again. And the thing is, like multiple endocrine neoplasia, they can have different neuroendocrine tumors. They can have a lung or a thymic carcinoid. They can have pancreatic neuroendocrine tumors. They can also have small bowel neuroendocrine tumors. They can also have carcinoid. So those are the things I need to look in somebody who presented that young to determine if that panel was done, at least to rule it out. One other thing, and does something because we have the experience at the NIH, is about familial carcinoid. So familial carcinoid is when we see 2 or 3 family members that had the history of having carcinoid. And sometimes those familial carcinoids are very difficult to diagnose. They're very small, they're very multiple, very close to the nearby area. Sometimes they can cause symptoms, but sometimes very difficult to localize. And surprisingly, this is something that Steve Wong at the NIH has worked on that. It seems that the Gallium scans, sometimes they don't detect the tumors. As we know, there is a specific scan called F-DOPA scan, which is only in research institutions. It's not approved by the FDA. I think it was recently approved for Parkinson's disease, but it's not necessarily approved for neuroendocrine tumors. So that's a difficulty, and so it's not widely available. But that's something that Dr. Wong and our institution has been able to diagnose, and he feels that this is a better scan compared to other imaging studies. But that's, one thing. I think those are the things that somebody that young is to determine if there is any family predisposition syndrome. And now, in regards, I wanted to answer like the second part of the question is like, well, I've been on Lanreotide. It helps me, but only lasts for like 2 weeks. And I also would like to know your thoughts of Dr. Lee and Dr. Kotaya. Like, what is their approach? How do they help control? Because I do have that with my patients that may last. It helps, but it may only last for like 2 weeks and then after that they start having the symptoms again. What do we do? And instead of 4 weeks, can we do it the long-acting Lanreotide as a statin every 2 weeks, every 3 weeks? How about the short-acting? When do we use that? How about the new pills? I don't have a lot of experience with the octreotide capsule extended release, but I know that was just recently approved, and that's something that I think they has been using for some neuroendocrine tumors. I personally don't have experience. I would like to know Dr. Lee and Dr. Kotaya's experience about the capsule on actin, but it seems that they wanted to use more like a rescue shots, and that's something that can be used in between the long acting as well to help control the symptoms. What do you think, Dr. Lee and Dr. Kotaya, about that?
I mean, I was going to say, you
go ahead. Go ahead. No, go ahead.
No, I was going to say, I think Dr. Lee kind of addressed, this dilemma that we get into where somebody has normal hormone levels, normal scans, and then you've done a trial somatostatin analog and they feel dramatically better. I mean, am I going to sit here and pontificate that we know how to measure all the hormone levels that neuroendocrine tumors make and we know how to, track them? No. I mean, there's hormones that are being made that we don't have the technology yet to sort of check or to really be aware. Right. I think the problem lies in that if somebody's young and you're giving them, these injections for symptom control, and, we're not talking about tumor control because you can't find any tumor anywhere, they're likely going to run into problems with developing diabetes on the drug and pancreatic insufficiency on the drug. And it's like Dan said, it's not a benign thing to put somebody on somatostatin analog. And it's a very sort of dicey situation because you don't have measurable disease. You don't have a way of knowing for sure that somebody has hormones and you're just treating them blindly. And I think it puts a lot of, pressure, like you don't want to do harm to that person, and that if they continue to take that drug, they will get side effects, or they will get toxicity. They will become diabetic potentially, and that's hard for me. Like, I think it's a lot of back and forth. I mean, I know our technology is not there, but are there other ways to manage the person's symptoms without intensifying somatostatin analog? I mean, I know there's new data now with Lanreotide. You can give it every 2 weeks potentially for tumor control. I'm sure that's going to translate eventually to for symptom management. But, and then we have Zermello, we have the Benfezia pens, and we have, these new, we have ways of helping people with breakthrough symptoms to try to get better control. But specifically for that patient, it's very challenging for me because I would feel the balance of toxicity versus benefit. Where are we and how bad are their symptoms? Are other things able to be done to manage their symptoms? Dr. Lee, I don't know if you have any other thoughts.
Yeah, no, I completely agree with your comments. I think, again, this comes down to an individualized approach, and just like everything in medicine right now, kind of weighing the potential risks and benefits, and what are your goals of treatment with any of those treatments. Unfortunately, in medicine, no matter how many advances that we have made, none of the treatments in medicine, this is not just in oncology, but overall in medicine, none of the treatments is completely benign. You could be taking a medication, let's say for constipation, for example, lifelong constipation, not related to your tumor or anything like that. There's a potential side effect with that medication over time. So you have to understand that everything comes at a risk, and what are you trying to achieve and everything. You could say that I can't live my life on a daily basis unless I have the injection in my system and everything, and I'm willing to incur the risks that might come, even if they're relatively small. I'm willing to incur that risk so that I feel better for the short time and everything. So here you're going to value that more than the long-term risk, and that if that's your value, then it makes sense. But if you say, the symptoms are really not that bad, I can probably tolerate it, I don't have the best quality of life, but I have an okay quality of life, and by not taking it, I'm going to potentially minimize my risk to other things, and now that's a different story in terms of how you prioritize. So this is really kind of area of research that we're looking at. We had a NIH grant with this, looking at kind of patient preferences for competing outcomes, and hopefully we'll be able to, in the near future, share some of that data to really see, how our neuroendocrine patients, kind of prioritize these, potential competing health outcomes, because I think that's ultimately what's needed to make a lot of these decisions.
That's a really good point, right? It's a risk-benefit analysis, and always a conversation with your doctors. And speaking of conversations, actually, there was a really good question that came up about communication with the doctors. Let's see if I can find it. So patients specifically said, I have trouble answering the question, what is your pain level? So can you come up with some way to help me communicate this that would be helpful? Dr. Lee, would you like to start with that?
Oh, so pain is very hard to quantify, right? I think, my pain threshold compared to everyone else's pain threshold might be very different, right? Like I think I can tolerate a lot of pain, so I'm not gonna ever rate my pain as really, really, really bad until it's really, really, really bad. Probably my, let's say, if I rate a pain on a scale of 1 to 10, which is traditionally what you get asked in the clinic, I might rate myself as a 3, but Lisa, you might rate yourself as 9 and everything, and we might actually have kind of very similar pain and everything like that. So it's very individualized. It's very perspective. There are kind of different scales to kind of measure these things. There's kind of a happy face scale where it shows you how bad your pain is, and you can see it in that way and everything. But I think rather than focusing on what the actual number is, it's really to kind of bring it back in terms of relating it to how is that compared to your normal day-to-day, and how is that, let's say, compared to what you have known previously and everything. So it's essentially quantifying it relative to your baseline rather than quantifying it to everyone else's baseline.
That's right.
I mean, I agree. And I think, so every time a patient tells me about a symptom, and I've been following them for some years, like shortness of breath or pain or whatever, I'm like, is it better, worse, or the same as the last time I saw you? And do you need me to do something about it? How, do you need me to interfere? Is it bothering you enough that we need to look into it more, or give you some medication for it? Or, that's how I sort of gauge symptoms in my patients.
Okay.
Yeah.
Thank you. That's really helpful, right? In really basic patient layman's terms, right? Is it better, worse? What can I do for you today?
Mm-hmm.
Dr. Del Riviero, did you have anything to add to that?
No. I think that was covered. Thank you.
Okay. Another question that comes up often surrounds diet and how it might impact NET. And specifically, there was one that came up about if a vegetarian diet might affect one's immune response, and could it lower your blood counts, your white blood cell counts, your red blood cell counts, enough that we need to consider this when taking treatments like everolimus or PRRT. Dr. Lee, let's start with you.
So I'm curious in terms of what the others on the panel would say. I mean, I don't believe we have necessarily evidence to indicate that. So I don't think that right now we have enough data to say that diet can potentially make a huge change on a consistent, durable basis in terms of hematological variations, whether it's white blood cell count, red blood cell count, platelets, and everything. Usually that's more impacted due to either other medications that you might be taking. Like medications is probably the number one cause of other medications in terms of impacting things like white blood cell count, whatnot. You can get a lot of variations in terms of the white blood cell count from day to day, just because how we measure the white blood cell count, and it's kind of complicated for me to kind of get into. You just have to kind of trust me in terms of how we test the white blood cell count. Right now, it's not like so precise, so that's why you're going to get a lot of variations kind of from day to day. So specifically with diet, I don't believe that there's enough evidence right now to suggest that can have an impact on kind of blood counts for a durable period of time.
Okay, so Dr. Cataia, if a patient is on everolimus or PRT and all of a sudden decides to change to vegetarian and their counts drop, could it have been from their diet?
I mean, I agree with Dr. Lee. I mean, we make white blood cells, they turn over every 3 to 24 hours. They turn over very quickly, right? That's why when you give chemotherapy, you give therapy, that's the white cell, that's the blood count that's going to go down the quickest and recover the quickest. I have had patients in the last 10 years that I've been at Mercy, who are, meat eaters, vegetarians, vegan. I have never noticed a trend that my vegetarian or vegan patients have lower white counts than my patients who eat meat, although everybody sort of acknowledges that, cheese and meat can be inflammatory type of foods. I think that the cancer guidelines are sort of very strict about how to prevent cancer or try to decrease your recurrence, in that they say that you should eat a plant-based diet and no processed meat, or eat meat very little, and exercise 2.5 hours a week, moderate intensity, and all those things that they recommend. So we don't want people to be like, well, I can't be vegetarian or I shouldn't be plant-based because somehow it's going to drop my white cell, it's going to impact my ability to tolerate treatments. I mean, we expect people to have, blood counts that drop on PRRT or on everolimus, and we have ways of adjusting for that so that patients can stay on treatment. That's sort of my spiel on it. Dr. De Oliveira, if you have anything.
Yeah, no, I agree with you and Dr. Lee on that aspect. I don't think there is any data or anything that suggests that a plant-based diet can lower the white blood cell. And again, I've been at the NIH for 8 years now, and going to 9 years. But yes, even on our clinical trials, we don't make any, diet restrictions, and even for some of our agents that may have a risk to lower the counts, but I don't think we have enough evidence to say that. I agree.
Great, thank you for all three of you. On the testing question, in that area of testing, there's a question that came up about how often an echo should be done in patients. So Dr. Lee, would you like to start with that one?
Okay, so this is also a kind of a controversial topic. Whether or not to do baseline echo as well as serial echoes in patients with neuroendocrine tumors. I think this really applies to potentially patients that have carcinoid syndrome. So those patients that have excess serotonin access, because over time, this potentially can cause an effect on particularly the right-sided heart valves. I think in patients that have carcinoid syndrome, it's reasonable to get an echocardiogram and then followed serially, depending on the overall extent valvular damage within the heart, as well as symptoms, and as well as kind of control. But there's no kind of set guidelines, even in those patients, in terms of how frequent you need a echocardiogram. So I think again, it's a provider-patient discussion about that. But for patients that have no suspected carcinoid syndrome, I wouldn't necessarily favor a routine echocardiogram, because I don't think you're necessarily going to find much unless you have a specific indication that you're looking for, symptoms like shortness of breath, chest pain, whatnot.
Mm-hmm. Yeah, I agree. I think, I get a baseline echo on patients who have syndrome, who have at least 3 to 5-fold elevation in their 5-HIA. And the patients that I get nervous about doing serial echoes are the patients where I just really can't get their 5-HIA down. Like, they're on maximal doses of somatostatin analog, they're taking like short acting, and they're on Zermello, and their 5-HIA is through the roof. And that's usually the patients who have high liver burdens, in my experience. And no matter what you do, they're still cranking out that serotonin. And so for them, I might follow their echo once a year. Mm-hmm. I think if you get their 5-HIA down, their serotonin is controlled, and you had an echo that didn't show any valvular damage, and I don't necessarily think you need to keep doing an echo unless they develop a symptom or they complain of something in particular.
Right. And I have to say that I agree with Dr. Kotaya, even though, as Dr. Lee mentioned, there is no guidelines that tell us like how often you need to do the echo, or what patient population you need to do the echo. But I do agree with Dr. Kotaya, and I actually follow her same approach, in the sense, like if we have a patient that have high hydroxyndolacetic acid, it has, large tumor volume that you're trying to lower this, the levels, and doesn't come down, I will be more, in those patients, I actually do serial echoes like once a year. For the other ones that don't necessarily has the classic carcinoid syndromes, maybe not significant volume of disease, or high hydroxyndolacetic acid is controlled on the somatostatin agonist, I may not necessarily do the echocardiogram as often. But again, this is something that is, every provider may have a different of opinion, and we don't have any guidelines about that. And that will be a great question. I think something that we can definitely bring to the organizations like LACNETS to say, like, what do we need to do for this carcinoid heart disease, to say, and that's a great question. And we definitely will bring it to the LACNETS board of directors about that. I think that makes sense. What do you guys think? Dr. Lee and Dr. Kotaya?
Yeah, I agree.
Well, Dr. Kotaya, you mentioned tumor burden both in your talk and just now. So I guess a question that comes up sometimes in our support groups is, how do you determine tumor burden, and how do you measure the percentage and decide how much tumor burden is too much? And before you answer that, there was actually a question that even asked, how do you determine if liver lesions found during ultrasound are NETs? So if you can answer that first before getting into tumor burden, that'd be great.
What was the how do you know? You don't, okay, so probably the radiologist will make fun of me, but usually when they scroll through, if I'm like, oh my God, then that's a high liver burden. No, that's not, no, I'm just joking. So I don't think you could tell by ultrasound if you have if you have metastases from neuroendocrine tumor. Imaging, except if you're doing, gallium scan or a copper-64 scan, those scans kind of tell you that there's receptors on there that you can see with slow-growing neuroendocrine tumors. Other than that, like a biopsy, and sometimes MRIs, if they're vascular tumors and they light up well, they have that characteristic finding, like the radiologist will be like, this looks like a hemangioma, this looks like a cyst, this looks like a neuroendocrine metastasis, right, in the right patient who carries the diagnosis. So, we as oncologists, I'm going to speak for all three of us, we don't want any liver burden, but, obviously everything kind of hinges on the patients. Like I remember when I started practicing 10 years ago, and I was starting the Neuroendocrine Tumor Center, a couple of patients came to me and said, well, we were told we don't have to worry about it because it's not really a cancer, so we don't need treatment for it. And these are patients who had liver metastases. And I had a guy recently who came from Puerto Rico who was 4 years, they were watching his liver metastases grow, and now he has a very high tumor burden. To me, high tumor burden is any tumor burden over 50%. That's sort of in my mind, it's not scientific, that's just how I think of it. how do I quantify the tumor burden? I just kind of get a sense from the radiologist how much they think. It's like a very crude thing. They don't like it when I pin them down on it. They don't like it when I get them to give me a percentage. But I sort of like ask them, well, how much of the liver do you think is involved? And then they kind of give me their estimate based on their experience. I don't know what Dr. Lee and Dr. Della Rivera do.
Dr. Lee and then Dr. Della Rivera.
Oh, sure. Yeah, I mean, I agree with Dr. Patai. I think liver burden characterization is somewhat subjective. But if you take a look at, let's say, other diseases that are also involved with vascular tumors. So, for example, I also treat liver cancer. So, liver cancer specifically in the liver and everything. A poor prognostic, factor is greater than or equal to 50% of the liver, and that's been shown over and over. So for those patients where primarily their disease in the liver, that's the threshold that we typically use. I think that's very reasonable to consider that, for neuroendocrine tumor patients as well. I do agree with that as kind of how you make the judgment of significant liver burden.
Yeah, I agree with Dr. Lee and Dr. Kataya. So first,
thank you. And on that note of the testing again, Dr. Kataya, here's a question about the scans. You were talking to the radiologist. For chest, abdomen, and pelvis CT, is there an optimal thickness and increment? And the second question, is it preferred for brain MRI to be on a Tesla 3 versus a Tesla 1 MRI machine?
I will tell you my recent experience. I'll start with the last question first, Lisa. So, I had a patient who was asymptomatic, and she actually had a lobular cancer of her breast, and she had this MRI, Tesla 3, ordered by her radiation oncologist, and they diagnosed her with potential early leptomeningeal spread, which is basically that there's tumor tracking along the brain and the lining. And of course, it created a whole lot of anxiety. And she's 37. She has 3 kids. She's an ER physician. And it turns out that it was just an artifact from Tesla 3. So, I'm not a radiologist to sort of pick one versus the other. I order a brain MRI with and without contrast when I want to look at somebody's, brain and make sure that they don't have metastases. And then I let the radiologist work out the kinks. In terms of pan scanning or scanning the body, I don't usually do a CT of the chest unless somebody has no lung nodules there that I'm following. In terms of, in the adjuvant setting, when I'm sort of following somebody who doesn't have cancer, we're just kind of following their disease, I usually do a chest x-ray once a year, and then I really just kind of focus on their liver imaging. But I order CT angiograms, like a triple phase contrast, I think that, the technology is pretty good now. And I think if your CAT scan is not showing you liver burden well, it doesn't matter how fine point the picture is. It's just not going to be a great scan for you. Maybe the MRI is better. But I think if you're, CT with contrast, your CT angiogram or whatever you're getting consistently showing your disease burden, it's going to. So I don't really tell the radiologist what to do, except I do order CT angiogram versus triple phase CT, but how they do their procedure to get the picture, as long as they get a good picture from me. And if they tell me I didn't get a great picture, you need to get an MRI or you need to get something else, and I follow their instructions on that. That's sort of how I approach things. So I'll let Dr. Della Rivera and Dr. Lee sort of chime in here.
Dr. Della Rivera?
Yes, I do agree. I'm not a radiologist, and I usually kind of request scans, and I don't specify to the radiologist what kind of, how many, if it's thin cut versus, and how much is the thin cut. It seems like whatever scans they are is like either 1 millimeter or 4 millimeters cuts. So I can tell you an experience as well. I at the NIH, we do have a fantastic surgical team for thoracic LACNETS as well for any abdominal neuroendocrine tumors. And sometimes in preparation for surgery, my thoracic LACNETS may say you know what, I may need a different CT scan of the chest with more thinner cuts because I need to know, what's going on and what will be my plan for surgery. I think that now, I mean, in terms of the imaging studies, I think, it has been more modernized. I think we have very good techniques. I think I personally just ordered like a regular MRI of the abdomen pelvis for follow-up, with just CT scan of the chest if needed as a follow-up for my patients, but I don't necessarily ask, the cuts. But I have to tell you my experience with my surgeons. They may want a specific CT scans, that they wanted to see specific structure in preparation for surgery. And that's when we need to specify about what cuts, what measurement, what they need to do. And I think that's the only way that I can specify about that. Yeah.
Got it. Dr. Lee, do you have anything to add to that?
No, I generally agree. I think it's also the technique. So sometimes, particularly with MRIs, you want to make sure that there's not too much motion when you're taking the MRIs. You take the deep breath at the right time and everything, so that you get a good picture. Sometimes, if the techs at different centers don't tell the patient to follow those, then you're gonna get a bad image no matter what, and you might have to repeat the imaging. So.
That's a really good point. I think those of us who had MRIs remember those instructions to take a breath and to hold it here and there. So another question about testing, Dr. Kataya, I'm going to give this one to you, is about NET testing. How does that compare to the chromogranin A, and if it's better? And if it is, why is chromogranin A so widely used and NET tests considered controversial?
In the last 10 years that I've been doing the endocrine tumors, there's been many criticisms of the chromogranin A and how it's an imperfect test that can be influenced by many things. And there have been, attempts to try to improve on that. And just generally as an oncologist, tumor markers are things that can guide us, and sometimes it's helpful when they're trending. There's never a perfect tumor marker for every tumor, unfortunately. And so I wish, I draw chromogranin A, but I wish I didn't, because I think people get way too nervous about their chromogranin A, and I'm really looking to treat their scans. I think that, I have not ordered a NET test, and I have sometimes ordered pancreastatin levels because they tend to be less prone to fluctuations than chromogranin A. But I've never had a tumor marker influence my management. And that's ultimately what it boils down to. Somebody has to show me that a NET test is going to impact the survival of my patient, and that somehow by intervening early, because I'm seeing a trend in a blood test, that it's going to help the patient have a better outcome. And right now, there's still too many unanswered questions. And I'm more than happy to acquire the test. I've acquired many tests to try to make sure that I have a better understanding. But for neuroendocrine patients, the most important test for me remains the 5-HIAA when I'm trying to figure out about quality of life and symptom control. That's what matters to me the most. And I can draw these NET tests and chromogranins and pancreastatins and watch the data trends, but ultimately it creates a lot of anxiety without helping the patient's overall treatment plan. Because I'll treat the scans, I'll treat the burden in the scans, I'll make sure if the cancer is growing, that's what triggers me to change my management. If the patient's symptoms are not controlled, that's what triggers me to change my management. But I'll defer to my colleagues and see what they have to say.
Dr. Lee, I know that you're going to be ordering NET tests with your open clinical trial.
Yeah, so I think, we have to really, I do agree with everything that, Dr. Katai has mentioned, in the sense that, we never make a decision based off of a blood test in isolation. So what I always tell my patients is, we make a decision in terms of treatment management. One, clearly in terms of how the patient is feeling. That's always number one. Number two is the imaging, and then three with the tumor marker. All three together in context, and make a decision of whether or not the tumors are growing or not. So I also do agree that without prospective, well done trial showing a potential survival benefit with a biomarker, that you're not necessarily going to really change how you're going to practice. So I think as a society, as well as a neuroendocrine tumor community, we have to really understand, if we're going to do some of these studies, is it worth it? And is it really going to change management and improve outcomes. And we have to question that because our resources are somewhat limited. So we don't have the luxury of infinite resources and everything. So we have to really pick the highest priorities in terms of how it can really impact and improve the lives of neuroendocrine tumor patients. So in our trial that we're doing with Dr. Chauhan's trial with PRT with TrialPen, there is the NET test that's built in as a correlative science. So it's really just to see whether or not we can use the NET test and generate some prospective data that will be openly discussed and everything to see whether or not that there is some type of signal that you see in relation to, let's say, response or following of the patient over time. That trial is relatively small, so it's very exploratory in nature, and you don't spend too much resources on it. So I think it's worth investigating. And if you do see something in terms of a signal, then it's worth further investigation. But throughout the time point, we always have to raise the question of whether or not this is worthwhile doing in the long term, in terms of like what Dr. Katai has mentioned. Is it going to change our outcomes? Because if the answer is no, then I would say we should not be doing it.
I'd like to move on since you brought up PRT. There's a couple questions about PRT, and Dr. Lee, if you want to take this one first, what are the types of scan and the timing of each to best track the effectiveness of PRT as you progress through the treatment and post-treatment?
Yeah, so I think this has changed within the field as well. For me, luckily, it hasn't changed. So I stood my ground on this and everything. So usually what we do, and certainly this is not, I think every single provider is going to be different, but originally it was thought basically you just get a scan in terms of anatomic imaging, so CT or MRI, as well as a baseline gallium scan prior to treatment, just to make sure that all the disease has somatostatin receptor positive tumors, and then you treat, and then you don't image until end of treatment. And I saw that from all the experts, saying that and everything. Again, I'm an oncologist. My approach has maybe differed slightly as a result of that. So what we did was we would always scan in the middle, just because what we wanted to do was to get a thought in terms of what is going on with the patient. We understand that there could be mild progression, and in our hands, we know that, and we expect that occurs sometimes with treatment, and that wouldn't necessarily impact our treatment, but it does allow us to just make sure that there's not a patient that's rapidly progressing. And that's always kind of been our stance, and that's always what we've done. So we essentially get baseline scan, and then scan in the middle, and then scan at the end of treatment, and then traditional surveillance imaging after that. Other people will disagree with that and everything, but again, even with the disagreement, there is no prospective study that shows that, let's say, early imaging or late imaging leads to better outcomes either way. So I think, again, really have that discussion with their provider. What is the rationale behind their approach? And if it makes sense to you, then I think you guys can, really come up with an agreement.
And Dr. Lee, when you say the scans you're doing in the middle and afterwards, which type of scans are you doing?
Still anatomic imaging. At the end of the day, gallium is not meant to follow in terms of changes in size of the tumors. It's meant to have an assessment of whether or not the disease shows somatostatin receptor activity, and where there is, disease in terms of its, very, high sensitivity. But it's not necessarily meant to evaluate for change in size of the tumor. So you still need anatomic imaging as your fundamental baseline.
Okay, so you're ordering a CT or MRI. And Dr. Kutaya, how about you? How does your practice difference in terms of what types of scans and the timing of the scans that you order to track the effectiveness of PRT as you progress through the treatment and post-treatment?
Yeah, I pretty much agree with Dr. Lee, because we get a baseline gallium scan just to make sure the patients are eligible for PRT, and then we usually have a CT or an MRI, whatever shows the liver burden better, going into the PRT. There are, I know in practice, we're supposed to be treating well-differentiated G1, G2 patients, but there are G3, well-differentiated G3 patients who have positive gallium scans. And for them, if I'm putting them through PRRT, I am more worried about progression in them and making sure that they're not progressing rapidly on the treatment. So it's hard to go 8 months without knowing what's going on, because you don't want to be caught unaware. Actually, not even 8 months, 11 months, right? So if you go through the whole course of PRRT and then you wait like 2 or 3 months to re-image, which is what people had been recommending, what other neuroendocrine experts have been recommending, then it will take you almost a year to find out whether PRRT has been effective. And I think that for your patients who definitely have slow biology and you've been following them for a while, that makes absolute sense, because it can take the third or the fourth treatment for things to actually work. And the only time I do a gallium scan after PRRT is in somebody who had extrahepatic disease. And they had like bone lesions or lung lesions, and I want to make sure that they've responded uniformly, although honestly, it's the liver burden that drives the survival. And it's important to see whether things are growing or shrinking in the liver. But, if somebody had really bad bone involvement and I want to make sure that it's deactivated, then sometimes I'll do a gallium, but usually we follow the lesion size, and I agree with him about that. So I don't know if that helps or not, but that's sort of my thoughts on it.
Dr. Del Rivera, what's your practice?
Yes, I think that I completely agree with Dr. Lee and Dr. Kotaya. One thing that I want to mention is so what do we do in the setting of overall clinical practice, and what do we do in the setting of a research or in the setting of a clinical trial? And I think that's a little bit different as well. I think in terms of the clinical practice, I think that's the standard. And I think that's what Dr. Lee and Dr. Kotaya has said. You always get your baseline gallium scan. And then after that, you may or may not do, I think everybody kind of do another scan at the end of the 4 cycles of PRRT. And they follow, with either MRIs or CT scans, whatever preference is the provider is choosing. In the setting of a clinical trials, we may do a little bit more often, just because that's what we wanted. We have specific questions that we want to answer. And I can tell you, at least for our FIO para trial with PRRT, we do have 1 or 2 scans or gallium scans that we have done, because we have seen that this patient may have progressed even after 1 or 2 cycles of PRRT. And as Dr. Kotaya says, maybe we wanted to really determine, of course, correlating that with anatomical images that is disease is progressing. But that's another thing that we have seen, that maybe with the more rapidly growing, maybe you don't want to wait until the end of the treatment. Maybe you want to do it sooner. But again, so kind of the question is what is allowed within the clinical practice and the things that we do within the research setting. But in the research setting, we do it more often just because, at least 1 scan in between, because we wanted to know what is efficacy. We wanted to know if it's worth to continue. And at least on our FIO para patients, some of them, we have discontinued treatment and they have not been able to complete the 4 treatments of PRRT because of that.
Great. On a related question, and we'll start with you, Dr. Lee. As you progress through the rounds of PRRT treatments, what are some of the indicators of treatments having a positive impact?
Yeah, so we can certainly see a potential positive impact, again, through various different things. So 1, are you clinically feeling better? Usually if you're clinically feeling better, that's the absolute first sign that you're potentially responding to treatment. Second, you can potentially look at blood work. So sometimes if someone has, let's say, a lot of liver burden, they might have elevations in terms of some of their liver function tests. And over time, that liver function test might come down. And that might be indicative of a good response, for that patient. And then lastly, ultimately, with scans, you'll be able to see whether or not there's been a change. So again, just like everything else that we do, it's just not just one component, but there's all these really kind of 3 major components that we look at to assess for response.
But syndrome, I had a patient who had 1 dose of PRRT, he had a VIPoma, his diarrhea, he didn't have syndrome, he had a VIPoma, his diarrhea went away, it was amazing. But sometimes if your syndrome is getting better and your 5-HIA is dropping, then there's hope there that the PRRT is actually doing you some good too, apart from what Dr. Lee said. I would add that.
Yeah, I agree.
Okay. And what about those who don't have any syndrome, that are non-functional?
Yeah, then it's hard to tell without imaging, I think. Yeah.
Yeah, but I mean, you could still have symptoms as a result of tumor bulk, right? And if your tumor bulk is improving and everything, then you could still see, or feel a potential response.
Right.
Great, thanks. Speaking of feeling badly, let's go back again to symptoms. And Dr. Del Rivero, NET patients have an excess of serotonin, as you know. So does this cause mood swings, irritability, fatigue, and depression, or does it only cause physical symptoms?
So this is where I have seen, and I also would like to know Dr. Lee's and Dr. Kotaya's thoughts about that. But, what are the symptoms related to excess serotonin? And that's kind of like one of the things that I have seen besides the diarrhea, besides the flushing, because that's kind of like quite significant, especially when the serotonin, because one thing, we talk about the urine test with the 5-hydroxylacetic acid, but what is that? Is the breakdown of serotonin. So, and sometimes, what the symptoms with this excess of hormones, they can cause, as I say, diarrhea, they can cause flushing, it can cause fatigue as well. One thing that I have seen is that they can also cause vitamin B3 deficiency. And because of this vitamin B3 deficiency, that can also be associated with the symptoms associated with vitamin 3 deficiency, which is the depression, which is the skin changes, which is, so those are the things I have seen, but those are the patients that has a significant high levels of serotonin. I think that the excess serotonin can definitely cause symptoms. And that's the reason why, whenever we have this excess serotonin, it's like, do we need to treat? And as well, whenever I see a patient in my clinic and I see them, it's like, and I measure the hormones and I see how high they are, I always ask 2 questions. And that's kind of like, I always teach my fellows those 2 questions. It's like, what am I going to do for the symptoms? How can I improve his symptoms, the current symptoms because of the hormone excess? And then what do I need to do in order to control the tumor growth? So those are the 2 things. Sometimes, like I know that we treat one of the other, but regarding to neuroendocrine tumors, that besides the serotonin, the pancreatic neuroendocrine tumors can produce excess of insulin, somatostatin, which is rare, BIP, which is also rare. But, this gastrin is another one. We see a large number of MEN1 patients that produce gastrin tumors as well. So that's one of the things that I always kind of like teach my fellows is like, what do we do for the symptoms and what do we do to control the tumors burden as well? So even though they're related, but I wanted to understand that there are things that we need to do in order to improve the symptoms of those patients.
Right. Dr. Kotaya, what do you think about if excess serotonin causes mood swings, irritability, fatigue, or depression?
I think it's more the lack of niacin. I mean, there's pellagra, there's depression, there's the shunting of the pathway to make excess serotonin creates like a niacin deficiency. And there's definitely mechanisms that can explain depression, like Dr. Del Rivero was saying. So I think it is a very real thing that patients who have syndrome have more mood swings and depression and mental health issues. And, just also from the standpoint of having cancer itself can give you mood swings and depression. So, mental health is extremely important because it helps. If it's aligned, it helps us with the physical health. So, it's nothing to be dismissed. Patients have to be treated globally, because if we're not treating their depression, we're not treating their mental health, we're never going to be able to get their disease under control the way we want. I mean, that's sort of how I feel about it. It's very tightly linked.
Mm-hmm. And Dr. Kotar, I think you say a very important word, like mental health is important, and we have to treat the patient globally. It's so important, and I'm so glad that you say that, because it is very important. And one of the things is because even having this diagnosis, the fact that you have the cancer diagnosis is just generate a lot of stress and anxiety on the patient well-being. Despite of the symptoms related to the hormone excess, the fact that having this diagnosis and living with this on a daily basis is just generate a whole turmoil of feelings that is important that we treat the patient as a whole. And another thing, just to put my endocrine, here, is that even though a lot of these there's a lot of these treatments, or even, the fact that having cancer itself can also downregulate the endocrine system. And a lot of this, we can also see that they lower the estrogen levels, even in a young patients, or testosterone levels as well. And those lowering of hormones, other endocrine hormones, that can also translate on patients not feeling well, feeling depressed, feeling not itself. But I do agree that, treating the patient's mental health, treating the patients globally as a whole is super important. Thank you for saying that.
Thank you too, Dr. Del Rivera, for saying that. And another endocrine-related question is, Dr. Del Rivera, what are some different causes of hypoglycemia or reactive hypoglycemia among NET patients?
Oh, wow, that's good. Yes, that's a good question. So in terms of reactive hypoglycemia, so hypoglycemia related to insulinoma, hypoglycemia related to reactive hypoglycemia. So as we know, there are other things that can cause hypoglycemia. Drugs can cause hypoglycemia. Somebody's on insulin, somebody's on oral diabetic medications can cause hypoglycemia. Anybody who doesn't have enough liver reserve, that can also cause hypoglycemia. Somebody who doesn't have good kidney function can also cause hypoglycemia. Those are other causes that can cause hypoglycemia. But now in terms of the neuroendocrine tumors, we know that insulinoma can cause hypoglycemia because the excess of insulin can lower the glucose. But at the same time, reactive hypoglycemia, we see a lot of the patients that have surgical abdominal surgery, like Whipple's disease, that they have this reactive hypoglycemia because of the surgical intervention. Sometimes it's quite difficult to differentiate one to the other. And that's a great question, because the two of them has high level of insulin, high level of C-peptide, low levels of glucose, the two of them. So it's sometimes very difficult to differentiate insulinoma-related to neuroendocrine tumors or reactive hypoglycemia. And the best way to differentiate the two of them is by doing what we call a dynamic test, by you doing a fasting test in the hospital setting, or by doing also a mixed meal test with a hard carbohydrate test. And the reason why is because reactive hypoglycemia it usually happen after eating a high carbohydrate meal, and it can happen anywhere from 1 to 4 hours after they ingest the carbohydrate meal. So that's another way to differentiate between the two of them. Insulinoma can happen anytime, regardless of what you eat, but the reactive hypoglycemia usually follows a high carbohydrate meal. But in terms of the labs, it's very difficult to differentiate. So that's why when that happens, we then need to do more of an testing to differentiate it between the two of them.
Great. Thank you.
That was all her.
Great.
Great explanation. Thank you.
Yeah, that was great. Dr. Del Rivera, actually, since we have you here, here's another related, or in that field, in your field, are parathyroid or thyroid tumors or hormonal issues related to NETs? That comes up often.
Okay, so MEN1, multiple endocrine neoplasia type 1, has been associated with we call it the classic 3 Ps, but we now know that it can have other clinical manifestations related to MEN1. But in terms of multiple endocrine neoplasia, they can have neuroendocrine tumors, and that can be anywhere in the body. It could be lung, it could be thymic, it could be pancreas, small bowel neuroendocrine tumors. But they also have, in most of these patients, they have primary hyperparathyroidism, meaning that they can have a parathyroid adenoma that is causing excess of parathyroid hormone. And what the parathyroid hormone is doing is basically upregulating your calcium levels. So parathyroid hormone raises your calcium levels. So that's one thing that we have seen in relationship with multiple endocrine neoplasia. We also have seen other patients that have multiple endocrine neoplasia that may have thyroid and as well as pancreatic neuroendocrine tumors, but it's not often seen. I will have to say in terms of the parathyroid, yes, we have seen the parathyroid adenoma with the pancreatic neuroendocrine tumors. And it's usually what we say a patient that we label an MEN1 patient, just because we know that the MEN1 gene testing is not positive in everyone. But if you have the clinical manifestation of having 2 of the 3 MEN1 clinical manifestations, we label them as an MEN1. In terms of thyroid disease or thyroid cancers, I mean, we associated with neuroendocrine tumors, not as often as with the MEN1. But one thing in terms of like in my experience with, I don't know, Dr. Lee and Dr. Kataya, sometimes I see with the long-term use of somatostatin agonists that they can also cause hypothyroidism. Even sunitinib, certain drugs can also lower your thyroid hormones, and that's something that you need to check regularly as well on those patients using these drugs. And we need to check the thyroid hormones, because that's another thing is they feel very fatigued, they gain weight. So that's another thing that you need to make sure that you also check the thyroid hormones, because sometimes they can affect the thyroid itself, those medications.
Great. Dr. Kotai or Dr. Lee, do you have anything else to add with that? Okay. Let's go to a pretty straightforward one. If your 5-HIAA, I'll give it to you, Dr. Kotai. If your 5-HIAA and chromogranin A are normal, but you have liver lesions, does this mean they are non-functioning?
Usually, yes. I mean, if you're not having any symptoms, that doesn't mean the chromogranin, again, the chromogranin A is an imperfect marker, right? So there are people who have normal chromogranin A, but they have actually like a high, like they have metastatic disease in their liver. So you have to follow what you have, like, so if the blood work is not going to help you, then you have to follow the imaging. So yes, but usually I would say that they're non-functional.
Okay, Dr. Lee?
Yeah, I agree.
Yeah, the same.
Great. And in this area of clinical trials, okay, so let's go with you, Dr. Lee. Can a person with no remaining options enter a clinical trial on a compassionate basis if they don't explicitly qualify based on the number or type of past failed treatments?
Yeah, that's a very good question. So, I mean, this kind of goes to the point that I was trying to highlight earlier in our discussion in terms of, clinical trials come and go. Clinical trials also depend on whether or not you're eligible for a clinical trial based off of meeting certain criteria within the trial. So as a general aspect, you usually wouldn't necessarily want to go on a clinical trial if you're really, really sick, because that can, and the reason why is, one, are you going to be able to tolerate the experimental treatment? So that's a safety issue for you. But two, it also has an impact on the greater NET community as well, because if something does happen, well, was it a result of your underlying condition that you were in, just because you were relatively having significant disease burden and more impacted as a result of the condition that you were in entering the clinical trial rather than the actual treatment. So it has a huge impact. So that's why you want to have that discussion with your provider in terms of creating the optimal timing to go on a clinical trial, and usually never too late. For a patient that is in that scenario where they have exhausted, let's say, all FDA approved treatments, and they're still looking for a clinical trial in a refractory setting, and they don't meet the criteria for a clinical trial, whether it's due to laboratory reasons or other reasons, then you can potentially try to get the medication, if it's already FDA approved for a different type of indication, on what's known as a compassionate use program. So this is very complex, but essentially you have to submit to insurance. Insurance either accepts it or denies it. If insurance denies it, if there's a patient assistance program within the company that makes the drug, then you submit it to that and you essentially get approval or not for the medication, and then you can use it on a compassionate care program. If the drug is actually not FDA approved, then you can potentially do what's known as a single patient exception clinical trial. So a clinical trial just for that one specific patient. I will say that's very, very, very rarely done, because the issue is that there's a reason why you're not eligible for that trial. So why would you potentially write a single patient exception to treat that patient on a drug that is not yet FDA approved for anything else, whatnot? So that would be a very, very exceptional case where you would do that. And it's in my whole time, practicing, I've only done that for one patient, and there was a specific reason why we did it and everything. And there's usually usually we would not go down that pathway if a patient's, because there's a reason why you didn't qualify for the trial, and it's a potential safety concern that we're concerned about, because we have to put your safety at the first part of our decision when we're making these decisions.
Mm-hmm. I did do it recently. It was for a patient who the trial closed.
So that's one of those scenarios, right? Because you would otherwise qualify.
But you had to give away your firstborn child. I mean, the IRB. I mean, there's so many rules. The patient has to come in every month for blood work, and you really have to kind of follow what the trial was going to do. So they really make you jump through hoops, but sometimes it's worth doing if you feel like the patient is going to benefit from it. But I agree. I mean, you summarized that very well, Dr. Blaze, I have to say.
Yeah, I agree. Lisa, do you mind if I ask questions to my colleagues?
Sure.
Is that okay? So I was just wondering, what are you, like, for example, for FIOPARA, that's some of a neuroendocrine tumor that we treat at the NIH, we have as an eligibility exclusion criteria, like not previous, that they haven't received MIBG. So if a patient received MIBG, that's an exclusion criteria. But we feel that the patient may benefit from Lutathera. They cannot enroll in our studies. But I don't know if there is a compassionate program for Lutathera. So we're just wondering what would you recommend in those situations? What would what would be the steps in order to get this patient Lutathera?
I don't think there's an issue, in terms of getting Lutathera, and I think it also depends on, what the insurance is, because there will be differences. So here in California, especially with, let's say, Kaiser. So Kaiser is a large organization, managed care insurance, as well as, essentially providing care to patients. What's interesting about Kaiser is that I've actually really welcomed Kaiser. So while Kaiser won't necessarily allow, let's say, a patient to come to us to get standard of care, if we're able to provide something that Kaiser is not able to provide, let's say, such as Lutathera, for example, Kaiser actually has been very good about that. So they don't have to follow kind of the traditional, let's say, FDA approved like indication for Lutathera that we have right now. Because their own insurance, they're basically saying, like, we're sending this patient for you for your advice on Lutathera. If you as a practitioner feel that the patient can potentially benefit from Lutathera, and we have the data for that, even though it's smaller data and everything, we do have the data for that, then they're going to say that's okay. And so you don't meet that same challenges as, let's say, larger, private insurance and whatnot. So I think it's insurance dependent and everything. But even if they can't, then, it's always a discussion with the company if the insurance denies whether or not they have an assistance program that will help.
Okay, that's great.
Definitely going to move to California. We're like the only capitated state, like Maryland. So reimbursement is a huge issue for us because, all the hospitals are on a budget that was set. Medicare sets the rules, and Medicare denies anything that's not FDA approved. So it's a struggle and a challenge in Maryland to treat anybody off trial with a treatment that you think might benefit them. That involves, expensive, especially if it's expensive. Like, I've had to use mainly for immunotherapy, I've had to appeal to the companies that make the drugs to give us compassionate use of the drugs. But for something like PRRT, where they don't really have compassionate use anymore, and it's going to cost a whole lot of money to give that treatment, there's going to be likely a very much a denial from the insurances, just because the private insurers are following Medicare. So, so that's been very tough for us. And so we're very challenged by that. And apparently all the other states are going to be capitated over time. I've been waiting 5 years for Florida to be the next state to be capitated. So we were supposed to be the model which controlled medical care costs across the US. But it's been very challenging for us. We're doing our best, but our patients are still, I think, getting very good treatment.
Yeah, no, I mean, it's the one scenario where I think, for us with Kaiser being, HMO and everything, where that creates a more opportunity compared to private insurers and everything. So I think it's very different, state to state, as you mentioned, and even within the state, there's differences. As Lisa knows, like Kaiser could potentially internally refer their patients for Lutathera. There's been certain Kaiser sites that have developed Lutathera, but then at least so far, I think there have been Kaiser providers who recommend, who have acknowledged and understand the potential advantage of referring these patients to see a NET expert for their Lutathera, even though they have certain specialized centers that do that.
So actually that leads me to the next question. Someone asked, is it important to have a NET specialist? And perhaps that's more of a question for me than it is for you guys. But I hope that whoever asked this can see the difference, right? Between these 3 NET experts answering these questions versus perhaps a local or community oncologist, and perhaps what you have to offer, like what you were saying just now, Dr. Lee, about that. And do any of you have anything to add about, I guess, more, not so much is it important to have a specialist, but what might the difference be? Dr. Lee?
So, it's a hard question for me to answer because I always know kind of where I came from and everything. And so I always want to be, cognizant of that. I think, you need to find a good doctor. At the end of the day, you need to find a good doctor first. So someone who's, willing to, follow your case, offer you very open discussions and, good advice, regarding your case, and be willing to, really take care of you in terms of how you want to be taken care of and everything. And that might be good or bad in terms of, discussions of, frankness of the discussions and whatnot and everything. But I think first of all, you need to have a good doctor who's kind of in your corner. I've seen a lot of, community oncologists who might not be viewed as NET experts, but they were great doctors. And they've been able to manage their neuroendocrine patients really, really well and everything. And they've been able to do exceptionally well. So finding a good doctor in your community, I think, is really important. And then, kind of seeking out the advice of quote unquote NET experts. And I think in this area, NET experts vary a lot and everything. And I might be, not giving a truly popular opinion in these days, but I think it's an opinion that we have to start talking about in the NET community. You have certain types of NET experts who are, let's say, just focused on research, but doesn't necessarily see a lot of patients. And that's okay, because they're going to help you design and identify the next generation of compounds that are going to be very important in care and everything. But then your expectation from them is that they might not be able to handle kind of the day-to-day things that you're looking for, versus someone who's, let's say, a NET expert who sees a ton of patients every single day. And I know all of us here are seeing a lot of patients and everything. So we know how to handle potentially the day-to-day, kind of complications as a result of that, and may be able to manage the patient, much better and everything. And then you also have to have that expectation of, are you going to go to the NET expert as more of a kind of a consultant, let's say every 6 months or a year and everything, and kind of travel throughout the United States, to do that, or are you going to actually be treated there? Because that's going to be different in terms of the expectations that you're going to need. Because if you're seeing someone, let's say, once a year, that person necessarily is not going to be able to manage your day-to-day, symptoms or day-to-day, adjustments in medications and whatnot. And you're really going there for a change in a time where there's a potential change in your management or treatment. So I think those are all kind of things to keep in mind. But at the heart of it, you really need a good doctor, because no matter for all of us doctors, we were not a NET expert from day one. And we have to remember that. And that has come over time in terms of the number of patients that we have seen over time. And you should not necessarily use kind of age or anything else as a measure of experience, because what you've seen with, what Dr. Del Rivero, as well as Dr. Katai have shown, is that the treatments that we're using for neuroendocrine tumor patients are vastly changing, and they're changing very quick. So it's really, how much experience they have with that treatment on a day-to-day basis that's going to be very important for you.
That's a really excellent answer.
Yeah. I was going to say, I'm a community oncologist. So, I
know, and you're a great NET expert.
You see a lot of patients.
Yeah, so I mean, I have to say, I have my own viewpoint on things. I never really expected to develop a neuroendocrine program. I came out of fellowship just trying to build a practice in the hospital. And the head of our cancer institute said to me, there's so many neuroendocrine patients out there. We're operating on them. He's a surgeon. More and more, we really need to create a center like we did for our appendix cancer patients. And it sort of built, from like 30 patients to like over 800 now in the last 10 years. And I'm sitting between like two academic institutions. And I've seen patients being referred to me from those, patients who are coming to me from those institutions. And I don't manage them the same as the oncologist there, because I feel, like I've seen a lot and I've seen all the good and bad. So I have my own approach. I mean, not always, but sometimes I don't approach it quite the same. So, I, in the converse, when I see a patient come to my office with a cancer that I don't treat a lot of, like sarcoma or like glioblastoma, I will tell the patient, listen, I don't treat a lot of this type of cancer. You need to go to somebody who treats a lot of those cancers. So that, because I know my limitations. If you see that type of patient every, once a year or like twice a year, that type of patient, that you're not really doing them a favor by keeping them in your practice, because then you're sort of, kind of like, well, I don't know how you're going to react to the treatments because I haven't given this treatment a lot, but I'm hoping that I know how to manage it. Like that's sort of like how I feel about it. So I will, and if the patient's like, no, I really got to stay with you because this is more convenient for me, I live down the road from you, then I will liaise with that expert wherever they are. And so I try to offer the same service. Like, if you want to come see me for your neuroendocrine tumor, but you live 4 hours away, 5 hours away, which happens a lot, I'm happy to manage you, see you once a year, twice a year, and help co-manage with your local oncologist. Because it's not about, it's more of a collaborative thing. And, it's not so much like for me, I think for us, it's more just about overall improving the treatment of neuroendocrine patients across the country. And if somebody is not familiar, not comfortable, I'm more than happy to help, lend my thoughts. And like Dr. Lee said, we don't all the neuroendocrine experts don't always manage everything the same way, and that's okay, because there's an art to this, and it's basically your experience that guides you just to do one thing more than the other. It's sometimes based on what kind of toxicity you had from a treatment or what kind of success you had with a different treatment. You want to start with something first versus something else first versus another neuroendocrine expert down the street. So it's always good. I think one of the great things that I enjoy about the neuroendocrine tumor groups that we have is that there's a lot of multi-D care, like a multidisciplinary care, and getting other people's input. And I always, run things by my other colleagues across the country, because sometimes you'll see it. For all these years that I've been taking care of neuroendocrine patients, there will be a case that walks in and I'm like, wait a minute, I have not seen this before. So every time I think I have things fairly down, somebody comes in and surprises me. So, and then I have to be like, let me ask everybody else, have you seen this? And sometimes that's a case that we all learn from. And that's the thing that I find amazing about, oncology and even neuroendocrine. You're never too old to learn, and you should always be learning.
Right.
And anyway, I got sort of sidetracked, sorry.
No, that's wonderful. That's wonderful. I think you guys cover everything. And at least in my experience is that, again, we are a research institution and I'm always available. I mean, we have patients that come from all over the States, even all over the world. I have patients that have come from South Africa, UK, all over the other side of the world. But yes, I do have a commitment with the NET community that I'm available as Dr. Kotai and Dr. Lee, and provide and help other providers to help continue the care. And I completely agree with you both.
Okay. Well, I know that I've already taken an hour and a half of your time, so let's see if we can get through a couple of these really quickly. Dr. Del Rivero, if grading is intermediate or unclear, are there studies addressing unclear or intermediate grade, or are all studies either very clear, low grade versus very high grade?
Okay, that's a very good question, and I have to say that I will also love their opinions of Dr. Lee and Dr. Kotaya. So the way that we now grade in neuroendocrine tumors is kind of like based on the Ki-67, which we call that's the proliferation index. If it's less than 3, well differentiated. 3 to 20, that's intermediate grade, and greater than 20, that will be grade 3 until usually 50, greater than 15. Then we go into other poorly differentiated neuroendocrine carcinoma. But one thing is that is usually we see that for the gastroenteropancreatic neuroendocrine tumors. My experience, and I would love to know Dr. Lee's and Dr. Kotaya's stories about the lung neuroendocrine tumors, it seems that they have a different classification system to determine typical versus atypical. But how about other tumor types? How about other neuroendocrine tumors like the bladder? We have a good number of bladder neuroendocrine tumors or ovarian neuroendocrine tumors. Can we extrapolate the same classification that we have used based on the recent WHO classification for the gastroenteropancreatic neuroendocrine tumors? So that's the thing that we're trying to understand, but at least for the GI and for the pancreas, we know that this Ki-67 and this gradient really kind of help us to also understand about the biology of the tumors, and as well as it's a prognostic tool. But we still, for the other sides of neuroendocrine tumors, I still feel like there's still more things that needs to be done. And I don't know what Dr. Lee and Dr. Kotaya think about that.
I mean, I absolutely agree. I think that, we still have work to do even with the GI, because, I do think that patients who have Ki-67 of 20 to 55% are different than the patients who have Ki-67 above 55%. And yet we have not done, most of our trials have been less than 20%, or just like, patients who have very high Ki, 80, 90%, and even those patients don't get a lot of trials. Number one. Number two, I've had breast neuroendocrine patients who have Ki-67s of over 90%.
Right.
And then their estrogen receptors are quite positive. And I'm thinking, oh, they need chemotherapy because their Ki-67 is very, very high. And some of them have refused and have done absolutely fine on hormonal blocking. And they're like 5 years out, without recurrence with chemotherapy. So definitely for a rare disease at rare sites, and the challenge is going to be getting enough cases together to kind of analyze and sort of realize what is the right thing to do for those patients. And you definitely don't want to be the patient with the rare disease at the rare site, because sometimes what happens is people correlate with the most common form of that disease and try to guide you in that direction, but we don't really know how to treat those patients, and that's challenging. I don't know how Dr. Lee feels about that.
I agree. I think even for one disease type, like just look at kind of the clinical trial data and everything. Even for GI neuroendocrine tumors, some of the trials will limit Ki-67 to less than 10% and everything. Well, so that puts you in a conundrum, because you could have a grade 2 that's 8 or 9% versus a grade 2 that's 15 to 18%. And I think what we know is that those patients probably will respond a little bit differently to different types of treatments and everything. And, we have to make a conscious effort in terms of how we're lumping everything together to make assumptions of outcomes.
Okay, thanks for that. And Dr. Lee, you talked about patient preferences earlier. There's a question that came in: can a patient decide the extent of a surgery to remove a midgut net? What if a patient wants to keep the valve? So I'm assuming the ileocecal valve, no matter what, if this means not to remove the whole net.
Yeah, so I think that's, again, a discussion with your surgeon and everything. I think most of us providers really want to work with you guys as patients and everything. But at the same time, I will push back a little bit here on certain things, like, procedural things, especially, big surgeries and everything. You have to have a lot of faith in your surgeon, because that's a big decision and everything. And there's a reason why they might be doing certain things, for that. So really have that open conversation with your surgeon, but also be open that you might not, get what you think is the best surgery and everything. And there's a rationale behind that from the physician that's treating you. So in order to have best care, I really believe in kind of this openness and trust that has to be developed. And that's not just, doing everything that a patient wants to do. It's not doing everything that a doctor wants to do. It's really like kind of coming in the middle and saying, this is the reason why I want to do this and everything. And these are why I want to do this. Are you okay with this? And kind of coming into that agreement.
Mm-hmm. Dr. Kotaya, do you have anything else to add? Or Dr. Del Rivero?
No.
I think that's great.
That was well said.
Cover everything, yeah.
Okay, Dr. Kotaya, should someone with a tumor removed from the appendix, so it's already removed, should they get a gallium-68 scan?
I mean, that's a multi-layered question. I guess it depends on the size of the neuroendocrine tumor, and whether or not there's features in the pathology report that are concerning that there might be lymph node involvement. I know that we love our gallium scans. I'm guilty of that too. But, I usually don't, do a gallium scan as somebody who had a very early stage appendiceal neuroendocrine tumor where we think the cure rate is high. So, I mean, if it's over 2 centimeters, I probably will do a scan to make sure everything's okay. If there's only the appendix that was removed. Other than that, I don't usually order a gallium scan just routinely.
Okay. Dr. Del Rivera, do you have anything to add?
Yes, I think, I mean, I have to say, I get this question a lot because we have the pediatrics and adults neuroendocrine tumors, and appendiceal neuroendocrine tumors seems to be, we see it more in pediatric actually, and because appendicitis, and then incidentally there was found neuroendocrine tumors. And one of the questions that I always ask is about the extension of the surgery, as well as what imaging studies needs to do in order to determine the extension of the surgery. And I'm actually working with my surgeries to develop like a kind of like a little bit of consensus statement about that, because my surgeons feel like, well, if it's greater than 2 centimeters in size, if it has any invasion to the mucosa of the appendix, if there is lymph nodes, so that indicates, maybe having a baseline scan to determine also the extension of the surgery, and then we can do more extensive surgery. Younger people may respond better to more aggressive surgery than older people as well. But I do agree with Dr. Kotaya, unless it's like greater than 2 centimeters, it has any suspicious findings, I may not necessarily do a gallium scan. But it's true, I'm kind of like also guilty saying like, yes, let's do a gallium scan, and we do it. But again, this is kind of like an area that needs to be further explored, and also have a consensus or guidelines to determine what to do, whether we need more extensive surgery, what is the criteria for more extensive surgery, do a gallium scan baseline prior to more extensive surgery is needed, do a gallium scan is needed after a baseline, and how long. So those are the questions that we definitely need to ask, and it's still an area that is ongoing in terms of research and answering those questions. I don't know what Dr. Lee thinks.
And the other thing is that I forgot to mention is, like having a negative gallium scan is great, but it doesn't necessarily mean that you don't have a neuroendocrine tumor, like microscopic disease hiding. Every imaging that we have is limited by size. If something's small enough, nothing's going to pick it up very well. And there are patients with appendix neuroendocrine tumors where what's going to happen to them in the future is they're going to have disease in their lining of the abdomen, like the peritoneum, because of the way that the tumor is extending outward versus lymph node metastases. So, and peritoneal metastases are very hard to find sometimes on scans, CAT scans, gallium scans, or even MRIs. Like nothing really picks them up that well. So, it's fine to have a negative scan. You're sort of happy about having a negative scan. But getting a scan should not make you feel like, okay, I don't need to do follow-up. You need to do follow-up no matter what. You need to be aware. Right. If somebody says to you, your tumor is very, very small, and we've cut it out, and the likelihood is low, so, go live your life, do your thing. Usually we have protocols in place, if we're worried about you and we think that you need to be watched, then we will put you on an imaging scan. So, kind of surveillance, or and blood work scan surveillance, whatever. That needs to be better defined too with NANETS, but we're sort of, I think we're working on being more consistent with NCCN and NANETS. But I think that I think people can sometimes use it as a crutch. Like, I feel better, my gallium's negative, but you just have to sometimes wait things out and hope that for the best.
Right. Good point. Okay. Well, speaking of tumors in less common sites, Dr. Lee, how often do you see kidney primary NETs? And some doctors might say like it's an unknown primary because they think that primary site is so unlikely, it doesn't matter for treatment.
Yeah, so it is. They do exist for a fact. There's only been a few publications on this. We actually have a publication that we've sent it to the journal looking at our experience in California. So it's definitely real, and kidney primaries are real. So you do have to, depending on the case, make sure that it's not some other primary as well in terms of metastasizing to the kidney. But just as a matter of fact, it is real, and then you have to, manage it because there's not a lot of, guidelines, like kind of like the earlier question. You might try to extrapolate from other, management, sequencing or management or treatment that you would do for other types of neuroendocrine tumors, but there's really not a lot of experience behind this. So hopefully as we get more experience with this, as a group, we can kind of come together and share some thoughts on that based off of our individual experiences. So I'm actively treating, patients with kidney. So I know what, we're doing here and everything, but, it would be good to kind of collaborate with others to kind of share their individual experiences in terms of treating that.
Dr. Kataya, do you have anything to add to that? Dr. Del
I
Rivero?
have not had one. So it's all...
Great. Okay. Dr. Del Rivero, if someone has symptoms of MEN1, genetics are negative, and hyperparathyroid adenoma is still not removed, should they only remove the adenoma or 3.5 glands?
That's a great question. And usually the recommendations is for a patient with MEN1 and primary hyperpara is to do 3.5 parathyroidectomy. And that's the indications and the recommendations because there is hyperplasia of the four parathyroid glands. So each one of us has 4. So there is hyperplasia of the 4 of them. And also the MEN1 gene is in every cell in your body. Even though they may say, well, we only see a 1, the other ones we don't see it, it's going to be there. And eventually you're going to have more adenomas causing primary hyperpara. So the recommendation is to do 3.5 parathyroidectomy when that happens.
Great, thanks. Dr. Lee, I know you also see lung nets. There's a question that came in about why experts don't talk about arterial blood gases for lung nets, and would these tests reveal any information? Why they're not part of the regular workup?
So unless you would only get arterial blood gas, and this is not again specific for neuroendocrine tumors, but for any patient seeking medical care, is if the oxygen saturation is really, really low, that's the only time you would potentially get arterial blood gas. To be able to get arterial blood gas, you're essentially putting a needle in terms of your artery in the wrist and everything, and that causes a lot of pain. I can tell you that. So I don't think you want to routinely be getting that because that's not going to provide you any additional information unless you're really critically sick and everything, and it's just going to cause you a lot of pain.
Yes.
Great. And another question about symptoms, Dr. Del Rivero, is example photos of jaundice and flushing tend to be of white or light-colored, light-skinned people. And is this often missed as a symptom in dark-skinned people of color, jaundice and flushing?
Jaundice and flushing. Jaundice is usually kind of like a yellowish discoloration. Even in patients that have really dark skin that we cannot see it, we can still see it on the eyes. We can still see it under the mucosas, like under the eyelids. And so we can still see it. It's a very classic, jaundice, signs that we can also see it on the eyes, even if somebody has very dark skin that we cannot see it. Now, in terms of flushings with somebody that have dark skin, it's a little bit harder to see visually. However, flushing also comes with symptoms, right? It's not just the flushing that you see it. They also feel like these warm feelings, the palpitations, the anxiety. It's a whole syndrome that comes with the flushing as well. That I feel like even you're unable to see it, we still ask the same questions, and we kind of assume, even though we don't see it visually, that these patients may have flushing just the way the patients feel.
Great. Dr. Kataya, do you have anything else to add? Dr. Lee?
No, I mean, I think what she summed it up pretty well.
Okay, great. And there's another question for you, Dr. Del Rivero. With the NIH Natural History Study, are you studying those who had their tumors surgically removed and currently have no evidence of disease?
We're actually following both patients that has history of neuroendocrine tumors, because one thing that we wanted to understand is because it's a longitudinal study, we study patients for long periods of time. We also wanted to understand once a tumor is resected, how, what is the likelihood that it may appear later on, what is the timeline? And so those are the things that we're also trying to study. But we also see the more advanced disease and patients that had received or they have resistance to other therapies. We're studying all neuroendocrine tumors. So this is a study that includes all neuroendocrine tumors, no matter what the stage are.
All right, great. Dr. Lee, we kind of talked about PRT and follow-up scans and treatments. There was a follow-up question for a patient who had PRT and say completed in June of this year, hasn't had scans since their pre-PRT gallium in December 2019, scheduled for a follow-up gallium in December 2020. Should they have a CT or MRI? Because you kind of mentioned both. So the question is really about whether a CT or MRI with follow-up imaging post-PRT.
I think it just really depends on, what imaging that you got at baseline and throughout the course, because, comparing MRIs to CTs is essentially comparing, apples to oranges and everything. So you want to be able to have a direct comparison. So whatever anatomic imaging that you have had most recently, during that treatment with PRT, that's what you want to be able to match up on, or else you're not going to be able to read too much on at least this set of scans that you get. So maybe even this set of scans might be your new baseline scan to assess and on which to compare moving forward.
Okay, great. There's one person who asked the question, this is our second to last question, why can't a pancreatic NETs be removed with surgery? So Dr. Kotaya, what are reasons that PNETs cannot be removed with surgery?
So it's more of a surgeon question, but usually the reason why you wouldn't be able to remove any kind of pancreatic tumor, not just a PNET tumor, is if it's wrapping around major blood vessels, and they can't sort of free it up, or if it's metastasized and there's too much of a liver burden to debulk, or the surgeons feel like they can't meaningfully remove most of your disease. I mean, and again, that's a controversial thing because not everybody believes in liver debulking. I think the neuroendocrine surgeons definitely believe in it, but not all institutions believe in doing debulking. But just to sort of focus mainly on the pancreas, it would be mainly because it's sitting in a location where the vessels can't be reconstructed, or the vessels are going to be compromised. I don't know what my colleagues will say, but that's usually.
Thank you. Can I comment on that, just because that's kind of like one of the things that every Thursday we have our tumor board, and we have all these, we have the endocrine surgeons and we have the hepatobiliary pancreas surgeon as well in this meeting discussing the cases, and it's always indication when to do surgery, and also and whether it's multiple or solitary. So it's also about depending on size as well. If the neuroendocrine tumors, a pancreas neuroendocrine tumors, is less than 2 centimeters in size, and they already underwent an endoscopy and it's well differentiated neuroendocrine tumors, maybe you want to watch it now, because the likelihood that this is going to grow rapidly is very low. So you may want to watch if it's less than 2 centimeters in size. Once it reaches 2 centimeters in size, so the indication is to do surgery. But now the question is, like, a lot of our patients, MEN1 patients, they have multiple pancreatic neuroendocrine tumors. They may only have one, they have multiple. And what are the risks of benefits of doing such an extensive surgery, of having multiple, pancreatic neuroendocrine tumors? And those are the things like, well, we can watch it because they say, depending on what is the age of the patient, what is the longevity, what is the comorbidities, all of the things we keep in mind to really determine which patients, you kind of like weigh the risk of the benefits of doing such an extensive surgeries when you're about to do Whipple's procedures, when you're about to do this extensive surgery. So I think those are the things that we need to keep in mind. That's why, as Dr. Kotaya said earlier, this is kind of like a multidisciplinary treating neuroendocrine tumors. It has to be discussed in a multidisciplinary team with surgeries, radiation oncology, and so forth, because that way we can definitely have all the information and have a better understanding how we can approach these patients. But it's also size is important to know. Sometimes we just watch it, and if greater than 2 centimeters, then we can say, okay, we can do surgery because the likelihood that can go to other places is higher. And then, and the question is there are multiples that we see in MEN1 or VHL? What do we do in those situations? And that's kind of like the risk of benefit. And there is a study, I think Dr. Lee and Dr. Kotaya know about using an embryotype. Could that stop the growth? And so sometimes we just use embryotype in those patients, so that way we can slow down the growth of these tumors, just because maybe for that time surgery may not be indicated for those patients. Yeah.
Good point.
Do you have anything else to add? that one?
Oh, I agree. Depends on size, and then obviously extensiveness of the surgery. Because if you're doing a large Whipple, then potentially you're putting someone as a diabetic, for the rest of their life. So that's something that you have to consider. Generally, for us, yes, 1 centimeter or less, definitely don't do anything. Over 2 centimeters, probably have to have a discussion on risks and benefits of surgical resection. And then 1 to 2 centimeters, that's a controversial area. So you can read about our thoughts based off of our review that we published recently. So with JCO, so it's a very controversial area. So
right.
But I had a patient who had like a pancreatic neuroendocrine tumor that was the same size for like 12 years. I mean, so I think what Dr. Delver is saying is also true, that you can monitor some of these patients. Some of them might never ever need surgery, and that's the thing that's challenging about neuroendocrine tumors. I mean, they say that the risk of lymph node metastases is lower if your tumor is less than 2 centimeters, and I guess there's some controversy Dr. Lee is alluding to. But like you don't always, you're right, you don't always have to rush into surgery.
Well, we'll just take this last question. And I think that, as you're all aware, right, this has been a really hard year for everyone. And then today we're especially recognizing the NET community. And thank you, all three of you, for celebrating with us today to help increase education and awareness. So in honor of NET Cancer Day, what would be the biggest takeaway you'd like to share with those of us affected by NETs, patients, caregivers, those in the community? So Dr. Lee, we'll start with you.
So I think with NET Cancer Day, it's really about awareness, raising more awareness for neuroendocrine cancers, and I think we've come a long way as a community in terms of raising that awareness. I think we do have to take it a step further. So it's not only necessarily raising awareness, but as I mentioned before, we have a lot of these potential innovative therapies that are going on that we're trying to bring to our neuroendocrine patients and improve their lives. But at the same time, like you mentioned, it is somewhat of a difficult year, and for our community, we are still somewhat limited based off of the resources. So I think what I want to encourage all NET patients is not only to raise awareness in terms of the diagnosis, but take it to the next step. Be able to advocate, not only for yourself in terms of your care on a daily basis, but now start to think about how you're going to advocate in terms of the future development of treatments that can potentially impact your life. So what does that mean? There's been a lot of clinical trials that have been designed, but they might have been designed without necessarily your full input. And particularly on this day, where we have come to recognize that every single vote counts in this country, what I want you to do is potentially to go out there and say, talk to the investigators that are investigating in the research and say, why did you not build this into your trial? Because what we've struggled with in neuroendocrine tumor research is that we have all these trials open, but a lot of the trials actually don't go to completion. And part of the reasons why is because they didn't take the input, right? One of the reasons why, let's say, the cabozantinib trial is struggling, it's a great trial, but could they have done something with patients and patients could have voiced them to them from the very beginning and said, you need to have a crossover arm no matter what, or else we're not going to go on the trial and everything. That could have solved things a lot from the very beginning, rather than potentially putting this trial on jeopardy that possibly could, really have a positive impact on patients' lives. So take that step further and say that your voice really does count. And we've been able to see that today. And talk to the investigators, talk to your community, and say, we're going to dictate how we're going to be able to change our lives one step further.
That's really well said. And thank you for, really encouraging us to have a voice. I know, Dr. Lee, you've always been like that with myself, Giovanna, with the LACNETS community. Thank you for that. Dr. Kutaya, what would you say?
I mean, I want to say that one of the things that I really enjoy about neuroendocrine community in general is the fact that there is a lot of collaboration with the patients and a lot of discussions where the patients are involved and they're supporting each other and supporting us. And that's kind of unique to neuroendocrine tumors, as opposed to other cancers, apart maybe from breast, where there's a lot of support groups. And I think it's great to continue to build patient centers and patient support groups, because we need more of them. I've been trying to build one in Baltimore for the longest time, and they haven't launched away from my hospital, but it makes an amazing difference when you have, and yes, it is still a rare cancer, to have other people who've gone through it and gone through the journey can help you, because that's a life-changing thing, a game changer is what I was going to say, that to be able to reach out to the people who've gone through it and feel like you're not lost. And the other thing I want to say is, not to lose the forest for the trees, we as physicians, we're focused on, treatment, moving treatment forward, moving neuroendocrine care forward, just like you are as patients. But don't forget to live your life. I mean, it's good to have knowledge. It's good to be aware. It's good to be informed always. And I think that we, as a younger generation of physicians, we want to be in discussions and help make decisions together versus trying to tell you what to do. Because like Dr. Lee was saying, your input matters a lot into how we move forward. But, like with all things in life, whether you have a metastatic neuroendocrine tumor or a breast cancer or lung cancer, I can't imagine living with metastatic cancer is a whole different ballgame. And I think it takes a lot of courage to sort of push aside your worry and live your life and make sure that you're maximizing your quality of life and make sure that you're not forgetting to enjoy the things around you. And I think when being an oncologist and watching people through their journey, it's taught me to appreciate my life and my health and the fact that none of those things are guaranteed. So, and it's great that if you have caregivers, because, having a caregiver is very, very, uplifting for a lot of patients, because it makes them feel that there's somebody in their corner, just like their doctors are in their corner, the support groups are in your corner. But, I really just, want to make sure that we don't stray away from, yes, there's treatments, there's things, there's decisions to be made. And that's always going to be a time point where you're going to have to make a decision. But don't forget in the middle to push it in the background and don't let the cancer take over. You're in charge. Your life is up front and center, and the cancer can walk behind you. And then when you have to bring it out and deal with it, you deal with it then. That's the main thing I want to sort of say to the neuroendocrine patients.
Thank you for saying that. That's really well said. So instead of just focusing on how long we live and how to extend that, how really to shift that focus to how well we live. And thank you for caring about that. Dr. Del Rivero, what would you have to say?
Oh, wow. So I have to say it's very difficult to, after Dr. Lee and Dr. Kataya, is so difficult to top everything that you guys say, because I do agree with you. And that's very inspirational what you both say and very true. But something that I wanted to say to patients and the NET community is that we understand your hurdles. We do understand. We understand the difficulties that you're going through. That we understand that sometimes you need to travel long distances to see somebody who has this NET expertise. You feel isolated, you feel alone, and we understand your struggles. And that's something that us as a NET community, we're trying to, help you with that. And I think that organizations or support groups just at the LACNETS, and I have to say, Lisa, you've been doing a wonderful job bringing us together. I think that you're bringing everybody together, and I know that you're also following the dream that Giovanni had. So I think that's something that we wanted to continue her dreams and continue what she wanted to do in her life. She wanted to advocate for each one of you. She wanted you to fight for this disease. She wanted you to stick together and move forward together. And I think that the NET community, you're doing an amazing job, and that's something that I think the patients needs to be aware of, that they're not alone. We are together in this journey. We are together with your journey as well. And we are going to fight with you no matter what they are. We are going to fight with you all the way, and we're going to be with you all the way. And that's important. And that's why being together with you and Dr. Lee and Dr. Kataya, that also tells me we are such a close community that we care so much about each one of you. And that thing that's very important. And I just wanted to say that, it's something that I have said in my talk as well, and that's
something when I met Giovanna, because I happened to meet Giovanna in Barcelona at the LACNETS meeting, and we have this cooking class together, and I was actually next to her the whole time, and I took a picture of her, cooking the paella. That, she was such a giving person. All she was doing is because of all of the people that were living with NETs. It was just amazing. And I actually, that was a time when I came with a quote that whatever you do for you, that stays with you and dies with you. Whatever you do for others and the world will always be immortal. And that's why Giovanna is going to be immortal all around us, because that's what you wanted to do. And with that, I have to say that, again, you're not alone in this. We're fighting with you, and we are in your voice count. And I completely agree with Dr. Lee, your voice count. For any clinical trial designs, for anything that we are doing in advancement, your voice count. And you need to speak out, because we are the ones that we need to listen to you in order to move forward. And without you, we cannot advance. So we need you. We are in all of this together, is all I want to say.
Amen. And I loved the quote that you ended with, the end of your presentation. Individually, we're one drop. Together, we're an ocean. We feel, I want to say on behalf of the NET community, we feel all your care and support, all of you, Dr. Lee, Dr. Cotaya, Dr. Del Rivera. One way is, right, the time you took on the presentations today, the time you took 2 hours with us on the Q&A to answer everyone's questions today, very thorough response. All the work you're doing behind this, both clinically and behind the scenes of clinical trials, all the research presentations, all of this that you do, so that we feel that, not just that we're not alone, but we have a team fighting for us, supporting us. So on behalf of the NET community, LACNETS, and all of us in the community, patients, caregivers, everyone alike, thank you, Dr. Lee, Dr. Cotaya, Dr. De Rivera, for taking this time to celebrate NET Cancer Day with us. And with that, this concludes our Q&A session. Thank you very much.
Thank you.
Thank you. Thank you so much.
Thank you. Thanks, Lisa.
Thank you. Bye.
Join us for the 2 remaining educational programs in 2020, including on November 17th on high-grade neuroendocrine neoplasms, and on December 8th with Michael Echelon from the Simsmans UCLA Center for Integrative Oncology. Check out our website for our other programs as well, including our virtual support groups, including our NET patient support group, our caregiver support group, NET Vitals, and health coaching, as well as much, much more. And I'll let you take it away, Lindsay.
Again, as a reminder, patient advocacy groups are an important source of NET news and resources, so we encourage you to sign up for our newsletter on our website and follow us on our social media pages. You can find us on Facebook, Instagram, Twitter, and YouTube. Speaking of YouTube, today's live symposium is being recorded and will be up for your viewing pleasure on the LACNETS YouTube channel in just a few days. We will also be sending out a post-symposium survey shortly. We would greatly appreciate if you took a few minutes to share your honest feedback with us. And before we say goodbye, we would like to thank our sponsors, Ipsen, Sun Pharma, AAA, and Tercera. And again, thank you to Rich at TVP Live for making today's live broadcast possible. Thank you for tuning in, everyone. Have a wonderful rest of your weekend. We hope to see you again soon. Goodbye.